or at 5 years if you want to save one limb or so probably it's a miracle drug because if you can afford it, that itself is a miracle. Now next we come to an important area of statin intolerance. This is a very important concept and we have to distinguish between true intolerance and pseudo intolerance. Especially in our Kerala population where people are hyper aware with Google and all sorts of health magazines and everything. I think more people are aware of the side effects than the good effects of many of these drugs. I think the only thing without side effect what I tell my patients is probably pachavallam, but even that is questionable these days. So there is something called a nocebo effect. That is a harmless thing is thought to cause harm because we believe that it is harmful. So as our knowledge of the statins adverse effects increases, naturally our recognition of these symptoms or probably perception of these symptoms will also increase. And mostly, like in the Cox postulate, probably a susceptible host has also need to be involved. So when somebody develops a true statin intolerance, either in the form of muscle symptom or a hepatic dysfunction or probably non-specific, so many symptoms are there. There are three basic strategies that are recommended. One is dose modification. Somebody is on 40, we try 20. Next thing is alternate statin. We need, somebody is on 40 milligram atorvastatin and that patient tells us that, doctor, this is high dose, what to do? So probably we can change it to rosuvastatin 20 milligram. So it gives the same effect and the patient feels that the dose has been reduced. The third option is a non-statin therapy, which is our focus because we have new alternatives that are available. So in this is the newest molecule, the Bembroic Acid, which has been approved by FDA, the US FDA. So it also acts in the liver. It inhibits hepatic cholesterol synthesis upstream of the statin, that is above the HMG-CoA reductase step. So this acts at the ATP citrate layers. Biochemistry exam in the pathway. So always we forget that. So it is very important clinically now. So the dose is 180 milligram once daily and it is an oral prodrug and it has to be converted to an active form by an enzyme. Thankfully, this enzyme is present only in the liver. It's not present in the muscle. So the action is supposed to be specific to liver and so that is why it is said that the muscle symptoms are low. And on an average, it brings down the LDL by around 20%. So it upregulates the LDL receptors and lowers the LDL cholesterol. The clear trials are the major trials of Bembroic acid and along with statin, they bring about 15%. If it is without statin, the percentage reduction is 25%. Along with ezetimibe, it brings down the LDL by 35%. So the US FDA said that Bembroic acid and a combination of ezetimibe plus Bembroic acid that is approved now in US, not yet come to India. So it is useful as an adjunct to diet and maximally tolerated statin therapy for patients with heterozygous familial hypercholesterolemia or in those with established CVD who require additional LDL lowering. One important side effect that has been noted in some studies for 0.5% is a tendon rupture or injury, which is seen to be more, involving rotator cuff, biceps tendon, Achilles tendon, and happen within weeks to months. Elderly patients, those on steroids, fluoroquinolones, patients with renal dysfunction and previous tendon musculoskeletal disorders are at higher risk and probably these people with these disorders we can avoid using this. No renal or hepatic dose adjustment is required, but it is not tried in child C cirrhosis. And importantly, we should not use simvastatin at a dose of more than 20 and pravastatin at dose more than 40 along with this molecule. And very, very importantly, just like statins, these drugs are contraindicated during pregnancy and lactation. So if you are prescribing to a young female, the drug has to be stopped at least 3 months prior to planning pregnancy, not after the pregnancy is confirmed. And we talked about muscle, but some patients we see have increased liver enzymes after starting statin. So because this also acts in the liver, does it increase the SGOT, SGPT levels? In the current studies, it has not been found to be a problem. In fact, it has also been found to improve the SGOT, PT values in patients with NASH, especially in animal studies. So, everything has a place and a purpose, and this is the National Lipid Association recommendations on the use of Bembroic acid. It is effective and well tolerated as both an add-on therapy for statin tolerant patients with very high risk ASCVD or patients with statin intolerance. But whether this will definitely reduce the LDL, but will it bring down the event rate just like statin? We need longer trials. So someone in the audience, my friend was asking me, sir, have you started using this? I said, in my vast clinical experience of one patient, I found this much of LDL reduction. Just joking. So this has come with a big bang. the main indication is when you don't achieve the target LDL or if patient is not tolerating statin. So just because this molecule has come, we should not stop all statins and start adding bembroic acid. We should choose the correct patient. So now coming to the triglyceride, which is again a controversy. We know about the non-prescription fish oil preparations, but the only triglyceride risk-based non-statin treatment approved. Good morning, sir. Approved by the US FDA for reducing the ASCVD risk is icosapentethyl, which is not yet available in India. Otherwise, we would know. So if you look at the triglycerides, if you look at patients above the age of 40 years, if the ASCVD risk calculation brings their score above 7.5%, and if they have a moderate elevation of triglyceride, that is 175 to 499, statins are still the first line therapy. We should not go straight away into fenofibrate as is commonly done. And if there is severe increase, that is more than 500 or more than 1000, we start considering the other molecules, especially the fibrates. And if we are using fibrates, fenofibrate is preferred over gemfibrozil. So essentially up to 500 statins should be the first line. And if it is more than 150, less than 500, consider statin or at the most icosapentethyl, which is not available here. And more than 500 to 1000, consider fibrate, because we are bothered not only about CVD but also about the risk of pancreatitis, and fenofibrate is preferred. There are many emerging treatments, just the names for our postgraduates, pemafibrate, evenacumab, alipogene, etc. And lomitapide, another non-statin drug which brings down LDL. It's an oral MTP inhibitor. It's also approved by US FDA, just the name. And mipomersen, that's an oligonucleotide antisense, and it is given as subcutaneous injection. Then we have Ldl Efferences, especially for selective elimination of atherogenic lipoproteins, especially in patients with severe forms of familial hyperlipidemia. It is done once weekly, and it should be started very early because it happens in young people, and it can be safely continued during pregnancy. This is data from India. And one thing is, when somebody is on Ldl Efferences, it is being done in some in Kerala also, and ACE inhibitors are contraindicated along with Ldl Efferences because there is a risk of allergic reaction and hypotension. We always talk about the heart and the brain when it comes to stroke and CAD when we talk about cholesterol, but ultimately liver is the most important organ in the cholesterol homeostasis, and people have even started trying liver transplantation because the LDL receptor problem may be at the core of the issue. Now, finally, as in all diseases, genetic treatment is also coming up. In fact, President Ramesh sir actually sent me one of the articles yesterday. That's how keen he was on the topic on genetic modification by gene replacement using viral vectors. Now, inclisiran, this might come soon because it has already been started to use in US. So it is a small interfering RNA, because previously these drugs were all short notes for our exam, but now an era has come where all the short notes are available for us to use. So this is inclisiran, small interfering RNA. It is also given as a subcutaneous injection every 6 months. So finally a time will come when, like an annual influenza shot, you get a shot for dyslipidemia, and it brings 50% LDL reduction. So we have covered statin as the major first line agent, ezetimibe 10 milligram added, evolocumab 140 milligram subcutaneously every 2 weeks, bembroic acid 180 milligram once daily. For hypertriglyceridemia, still up to 500 statin as a first line, inclisiran, newer drugs, Ldl Efferences. And finally, these numbers we should please remember, that is high risk is less than 70, very high risk less than 55, recurrent events it should be less than 40. And intensity, if you use all three together, it is 85%. If you use statin plus ezetimibe, it is 65%. But we'll end with a perspective because we know that guideline publication does not guarantee guideline implementation. Even people like us who read these guidelines, we sometimes have doubts. And there is drastic underutilization and flaws in trial design, marketing, and drug pricing of many of these drugs because they are not accessible to most of our patients. Next question is how long to give, because we start these drugs, the cholesterol comes down. The first question the patient asks on follow-up is, Doctor, and when exactly to strike? Do we start using these molecules early to bring down the LDL right from an early age, or do we wait for events to happen and then say, okay, there are so many events, so we'll start this? So the exact time, the science is yet not clear. And this is a general tendency. All human physiological variables like glucose, cholesterol, blood pressure, maybe glucose was spared, thankfully. Sir will know. And so how low to go with these values, that this is a trend. And every year, our cholesterol may remain the same, but the guidelines may change. So the problem is when a patient comes for follow-up 1 year after angioplasty, the patient is coming, okay, now the doctor will reduce some drugs. Then we'll tell that your LDL is now 70. It is good, you are taking atorvastatin 40 milligram. But last week a new guideline has come, it needs to be below 55, so we'll add bembroic acid. So we'll have a lot of unhappy patients also. We have to think about this. And we also have skepticism whether we are using a too aggressive approach in bringing down these LDL cholesterol. What could be treated with a bullet, we are treating with the bazooka. But even our, the big B of cardiology, Dr. Eugene Broadwood himself mentioned that the race to the bottom is an exhilarating experience. And he wrote an editorial that people will start living for around 100 years. After using inclisiran and PCSK9 inhibitors. Hopefully we don't have dementia at that time. So ultimately I think we go through all these guidelines, people sitting, including me. When we have this disease, we will think twice or thrice before starting medications. In our OP, when we sit, we see a value, we see a patient. It is very easy for us. It happens sometimes at even spinal level, not cerebral level. The prescription comes. But when it happens to us, to our wife, to our kids, to our parents, we think twice. We ask for 3 opinions and then only start these molecules. So I think the ultimate question is how would you treat yourself? And probably like the Buddhist philosophy or the Rumi philosophy and even the ancient Romans had this middle pathway. And the Hutcheson's prayer of too much zeal for the new and contempt for what is old. I think the good Lord deliver us, and still we have to pay our tribute to this gentleman, Dr. Akira Endo, who introduced statin and still continues to be the first line agent. But of course, we have niche areas where the second line agents are extremely useful. Last week, there was a priest, a 34-year-old priest from Ireland, who had an MI, 2 stents implanted at Ireland. He was on atorvastatin 80 milligram. And he had come for a vacation and he came to see me and he said that, doctor, I am very tired. I have a lot of muscle symptoms. So we did all the routine evaluation, CPK levels, everything is normal. So statin associated muscle symptom by definition means that the serum CPK level will be normal. So you won't have any objective evidence. So the patient was very keen to bring down the dose of, but when I took the history, it was very clear that the symptoms were not related to statin. It was a generalized symptom. And we did a CPK, it told him that it is normal, there is no muscle damage. He was very convinced. And then I gave the option of, do you want to really change the drug? Then he said, doctor, which is the best medicine? Then I will continue that. Now I am convinced, so I want to continue statin alone. So, but there was another patient, a lady who came with a past history of severe hepatic dysfunction following 10 milligram of atorvastatin. She had dyslipidemia. She has family history of CAD, probably a heterozygous familial hypercholesterolemia. So she needs drug to bring down the LDL. But when she was given 10 milligram atorvastatin, the SGOT-PT went up to 800, 900. She developed severe symptoms. She had to be admitted in Kochi. So now she is very afraid to start. So in such a patient, I think it is not a good option to restart it. So this patient, I started on ezetimibe and the LDL came down. Bembroic acid again acts on the liver. So muscle symptoms, definitely bembroic acid is better, but for liver dysfunction, we have to see. Thank you so much. Thank you very much for the invitation. And I didn't think that there would be so many people at 9 a.m. It shows the enthusiasm. Thank you so much. Yeah.
Thank you, Dr. Sajan, for that excellent presentation with lots of experiences incorporated, and more so in a very humorous manner. You have included even that component of medical education called as cinema education. Cinema education is now catching up, you know. You can use cinema clips to convey the messages much better. Now, this is an area of controversy. Of course, all of us know that even in spite of so many Nobel Prizes and other guidelines being revised every now and then, still when a patient comes to you, still you have to think 100 times before you actually give the final conclusion, especially in the area of so much of Google medicine being practiced. And every time you prescribe any new combination, they are always coming up with a lot of questions and other confusions. And I'm sure his presentation would have clarified many of those issues, including even the hypertriglyceridemia and other issues that we very commonly see in our population. I think we have some time left because he has finished before time. So we have enough time to ask a few questions.
Sir.
Sir, Mike, please.
You had 41 post-ACS patients on PCSK inhibitor. How many of them are continuing it now?
Honest answer is 0%, sir. 0%, because that is why this we have tried it in the immediate post ACS period. We have follow up only up to 3 months. We have not followed up because most patients cannot afford.
Thank you, Surgeon, for the wonderful talk. I have one Surgeon.
Yes.
Thank you for the wonderful talk.
Thank
In one
you.
of the slides, you show that bempedoic acid alone, statin. Sorry.
The percentage you are asking?
Yeah.
Okay, good question, very good question. I
Thank
was
you.
thinking whether the percentage reduction actually will be less if you use it along with statin. That is the additional percentage reduction. If somebody is not on statin, the percentage reduction will be more because the baseline LDL, the percentage reduction depends upon the baseline LDL.
Statin to bempedoic acid would result in less.
No, not that.
Oh,
From the baseline, how much percentage it is reduced. So
Oh.
somebody is on statin, already it is at a low level.
Yeah.
From there, further reduction. So as the cholesterol level comes down, the percentage reduction again will be lower. That's all.
Thank you.
Sir. Up to 500, sir.
Yeah, up to 500. What
Yes.
is the mechanism action? Where does it act?
It acts on the HMG-CoA reductase only, sir. It
But
also brings down the triglyceride, but only by up to.
No, the structure of cholesterol is different.
Yes, sir.
But the triglyceride is glycerol plus fatty acid.
Acylglycerols with a backbone. Yeah.
Then how does it act there?
Sir, statins also reduce the triglyceride level by up to 10 to 15%.
That I agree. What is the mechanism? Just where is it acting? Because you said the sequential action on the cholesterol
Only
part,
the- yeah.
newer drug is working.
Right.
But where is it acting?
I don't know, sir.
Yeah, sir, I didn't know.
Yeah.
If you see about, very good lecture, very nice.
Thank you, sir.
So, if you see 100 cases of coronary artery disease, how many are not related to cholesterol, lipids?
Yes.
For example, family history. And what is the usual practice in 100 cases?
Yeah.
How many of them are not related to cholesterol? They may have a normal cholesterol.
Correct, sir. Correct. This is a question that most people ask because when they come with MI, they will tell my sugar is normal, my BP is normal, my cholesterol is normal, but still, why did I have MI? We have to be humble enough to understand that we don't really know what is happening in our human body because it is a vast area. So science still has to evolve. We don't have questions for. We read about percentage reductions. If you use this drug, it will bring down by risk by 25%. Add one more drug, it additional 35%. Finally, when you add this, as a MBBS student, I used to wonder. So finally, if you add all these things, there is nothing. So the Interheart study, in the Interheart study, which was the landmark study, 90% of patients had one of the conventional risk factors. So which means that if you target the conventional risk factors, we can address 90% of MI, but 10% we don't have an answer.
No, as a-
Family history is extremely important. Like sir has said, I think it's very under-recognized, and it should be just like we say diabetes, hypertension, dyslipidemia. We should say family history because it is extreme. We rarely find somebody with a young MI without a family history.
As a corollary to that, Doctor, 1 second. As a corollary to that, how many of these studies have actually looked at the patient outcome rather than reduction in the quantitative levels of cholesterol?
There is enough data, sir. Long-term follow-up data is available so we need not go into that. If you want to believe evidence, there is evidence to suggest that low LDL brings down the event rate. But we, like everything else, we are very selective in choosing our evidence.
Okay. Dr. Vijayamar?
No, sir. We routinely do not check, and we use it only in patients with very young MI who come with young patients with MI. Recently, after COVID, we had a lot of young patients with MI who had all values normal, but only thrombus. In most of these patients on angiogram, there was no atherosclerosis following COVID. It was mostly only thrombus. So,
Hyperhomocysteine is.
yes, that's also a risk factor. But studies till now have not shown if you bring down the homocysteine, will it lead to a reduction in MI? That we don't have evidence.
So bempedoic acid is one thing which.
Sir, I will look up on that matter. Extremely important question. Yeah.
Bempedoic acid is one thing which you told it's sparing the muscles so that it doesn't produce those side effects of statins.
That is the proposed mechanism.
But in the side effects,
yeah,
how come tendon rupture happens if it's
there is no. I have searched because no, even before this talk, because when the molecule came, I searched extensively mechanisms. There is nothing. There is no data, and there has also been slight increase in the uric acid level and a minimal increase in the creatinine level of 0.2 milligram per day that has been noted. And for that also there is no mechanism has been given.
And another thing is that we usually advise them to do regular physical exercise also.
Yes,
and if
definitely.
it is something which is going to produce a tendon rupture, maybe
Good
by
point.
doing
Good point.
that again, it's going
Good
to be.
point. Vigorous exercise anyway, we don't recommend for cardiac. We usually recommend isotonic exercise.
One patient has CPK after angiogram. CPK is 2000 since many months. How will you manage in that case?
Sir, CPK, total CPK.
No.
Immediately after MI or?
No,
Because normally CPK will increase after MI also.
For checkup, he did an angiogram.
Yeah.
Since many months, CPK is nearly 2000.
Okay. So which means probably there is a muscle. So many patients with this kind of very high values of CPK, it may not always be related to statin alone. They may have underlying muscle disorders. So we usually refer them to neurologists for evaluation and a biopsy if possible.
Can we use ezetimibe?
We can use ezetimibe. I will prefer ezetimibe or PCSK9 inhibitor in this setting rather than bembroic acid because we don't have much data. So ezetimibe we can definitely use. If possible, we can use PCSK9 inhibitor.
What about bembroic acid?
Bembroic acid we can use, sir. We can use. But ezetimibe is the first line.
What is the trade name? Is it available here?
Bembroic acid. So there are a lot of molecules that are available. It is available as 180 milligram once daily.
So after an event, of course, we all use like cerebrovascular or cardiovascular events, and even the patients who are very much prone, like diabetic, hypertensive patients with the borderline dyslipidemia, anticipating a problems we start. But there are majority of patients who have no comorbid diseases at all.
Correct.
But with the cholesterol going to 250, LDL going 160, you have no other problem.
Yeah.
Many of them are youngsters. And what do you recommend in such people who don't have any other comorbidity?
Understood,
Cholesterol
sir.
is high.
Understood, sir. Sir, when we have diabetes, we take it very seriously. When we have hypertension, we take it very seriously. Then why not take dyslipidemia seriously? Don't think that I have no other. If I have diabetes, I will treat diabetes. I will not think I will not have any other disease, so I will not treat diabetes. I think familial hypercholesterolemia is probably the most common genetic syndrome worldwide. If you take heterozygous and homozygous we don't see much. But many of us sitting here will be having heterozygous familial. So last week I saw a family of 3 women, I think 33, 38, 44. One patient came, bystander had Sandal asthma. We checked all the family members, extremely high. All cholesterol levels total were 300, 380, 400, LDL levels 250. So LDL more than 190 is a clue that this patient may be suffering from heterozygous familial hypercholesterolemia. And since we are not routinely doing a genetic testing, definitely these patients, as per the guideline also, we have to start on statin.
Dr. Sajan,
but not in the first visit. We can try lifestyle modification, exercise, weight reduction, and then after that.
It is said that it increases the all-cause mortality. The all-cause mortality in these
on statin.
Yeah, of course, with statin, if you do over reduction, it
Sorry, sir, I'm
increases
not aware of that.
all-cause mortality, though it reduces the cardiovascular events in patients who are not without any comorbidities.
I'm sorry, sir. I have not read like that, and we will verify that statement. Yeah, sure.
Dr. Sajan,
so what you are saying is that somebody for primary prevention, somebody has significant dyslipidemia. If you start statin, they will have all-cause mortality increase.
Higher than.
Not sure. I think we'll open a Pandora's box of more controversies. Yeah.
Dr. Sajan, there is most of the patients who are coming with the LDL elevation. Once you reduce the LDL to a level, they will ask why my HDL is not going up. So, are you giving much importance for that?
No,
and
sir.
second question is, how will you decide the dosage of statins depending upon the risk factors?
Very good questions. First part, naturally, when the total cholesterol content itself comes down, the HDL level will also be low. And frankly, there are no good drugs available to increase the level of HDL. The only proven way is exercise. That is the best way to increase the HDL level. So that is one. Second, so even though we want to increase the HDL, there are no good drugs available. So exercise is the best. The second question sir was asking was about the dose. So we always have this fixed combination, 40, 80. We don't have 60. So somebody who is on 80, somebody has an MI, start on 80, 1 month later comes for follow-up, LDL level is 40, okay. So now you think, okay, now we can reduce it, because now it is anyway below 40. So there is no 60 available, so we have to go down to 40. So just like that rosuvastatin, from 40 we usually go down to 20. And only some brands, I think 1 or 2 brands have 30 milligram rosuvastatin, which can be useful in those situations. Some situations we will take one 20 milligram tablet and one 10 milligram tablet. So one size does not fit all, just like anything. So for BP, we use different drugs, different combinations, different doses for each particular patient. So we don't have to go by a blind value. So whatever is the level, if the patient is having a standard high risk patient, it is less than 70. Whatever dose of the statin is good enough to bring down to that particular level, we can use. It is not that we should use this at this dose alone for that patient. We have to individualize the treatment. Yes, sir.
Now they say that there are conditions other than familial hyperlipidemia, there are other hereditary.
Yes.
Do you have any idea? Can we diagnose anyone of them?
So the next generation NGS, the new next gen gene sequencing they have identified lot of disorders that are not related to, because familial hypercholesterolemia classically is the LDL receptor. So there are many other, they account for around 80 to 90% of the genetic abnormality, but there are a lot of other, even chromosomal anomalies have been implicated. So it is an evolving field. NGS may bring about new change. Omega-3 alone may be enough in moderate. Up to 500, it may be useful. We can try it, but may not help.
Thank you. Thank you.
The icosapentaenoic acid formulation, sir. Icosapentaenoic acid formulation.
Thank you.
Yes, sir. Yeah, yes, sir. No, sir. I have not found, and I have discussed with my wife also, who happens to be a neurologist, so she has also not seen any till now. But this particular, there is Ebbinghaus. There is an Ebbinghaus data which specifically looked at this, and they followed up these patients up to, I think, almost 2 years, and correlated the LDL level. They did sequential psychomotor analysis and everything, and it was found that it was not there. Sir, I am not using Saraglitazar much, but I know that there are many people who are using it. It may be a good molecule, especially in a combination of diabetes with dyslipidemia. It may be a good molecule.
Thank you.
Yeah.
Thank you.
Yeah.
That finishes.
Thank you.
So it was an excellent presentation. We'll give a good hand to Sajan.
Thank you, sir.
And thank you for the discussion. This session is finished.
Thank you, sir.
Thank you.
It was like a viva also at the end. I got one question wrong, very important question. I'll try to find out the answer. Thank you, sir.
Thank you so much, sir. This brings the curtain down on our first topic. I invite Dr. Sojan Keskari and Dr. Sajith Kumar, sir, to hand over the memento to Dr. Sajan, sir. Thank you, sir. I invite Dr. Vijay Kumar to please hand over a memento to our chairpersons. Let's please give a big round of applause. Thank you, sir. Ladies and gentlemen, the inauguration ceremony is about to start. I request all of you to please kindly take your seats. This is for the kind attention of all postgraduates. Doctors who are prepared for the poster presentation can upload their posters in the system, which is kept at the Ambassador Hall in the second floor. I repeat, the Ambassador Hall in the second floor. we proudly once again welcome all the members of the audience, delegates, presenters and postgraduate students to the first quarterly meeting of the Association of Physicians of India Kerala chapter. It is an honor for me to introduce and welcome the esteemed guests onto our dais. Advocate Matthew T. Thomas sir, Dr. Ramesh Nair sir, Dr. Sunil Matthew sir, Dr. Neeraj Manikad sir, Dr. Matthew Thomas sir, Dr. C.R. Radhakrishnan sir, and Dr. G.K. Hari sir. Please occupy the dais, sir. Distinguished guests, faculty, and postgraduates. A day without prayer is a day without blessing, and a life without prayer is a life without power. Let us begin our conference in a most auspicious manner by invoking the blessings of the Almighty. I request everyone to kindly rise for the prayer song led by Dr. Shruti and Dr. Judith.
സർവേശ്വരാ നിന്റെ സന്നിധാനത്തിൽ സർവം മറന്നൊന്നു നിൽക്കട്ടെ ഞാൻ നിൻ വരദാനങ്ങൾ പാടിപ്പുകഴ്ത്തുന്ന പുല്ലാങ്കുഴലായി മാറട്ടെ ഞാൻ സർവേശ്വരാ നിന്റെ സന്നിധാനത്തിൽ സർവം മറന്നൊന്നു നിൽക്കട്ടെ ഞാൻ വിശ്വം വിധാനിക്കും മുൻപു ഞാൻ നിന്റെ മനസ്സിൽ ജനിച്ചിരുന്നു വിശ്വം വിധാനിക്കും മുൻപു ഞാൻ നിന്റെ മനസ്സിൽ ജനിച്ചിരുന്നു സമയം വീരിയും മുൻപു ഞാൻ നിന്റെ ഹൃദയത്തിൽ വസിച്ചിരുന്നു സമയം വീരിയും മുൻപു ഞാൻ നിന്റെ ഹൃദയത്തിൽ വസിച്ചിരുന്നു സർവേശ്വരാ നിന്റെ സന്നിധാനത്തിൽ സർവം മറന്നൊന്നു നിൽക്കട്ടെ ഞാൻ നിൻ വരദാനങ്ങൾ പാടിപ്പുകഴ്ത്തുന്ന പുല്ലാങ്കുഴലായി മാറട്ടെ ഞാൻ.
Please be seated. Light fades away the darkness, spreading the Almighty's grace and divine energy. Light symbolizes abundance, prosperity, knowledge, and wisdom. The lighting of the lamp is regarded as a bow down to knowledge. To solemnize this special occasion, I would like to invite the dignitaries on the dais to please come forward and light the lamp and kickstart today's programs. Thank you, respected sirs. To welcome our little gathering, I would like to invite on stage a man who needs no introduction, a teacher beloved by all his students, and a friend to many of us gathered here. Dr. Sunil Matthew, Associate Professor, Department of Internal Medicine, Pushpagiri Medical College, THIRUVALLA, and the organizing chairman of this conference. We invite you on stage, sir, to deliver the welcome address.
Good morning, everybody. Respected President, API Kerala Chapter, Dr. Ramesh Nair, Chief Guest of the Day, Advocate Matthew T. Thomas, Honorable MLA of THIRUVALLA, Patron of API Kerala Chapter, Dr. Matthew Thomas, Secretary of API Kerala Chapter, Dr. Neeraj, President of IMA THIRUVALLA Chapter, Dr. C.R. Radhakrishnan, Organizing Secretary, Dr. Sri Hari. Dear teachers, senior faculty, teachers, and my dear friends. First of all, let me thank the President and the Secretary of the API Kerala Chapter for giving us a chance to arrange the API first quarterly meeting at THIRUVALLA. Our President, Dr. Ramesh Nair, needs no introduction at all, and this is his first meeting after he inducted as the President of the API Kerala Chapter. On behalf of the Central Travancore Physicians Club and API Kerala Chapter, I would welcome you, sir, for this meeting. And we wish you all the best in the coming activities of the API Kerala Chapter. Chief Guest of the Day, Honorable MLA of THIRUVALLA, Advocate Matthew T. Thomas, needs no introduction at all. He was the former Minister of State Transport and Water Resources Department. Without any hesitation, he accepted our invitation in spite of his busy schedule. So on behalf of the club, we welcome you, sir, for this meeting. We are happy to welcome our patron, Dr. Matthew Thomas, for this meeting. We welcome Dr. Radhakrishnan CR, President of IMA THIRUVALLA, for this meeting. We welcome our dynamic secretary, Dr. Neeraj, who has taken the responsibility for arranging the excellent scientific topics and speakers for this conference. On behalf of the CTPC and API Kerala Chapter, I welcome you, sir. Last and the most important personalities who took a lot of pain in arranging this conference, and whatever you have seen here is actually the effort behind, the man behind is Dr. Sri Hari. On behalf of the Central Travancore Physicians Club and API Kerala Chapter, we welcome you, sir, for this meeting. Last and the most important personalities are the delegates. Without the delegates, the meeting is not going to be a successful one. So hope you will enjoy the meeting, and your participation. We welcome you for this meeting. Thank you.
Thank you, sir. A great leader is one who knows the way, goes the way, and shows the way. Without further ado, may I please invite Dr. Ramesh Nair, Senior Consultant Physician at Bharat Hospital, Kottayam, and furthermore, our Honorable President of the Kerala Chapter of API, to deliver the presidential address.
Good morning, everyone. Respected persons on the dais, our Chief Guest Advocate Matthew T. Thomas, our patron Dr. Professor Matthew Thomas, Dr. Sunil, Dr. Neeraj, and Dr. Radhakrishnan. Sunil has mentioned that this is my first meeting and this is my first presidential address. I am thankful to all of you for electing me as the president. You know, general medicine is one department where you should be aware of all the developments in any field, because everyone will first come to a physician and ask what is going on. So it is our duty to get educated, and meetings like this will teach us a long way. I hope at the end of the day, most of you will be knowledgeable from the lessons we are learning from today. I thank all of you for coming from all over the Kerala to attend the meeting, and my special thanks for the speakers and for the chairperson. Thank you.
Thank you, sir, for those enlightening words. It is my privilege to introduce an eminent personality among us. He is an active member of society, striving to make our world a better place. Ladies and gentlemen, please put your hands together and let's give a great round of applause for our Honorable Thomas, sir. I request you, sir, to formally inaugurate the first quarterly meeting of the API Kerala chapter and to declare this conference open.
API Kerala chapter President Dr. Ramesh Nair, Organizing Chairman Dr. Sunil Matthew, API Secretary Dr. Neeraj Manigat, Dr. Matthew Thomas, Dr. C.R. Radhakrishnan, Dr. G.K. Srihari, ഈ സദസ്സിനെ സമ്പന്നമാക്കുന്ന ഡോക്ടർമാരെ, പ്രിയപ്പെട്ട സഹോദരി സഹോദരന്മാരെ, മീറ്റിങ്ങിൻ്റെ ഒരു സ്വഭാവം കണ്ടിട്ട് ഉദ്ഘാടന ചടങ്ങിനേക്കാൾ നമുക്ക് പ്രാധാന്യം ഇതിൻ്റെ 5 സെഷനുകളായി നടക്കുന്ന ക്ലാസ്സുകൾക്കാണ് എന്ന് മനസ്സിലാവുന്നു. അതുകൊണ്ട് ഒരു ദീർഘമായ ഉദ്ഘാടന പ്രസംഗം ആവശ്യമില്ല. എന്തുകൊണ്ടാണ് എന്നെ ഈ യോഗത്തിന് ക്ഷണിച്ചത് എന്ന് ഞാനൊന്ന് ശങ്കിക്കാതിരുന്നില്ല. പിന്നെ മനസ്സിലായത് ഏറ്റവും കൂടുതൽ നമ്മൾ പറയുക സ്റ്റേക്ക് ഹോൾഡേഴ്സിനെ തന്നെ വിളിച്ച് യോഗം നടത്തണമെന്ന് ഉദ്ഘാടനം നടത്തണം തീരുമാനിച്ചതായിരിക്കാം. എൻ്റെ പല ഡോക്ടർമാരും ഇവിടെയുണ്ട്. ഡോക്ടർ രാധാകൃഷ്ണൻ ഓർമ്മയുണ്ടോയെന്നറിയില്ല, പണ്ട് GK ഹോസ്പിറ്റലിൽ ഒരു ഡയബറ്റിക് വാർഡ് ഉദ്ഘാടനം ചെയ്യുന്ന സമയത്ത് ഡോക്ടർ ഉണ്ടായിരുന്നു. അവിടെ GK ഹോസ്പിറ്റലിൽ വർക്ക് ചെയ്തോ? സക്രിയാസ് മാർ തിരുവല്ലോസ് തിരുമേനി പറഞ്ഞു, ഡയബറ്റിക് വാർഡ് ഉദ്ഘാടനം ചെയ്യാൻ ഏറ്റവും യോഗ്യൻ അദ്ദേഹമാണ്. കാരണം 23 വർഷമായി മരുന്ന് കഴിക്കുന്നു, ഇൻസുലിനാണ്. പക്ഷെ അന്ന് അതേ ഹോസ്പിറ്റലിൽ ഒരു സൈക്യാട്രിക് വാർഡ് ഉദ്ഘാടനം ചെയ്യാൻ എന്നെയാണ് ചുമതലപ്പെടുത്തിയത്. അത് പരിഹാസരൂപേണ തിരുമേനി ഞങ്ങളുടെ ഒരു സൗഹൃദത്തിൻ്റെ പേരിൽ പറയുകയും ചെയ്തു. അപ്പം ഞാൻ ആ യോഗത്തിൽ പറഞ്ഞു, ഈ ഡയബറ്റീസ് ഉണ്ട്, ഷുഗർ പ്രഷർ ഉണ്ടെന്നൊക്കെ പറയുന്നത് സ്റ്റാറ്റസ് സിമ്പിളാണ്. ആരെയും ഞാനൊരു സൈക്കാട്രിക് പേഷ്യൻ്റാണെന്ന് പറഞ്ഞു കിട്ടുന്നുണ്ട്. മനുഷ്യനുണ്ടാകുന്ന മറ്റൊരു അസുഖമാണ് സൈക്കാട്രിക് ഡിസീസസ്. പോട്ടെ, ഞാൻ അതിലേക്കല്ല കിടക്കുന്നത്. ഈ മീറ്റിങ്ങിൽ കണ്ട ഒരു താല്പര്യം, API കേരള ചാപ്റ്ററിൻ്റെ ഒരു ഫസ്റ്റ് ക്വാർട്ടർലി മീറ്റിംഗ് ആണല്ലോ. ഞാൻ വന്നു കയറുമ്പോൾ ക്ലാസ്സാണ് നടക്കുന്നത്. ഡോക്ടർ സാജൻ വളരെ സീനിയറായ ഡോക്ടേഴ്സ് പോലും സംശയങ്ങൾ ചോദിക്കുന്നു, ചർച്ച ചെയ്യുന്നു. അപ്പോൾ ഡോക്ടർമാരുടെ ഒരു മനസ്സെനിക്ക് മനസ്സിലായത്, നമ്മുടെയൊക്കെ അറിവ്, ഞങ്ങൾ MDയും DM ഒക്കെ കഴിഞ്ഞ ഡോക്ടേഴ്സ് എല്ലാം അറിയുന്നവരാണെന്നാണ് ഞങ്ങളുടെയൊക്കെ ധാരണ. പക്ഷേ നിങ്ങൾ തന്നെ സ്വീകരിക്കുന്നു, അറിവ് പൂർണ്ണമല്ല, ഇനിയും പലതും നമുക്ക് അറിയാനുണ്ട്, മനസ്സിലാക്കാനുണ്ട്. ആ അന്വേഷണത്തിന് വേണ്ടിയുള്ള നിങ്ങളുടെ താല്പര്യത്തെ ഞാൻ അങ്ങേയറ്റം മാനിക്കുകയാണ്. ഞാൻ പെട്ടെന്ന് ഓർമ്മ വന്നത്, ഈ വീടുകളിൽ അക്വേറിയമുള്ള വീടുകളിൽ ഉള്ള അലങ്കാര മത്സ്യങ്ങളുണ്ടല്ലോ, ആ മത്സ്യത്തെ അറബിക്കടലിലെ മറ്റൊരു മത്സ്യവുമായി ഒരു താരതമ്യപ്പെടുത്തിക്കോ. അക്വേറിയത്തിലെ മത്സ്യത്തിന് ആ 4 ഗ്ലാസ് ചൂരുകൾക്കുള്ളിൽ എന്തൊക്കെ ഉണ്ട് എന്ന് ഏതാണ്ടൊക്കെ ഗ്രഹിക്കാം, അറിയാം. പക്ഷെ അറബിക്കടലിലെ മത്സ്യം അറബിക്കടലിൽ എന്തൊക്കെയുണ്ട് എന്ന് അറിയുന്ന മത്സ്യമല്ല. അതിങ്ങനെ എത്ര യാത്ര ചെയ്താലും കൂടുതൽ അന്വേഷിച്ചുകൊണ്ടിരിക്കുകയാണ്. അപ്പം നമുക്ക് ലഭ്യമായി കഴിഞ്ഞിരിക്കുന്ന അറിവ്, അല്ലെ കണ്ടെത്തി കഴിഞ്ഞിരിക്കുന്ന അറിവ് പൂർണ്ണമല്ല. കണ്ടെത്തിയത് മുഴുവൻ നമ്മൾ ഹൃദയസ്ഥമാക്കി കഴിഞ്ഞിട്ടില്ല. ഇനി കണ്ടെത്താൻ എത്രയോ അറിവുകളുണ്ട്. കണ്ടെത്താനുള്ള അറിവുകൾ കണ്ടെത്താനും കണ്ടെത്തിയവയെ ഹൃദയസ്ഥമാക്കാനും ഒക്കെയുള്ള നിങ്ങളുടെ ഒരു പരിശ്രമം ആത്യന്തികമായി രോഗികൾക്കാണ് പ്രയോജനമുണ്ടാകുക എന്ന തിരിച്ചറിവിലാണ്. നിങ്ങളുടെ എല്ലാവരുടെയും ഇതിലെ പങ്കാളിത്തം എന്നത് വലിയ സന്തോഷത്തോടെ ഞാൻ മനസ്സിലാക്കുന്നു. ആ സന്തോഷം ഞാനും പങ്കുവയ്ക്കുന്നു. കേരളത്തിൻ്റെ വിവിധ ഭാഗങ്ങളിൽ നിന്നാണ് എൻ്റെ നാട്ടിലേക്ക് ഞാൻ പ്രദാനം ചെയ്യുന്ന തിരുവല്ലയിലേക്ക് കേരളത്തിലെ ഏറ്റവും പ്രഗത്ഭരായ ഡോക്ടർമാരെത്തിയിട്ടുള്ളത്. ഞാൻ പറഞ്ഞു, ഡോക്ടർ ജബ്ബാറിൻ്റെ ഡയബറ്റോളജി ഇൻസ്റ്റിറ്റ്യൂട്ട് ഓഫ് ഡയബറ്റോളജി ഡോക്ടറാണ്. ഡോക്ടർ സുനിൽ സ്ഥിരമായി എന്നെ കാണുന്ന ആളാണ്. ഡോക്ടർ മാത്യു തോമസ് എൻ്റെ കുടുംബ ഡോക്ടറാണ്. എൻ്റെ സഹധർമ്മിണിയെയും മക്കളെയൊക്കെ ചികിത്സിച്ചിട്ടുണ്ട്. അതിനേക്കാൾ പ്രധാനമായി രാഷ്ട്രീയത്തിലെ എൻ്റെ ഗുരുനാഥൻ വിശ്വംഭരൻ സാർ എന്ന മൺമറഞ്ഞു പോയ നേതാവിനെ അവസാന കാലത്ത് ചികിത്സിച്ചത് ഡോക്ടർ മാത്യു തോമസ് ആണ്. അപ്പോൾ പ്രഗത്ഭരായ ഡോക്ടർമാരുടെ ഒരു സംഗമമാണ്. ആ സംഗമം കൂടുതൽ അന്വേഷണങ്ങൾ നടത്തി നല്ല ചികിത്സ രോഗികൾക്ക് നൽകി കൊടുക്കുവാൻ വേണ്ടിയുള്ള ഞങ്ങളുടെ താല്പര്യത്തെ ഞാൻ ഹൃദയപൂർവ്വം ഒരിക്കൽ കൂടി അഭിനന്ദിക്കുന്നു. തിരുവല്ലയിൽ എത്തിയിരിക്കുന്ന കേരളത്തിലെ പ്രഗത്ഭരായ എല്ലാവരെയും സ്വാഗതം ചെയ്തുകൊണ്ട് ഈ ഫസ്റ്റ് ക്വാർട്ടർലി മീറ്റിംഗ് ഉദ്ഘാടനം ചെയ്തതായി അറിയിക്കട്ടെ.
Thank you so much, sir, for captivating the audience. Next, I would like to call upon Dr. Neeraj Manikat, the Secretary of the API Kerala chapter, to address the audience.
Good morning. First of all, I'd like to thank the entire API Kerala chapter members for giving me an occasion to be the secretary of this honorable association, and also to work with Dr. Ramesh Nair sir as the president. The last 3 months, for the first time I am being the secretary, so it was a little anxious, but he was always there to help me. And we have 3 quarterly meets in a year and 1 annual meet, and this is the first quarterly meeting for this 2022-23. And as you can see, with the help of Dr. Sri Hari, the secretary, and Dr. Sunil Matthew sir, they have given excellent support to us, and almost the entire work. They were here till 11 p.m. yesterday, and they have done excellent work in organizing this successfully. I thank them for making my job very easy, and I also hope to look forward for you people to come in similar large numbers in the upcoming quarterly meet. Thank you.
Thank you, sir. I request Dr. Matthew Thomas, patron to the API Kerala chapter, to felicitate the gathering with his thoughtful and inspiring words.
Respectful dignitaries on the dais and my dear friends, it is so pleasant to see, as the first speaker announced, there are a lot of people even at the first session of the API meeting. That is very, very encouraging. And for the juniors, this organization or this association started in 1977, and I was a member at that time. And we have reached the other end. Now you have all selected me as the patron. It's a big favor, big thing for me. Very, very big honor for me. And I invite all the people, all the physicians. We are a association of about more than 1,000 members. But I would like all of them to come. As the Honorable MLA said, we have to imbibe this. Even we are studying now, so we have to go on studying. So it is very important that you attend this meeting, get the current knowledge, see how much information we got from the first lecture, first talk. So that is going to be daily useful for us when we see our patients. So please bring as many as of our members to these meetings so that you can be equipped with good knowledge and answer the patient's question. And I'm very happy to see the Honorable MLA. There's only a cup of tea differentiating us. His name is Matthew T. Thomas and I am Matthew Thomas. So only a cup of tea is different. So we have been long as yes. So we have a long association and I was very happy to see him there. And all the best wishes for the delegates who have come. You stay till the end. So that is another message from me. Stay till the end. See the youngsters presenting free papers. Go to the poster, see the posters and ask questions. I think you should make the full use of it. Thank you very much.
Thank you, sir. Next on stage, I invite Dr. C.R. Radhakrishnan, the President of the IMA THIRUVALLA, to felicitate the audience.
Good morning, everybody. ആദ്യമായിട്ട് ഞാൻ ആദ്യം വരച്ച CTPയുടെ ഒരു മീറ്റിംഗ് ആണെന്നാണ്. ഫോണിൽ കൂടെ മിനിഞ്ഞാന്ന് സുനിൽ വിളിക്കുമ്പോൾ അങ്ങനെ ഞാൻ തിരിച്ചത്. പിന്നെയാണ് APIയുടെ മീറ്റിംഗാണ്. ആദ്യമായിട്ട് ഇതുപോലെ കൂടെ ഒരു ഗ്രാൻഡ് ഫംഗ്ഷന് എന്നെ വിളിച്ചതിന് നന്ദി പറയുന്നു. എൻ്റെ പ്രസക്തി എന്താണെന്ന് എനിക്കറിയില്ല. ഒരു പക്ഷേ സംഘടനാപരമായ എന്തെങ്കിലും ഒരു ചില പോയിൻറ്റ്സ് പറയാനായിരിക്കാം എന്നാണ് സുനിൽ ഉദ്ദേശിച്ച് തോന്നുന്നു. ഇന്ന് രാവിലെ മിനിഞ്ഞാന്നത്തെ ഇന്നലത്തെ മനോരമയിൽ ശരിക്കും ഡോക്ടർമാർക്കെതിരായ തന്നെ ന്യൂസാണ് പറ്റുന്നത്. മിനിഞ്ഞാന്നത്തെ മനോരമയിൽ 1000 കോടി രൂപ ഡോളോ പ്രിസ്ക്രൈബ് ചെയ്തിട്ട് കൊടുത്തത്. എനിക്ക് മനസ്സിലാകത്തില്ല എന്തുവാണ് ഡോളോ എന്ന് പറഞ്ഞാൽ വഴുതികളെ ആൾക്കാർ പോയി മേടിക്കുന്ന ഗുളികയാണ്. അതൊരു മിസ്ലീഡ് ചെയ്യുകയാണ് മീഡിയയെ, ഡോക്ടർമാരെക്കെതിരായിട്ടുള്ള ഒരു മിസ്ലീഡ് ചെയ്യുകയാണ്. ഇന്നത്തെ മനോരമയിൽ എന്താണ് കേരളത്തിലാണ് ഇന്ത്യയിൽ ഏറ്റവും കൂടുതൽ മരുന്ന് കഴിക്കുന്നത്. അതിൻ്റെ ഒരു വലിയ കുറ്റം ചെയ്യുന്നവർ നമ്മൾ MDMA ഒന്നും അല്ല കുറിച്ച് കൊടുക്കുന്നത്. അതിൽ തന്നെ 90% ഡോക്ടർമാർ കുറിക്കുകയാണെന്ന് പറയും. ഇതെല്ലാം പബ്ലിക്കിനെ മിസ്ലീഡ് ചെയ്യുകയാണ്. ഇന്ന് മരുന്ന് ഭയങ്കര കുഴപ്പമാണ്, അല്ലല്ലേ മരുന്ന് കൊണ്ടാണ് ഈ കേരളത്തിലെ ആയുസ് 75 എന്നുള്ള അതിനെപ്പറ്റിയൊന്നും ആരും പറയത്തില്ല. എൻ്റെ ചെറുപ്പകാലത്ത് ഞാൻ ഒത്തിരി ഷഷ്ടിപൂർത്തി കൊണ്ടിട്ടുണ്ട്. അതായത് ഒരു 60 തൊട്ട് 70 കാലത്ത് ഷഷ്ടിപൂർത്തി കഴിഞ്ഞാൽ പിന്നെ ദിവസങ്ങൾ എണ്ണപ്പെട്ടു എന്നാണ്. ഒരു 1-2 വർഷം കഴിഞ്ഞാൽ അദ്ദേഹം തട്ടിപ്പോയി, അല്ലെങ്കിൽ മാടനടിച്ചു എന്നൊക്കെ പറഞ്ഞ് ഹാർട്ട് അറ്റാക്ക് ആയിട്ട്. അപ്പോൾ ആ കാലമൊക്കെ പോയി 75 വയസ്സ് ആയുസുണ്ട്. ഇനി നമ്മുടെ ഇച്ചിരി ഈ ഫൗളായിട്ടുള്ള മദ്യപാനമോ അല്ലെങ്കിൽ കണ്ടപാനം ആഹാരം കഴിപ്പും അല്ലെങ്കിൽ സെഡൻറ്ററി ലൈഫോ കുറയ്ക്കാൻ ചിലപ്പോൾ 80 അതിൽ കൂടുതൽ വന്നിരിക്കാം. അപ്പോൾ അതിൽ ഡോക്ടർമാരുടെ കോൺട്രിബ്യൂഷനെ പറ്റി ഒന്നും ഒരു ന്യൂസും വരത്തില്ല. ഇതിൽ ഡോളോ 1000 കോടി രൂപ കൊടുത്തു. ആർക്ക് കൊടുത്തുന്നു? ഏതായാലും നമുക്കാർക്കും കിട്ടിയിട്ടില്ലെന്നുള്ള ഉറപ്പാണ്. അങ്ങനെയൊക്കെയുള്ള ന്യൂസുകളാണ് വന്നുകൊണ്ടിരിക്കുന്നത്. അപ്പോൾ ഡോക്ടർമാരെ സംബന്ധിച്ചോളം നല്ല കാലമൊന്നും അല്ല എന്നുള്ള വാസ്തവമാണ്. ഡൽഹിയിൽ നിന്ന് ആയുഷ് വരുന്നു, പിന്നെ വേറെ പല ഭാഗത്തുനിന്നും പല ഡോക്ടർമാരെ സംബന്ധിച്ചോളം നല്ല കാലമല്ല. നമ്മുടെ പ്രതാപകാലമൊക്കെ പോയി തന്നെ വിചാരിക്കുക. കഴിയുന്ന പിള്ളേരെ നിർബന്ധിച്ച് മെഡിസിന് വിടാതിരിക്കുക, അഥവാ പോകുന്നവരെ എത്രയും വേഗം നാട് കടത്തുക എന്നുള്ളതാണ്. ഇവിടെ ഒന്നും വലിയ രക്ഷയൊന്നുമില്ല. തല്ല് കൊള്ളായിരുന്ന ഭാഗ്യം. തല്ലൊക്കെ ഒത്തിരി പേർക്ക് തല്ലിൻ്റെ വക്കത്തെത്തുന്നുണ്ട്. അപ്പം ഇതിനൊക്കെ എന്ന് പറഞ്ഞാൽ വേറെ മാർഗം നമുക്ക് ഒരുമിച്ച് നിൽക്കുക എന്നുള്ളതേ ഉള്ളൂ, അല്ലാതെ സപ്പോർട്ട് കിട്ടുമെന്നും വിചാരിക്കേണ്ട. എനിക്ക് തന്നെ ഒരു പദഭീഷണി ഉണ്ടായിരുന്നു. 2030 കഴിഞ്ഞാൽ പിന്നെ എനിക്ക് തോന്നുന്നു ഫോറിൻ എംപ്ലോയ്മെൻ്റൊക്കെ മിക്കവാറും നിന്ന് പോകും. ഈ നമ്മുടെ കരിക്കുലമൊക്കെ എന്താണ് ശബദമുണ്ട്, ഇപ്പോൾ ശബദം നമ്മൾ കറക്റ്റ് ശബദം, അതിനകത്ത് അതൊക്കെ ശബ്ദം ചെയ്താൽ നമുക്ക് നമ്മുടെ എത്തിക്സിനെതിരാണ്. പണമുള്ളവരെ ചികിത്സിക്കുക, രാജാവിനെ ചികിത്സിക്കണം, അങ്ങനെയൊക്കെയുള്ളതാണ്. പാവപ്പെട്ടവരെ മൈൻഡ് ചെയ്യേണ്ടതാണ് ശബദത്തിൽ. പക്ഷേ നമ്മൾ ആ ശബദം എടുക്കാൻ തയ്യാറല്ല. സോ നമ്മുടെ ഇതിനൊക്കെ ഒരു ചെറിയ പരിഹാരം എന്ന് പറഞ്ഞാൽ IMAയിലൊക്കെ ചേരുക, എന്തെങ്കിലുമൊക്കെ ഒരു ചെറിയ സപ്പോർട്ട്. ഇപ്പം എനിക്ക് തോന്നുന്നു ഇപ്പോൾ കേരളത്തിൽ ഇപ്പോൾ 10,000-80,000 ആണെന്ന് തോന്നുന്നു. അതിനകത്തൊരു 10,000 പേരൊക്കെ പോയി കാണും, മരിച്ചു പോയോ അല്ലെങ്കിൽ അപ്പം ബാക്കി ഒരു 60,000 പേരുണ്ടെങ്കിലും ഒരു 40,000 പേരെ ഉള്ളൂ ഇപ്പോൾ IMAയിൽ ചേരുക എന്നുള്ള നല്ല കാര്യമാണ്. അതുകൊണ്ട് കഴിയുന്നത് IMAയിലൊക്കെ ചേരുക. അതുകൊണ്ട് നെഗറ്റീവ്സ് ഒന്നും ഉണ്ടാകാൻ പോകുന്നില്ല, എന്തെങ്കിലും ഗുണമേ ഉണ്ടാകും. പിന്നെ അറ്റ്ലീസ്റ്റ് 1-2 സ്കീം, പ്രൊഫഷണൽ സ്കീമോ ഒരു കേസൊക്കെ വന്നു കഴിഞ്ഞാൽ നമ്മൾക്ക് ലോൺ എടുത്ത് വീട്ടേണ്ടി വരും. അപ്പം അതുകൊണ്ട് അതൊക്കെ ചേരുക, ഒരുമിച്ച് നിൽക്കുക. കൂടുതലൊന്നും എനിക്ക് പറയാനില്ല. ഈ വലിയൊരു വേദിയിലേക്ക് എന്നെ ക്ഷണിച്ചതിന് ഞാൻ ഡോക്ടർ സുനിലിനോടും ഈ ഭാരവാഹികളോടും ഞാൻ നന്ദി പറയുകയാണ്. നമ്മുടെ ഈ മീറ്റിംഗ് മാത്യു തോമസിൻ്റെ സാന്നിധ്യം കൊണ്ട് മഹനീയമായി. താങ്ക് യു സാർ. അദ്ദേഹത്തിന് മെഡിക്കൽ ഫീൽഡുമായിട്ട് വളരെ അടുപ്പമുള്ള ഒരു രാഷ്ട്രീയ വ്യക്തിത്വമാണ്, അല്ല ഡോക്ടർമാരെ തല്ലുന്ന ഒരു രാഷ്ട്രീയ വ്യക്തിത്വമല്ല. അതുകൊണ്ട് സാറിന് പ്രത്യേകം നന്ദി പറഞ്ഞു ഞാൻ നിർത്തുകയാണ്.
Thank you, sir. I invite Dr. Sunil Matthews, sir, the organizing chairman, and Dr. Ramesh Nair, our president of the API chapter, to please hand over the prestigious Aramulla Kannadi to our honorable MLA, Advocate Matthew T. Thomas, on behalf of the Central Travancore Physicians Club and API Kerala chapter. Thank you so much, sir. Every good thing must come to an end. On this note, I invite Dr. G.K. Srihari, the organizing secretary of this conference, to deliver the word of thanks.
Respected President Dr. Ramesh Nair, our Chief Guest, Advocate Matthew T. Thomas, Honorable MLA, THIRUVALLA, Dr. Matthew Thomas, sir, Dr. C.R. Radhakrishnan, sir, Dr. Neeraj Manikat, Dr. Sunil Matthew, sir, teachers and dignitaries of the dais, very good morning. First of all, I thank our chief guest, Advocate Matthew T. Thomas, for being with us and lighting the lamp for this function. Thank you, sir. I thank Dr. Ramesh Nair, sir, President APA Kerala chapter, for presiding this session and for all the guidance and support. Thank you, sir. I thank Dr. Matthew Thomas, sir, Patron APA, for all the guidance and blessings. Thank you, sir. I thank Dr. Neeraj Manikat, APA Secretary, for all the guidance and arrangements and timely interventions for this function. Thank you, sir. I thank Dr. C.R. Radhakrishnan, sir, President, Indian Medical Association, THIRUVALLA, for being with us and his humorous and practical words. Thank you, sir. I thank Dr. Sunil Matthew, sir, organizing chairman of APA Kerala first quarterly meeting, without support of whom this event may not be happened. Thank you, sir. I thank Dr. P.K. Jabbar, sir, for receiving Professor V.C. Matthew Roy Memorial Oration Award and for his speech. Thank you, sir. I thank Dr. Sajan Ahmed, Dr. Anil Satyadas, Dr. James Thomas, Dr. Suma T.K., Dr. Nihal Thomas, and Dr. Raghunath M. for being faculties and sharing their expert scientific knowledge with us. Thank you. I thank all the chairpersons and experts for the evaluation of free paper sessions and poster presentations. Thank you. I thank all the doctors who are here for presenting their papers and posters. Thank you. Thank you very much. Next, I thank all the delegates who are here before 9 a.m. so that we could start the CME on time. Thank you. I thank Dr. P.K. Benjamin, sir, President of Central Travancore Physicians Club, THIRUVALLA, and all the members of Physicians Club for organizing this CME. I thank KGA Elite Hotel, THIRUVALLA, for providing this venue. I thank Mahadeva Group for all the audiovisual arrangements. I thank Q Events for decorating the stage and venue and arranging the stalls. I thank Mr. Jadish PT for the support in each and every step of the execution of this CME program. Thank you, Jadish. I thank the staff and students of Pushpagiri Medical College for the nice comparing and their graceful presence. Thank you. I thank IRIS, Akasis USV, Microlabs, AstraZeneca, Sun Pharma, Corona Remedies, and Unilex Pharmaceuticals for their support. Once again, I thank one and all. Thank you very much.
Thank you, sir. This marks the end to our inaugural function. I thank each and every one of you for being an active participant in today's proceedings and in making this function a grand success. Let us next move on to the next phase of our conference, the scientific program, which I'm sure all of you are eagerly awaiting for. This is the second topic of our first session. This is again chaired by Dr. Sojan K. Skaria sir and Dr. Sajid Kumar sir. I invite both doctors to please be on stage. The next topic we have in store for us is ventilatory support in ARDS, a very common scenario faced by many of us in the ICU and yet still one of the most poorly understood topics. I hope Dr. Anil Satyadas will be able to clear our queries and set our minds free of any doubts we may have on this enigmatic topic. With great pleasure, let me please welcome Dr. Anil Satyadas, an Associate Professor in Anesthesiology and the Intensivist at Government Medical College, Trivandrum.
Good morning all, respected teachers and delegates. Sorry.
Good morning again. Our next topic will be presented by Dr. Anil Satyadas. He is Associate Professor of Anesthesiology and Intensivist, Medical College, Trivandrum. With these few words, I ask our co-chairperson to introduce the subject.
As all of us know, in the last few months, we have realized the importance of this particular entity called ARDS and how the ventilator is playing a major role now. Probably in the erstwhile years, ventilator was supposed to be a part of terminal care, but subsequently now we have seen in the last few months that care of patients on ventilator as well as the other modalities of support for respiration has definitely improved the chances of survival and has become a major component of critical care in all parts of the world. And one major aspect we have to notice in this particular aspect of management of ARDS is the interdisciplinary or the multidisciplinary participation in ventilation as well as other related intensive care issues. To discuss about this, we have Dr. Anil Satyadas with us, who has been a regular orator in the field of ventilation and ARDS, and I'm sure he will be contributing a lot to the components of ventilation and management of ARDS, particularly from a physician's point of view. Over to Dr. Anil.
Yeah, once again, good morning, sir. Thank you for the introduction. So, thank the organizers for giving this opportunity to talk about ARDS ventilatory support. We'll go through these topics in the following headings. We'll discuss a few points regarding the pathophysiology. Then a lot of controversies are there here, whether you stick on to a non-invasive ventilation or go to intubate the patient. The concepts regarding lung protective ventilation, what are your oxygenation goals, what is an optimal PEEP, whether to recruit or prompt the patient, and last but not least, weaning of patient on ventilatory support. This, anybody who has gone through this management of severe ARDS, it's definitely a nightmare, because even the Western literature shows a mortality as high as 55%. And there are no definite endpoints, especially with respect to how this patient would tolerate a hypoxemia. Regarding the pathophysiology, it's so very devastating, and the support we are going to give can damage the lung further. So all this makes this a worse scenario. And there are few treatment options with good evidences. So coming to the pathophysiology, it's like a hurricane or a flash flood with damage to the basement membrane, the endothelium, as well as interstitial edema. Okay, so it's an alveoli that is flooded with water, and we have diffuse. It's a diffuse process affecting most of the alveoli, making the lungs very stiff, and most of the areas are collapsed. This can increase the pulmonary vascular resistance and put a strain on the right side of the heart. That can lead to very severe hypoxemia because of true shunts, which rarely respond to increasing FiO2s or oxygen, and then the low V/Qs can also exist, causing hypoxemia. So initially we have a phase where the alveoli would be fluid filled, later proliferative, and then going to the fibrotic phase. So these phases are important because if you don't halt or limit the disease process, you can land up in patient having a lot of fibrosis and a chronic liver disease, lung disease. So coming to the definition of ARDS, as you all know, it's an acute within 7 days. Should have bilateral infiltrates in the X-ray. Usually it's bilateral. And hypoxemia is defined as a P/F or PaO2 by FiO2 less than 300. And it's non-cardiogenic in origin. You don't have to do an echo or do the pulmonary capillary wedge pressure to prove that it's cardiogenic. You can do an echo to rule out a major cardiac problem that is causing this. And most of the time you have bilateral fluffy exudates in both the lung fields. Coming to CT, which would explain this disease process further, we have initial stage which is exudative. And remember, all this consolidation are confined to the gravity dependent bases rather than the apex. And what they say is that you have 3 areas in the lungs, which one part is usually 1/3 is the normal aeratable lung. You have an area in between which are collapsed but are recruitable, so they open up with higher pressures. And area very at the base level, you have dense consolidation which usually don't respond to high pressures. So 1/3 is normal, and that normal 1/3 is usually referred as the baby lung. So our aim of ventilation is to protect that small lung. So if your ventilation is going to damage that small normal lung, that is going to have a very bad outcome. Okay. So next phase would be a lot of consolidation with ground glassing and traction bronchiectasis, and later going to fibrotic changes. This is a CT image. So coming to our options, okay, we start with oxygen therapy and then go to HFNC, because hypoxemia would be the presenting symptoms or signs you elicit in patients. And then we go to NIV, and then later to intubation and further management of the ventilated patients. Coming to HFNC, we had a recent guideline, that is 2021 update on ARDS, which said that HFNC was okay initially, but then it definitely avoid the complications of tracheal intubation, which because we are not doing that, especially in the initial stages. But remember, one point is that this HFNC may delay intubations, and then that can increase mortality. So, and also it was not an established treatment. It's still not an establishment treatment for ARDS. What they suggest is conducting HFNC over oxygen therapy. It's not even NIV. So instead of oxygen therapy, you can consider HFNC as the initial therapy of ARDS if there is no contraindication to HFNC. As you know that this machine has an interface which has a diffuser at the nasal part, okay, and the differences from normal oxygen therapy is that it has a high flow. Flows as high as 60 liters per minute, and FiO2 can go as high as 100% or 1. So it has a machine sort of thing that would have a turbine which would like pump in gases into the patient's airway, and this high flows and high FiO2s usually helps the patient get some
some amount of PEEP, that is positive index periodic pressure, which has an advantage of keeping these alveoli open and trying to recruit other alveoli which are openable. Remember, one point is that the PEEP would be more effective when the patient keeps the mouth closed. So if the patient is not cooperative and maybe having food, it might be not very effective as thought to. Next option we have is non-invasive ventilation. So what the recommendation says is that we can start a non-invasive trial. Okay, so whether to go with HFNC or to go with NIV would be decided by the clinical scenario. Okay, so the patient puts in a lot of work of breathing, is severely hypoxemic. Non-invasive ventilation would be much better than a high flow nasal cannula. So initial NIV trial, if there is no contraindications. Contraindications are a very obtunded patient, non-cooperative patient, some problem with attaching the interface like your burns, very abnormal faces, very small face which usual mask might not fit into, and patient who is claustrophobic might not accept such mask. So the recommendation, though it's weak, what they recommend is to have the patient in a scenario or an area where these patients would be very closely monitored. You have people who can intubate the patient SOS and suggest conducting NIV over tracheal intubation. So in COVID also we'd hold on with the NIV for some time. We'll have a close monitoring, and the patient not responding to non-invasive ventilation. Okay, the work of breathing increases or there is no response to non-invasive ventilation. We'll think of stopping that and going to intubation. So with respect to non-invasive ventilation, it's usually reserved for mild. Mild is said when the P/F is between 200 to 300. Okay, and patient is hemodynamically stable, does not need, clinically census tell you that you don't need to intubate the patient, just immediately patient comes to the ICU. And as usual, there's no contraindications to it and is frequently evaluated for any signs or symptoms that tells us to upgrade the treatment. And next is advice what they found was that helmet interface. We have oral mask, we have oronasal mask, we have some helmet mask. Okay, so helmet mask had the best results. So if we are able to procure this, we can use this for ARDS, but then that we have to keep a low threshold for intubation. So the next question is when to intubate. So the answer I've already discussed in some of the previous slides, but then it's always a moderate ARDS, and that was a recommendation before the COVID came in. P/F less than, that is PO2/FI of less than 100, and moderate ARDS. But COVID changed the scenario a bit. Some of the guidelines came down with the respect to the P/F, and they said that we could wait till the PF came less than 150. Okay, so that was based on the pathophysiological changes that occurred in COVID, where the alveoli might not be very water logged initially, but it was a dysregulated vascular problem. So the blood flow to that particular alveoli was high, and that produced hypoxemia rather than a fluid filled alveoli. So that resulted in a change in recommendation where we could hold on with the non-invasive ventilation for P/F of up to 150. And also they introduced one term that's called as a patient self-induced lung injury. They said that the patient on NIV, if you see that work of breathing is very high, the negative pressure that is created by the patient itself can damage the lung. It's not, you don't have to put the patient on the ventilator to damage the lung and overinflate the lung, but the pressures that are developed by the large efforts, negative inspiratory efforts of the patient itself can produce lung damage. So specific indications for intubating the patients would be altered consciousness, patients at high risk of aspiration, pregnant patients, severe hypoxemia, patients who are having high intraabdominal pressure. Severe hypoxemia is defined as less than 100. Severe acidosis. Okay, so retention of carbon dioxide or even metabolic acidosis, you try to intubate the patient early. And this is the most important. So you have to closely monitor the patient and look for the work of breathing, use of accessory muscles, the large tidal volume breaths the patient takes, and a failed NIV. The NIV is not producing results either with respect to your carbon dioxide washout or oxygen, increase in the oxygen. So these are the point in time when we think of intubating the patients. So once you intubate the patient, okay, so what category of ventilation would you stick on to? Whether would you go for volume control where you fix a tidal volume, you ask the ventilator to deliver a fixed tidal volume, or would you go for a pressure targeted ventilation where the ventilator will try to deliver a fixed pressures, okay, during the inspiration. So it's very unclear. It's still hotly debated whether pressure control is good or volume control. But remember, most of the older studies, the ArdsNet study was done under the volume control. They went for low versus high tidal volume and found that low tidal volume ventilation was much, much better. But the basic take-home point here would be, in volume control A-bar-CMA, that is assist bar control mechanical ventilation, which is one mode that gives you the best respiratory support. You have a fixed tidal volume, okay? So you don't allow the ventilator to give that fixed tidal volume without any limitations for the pressures. Because if you are asked to give 400 ml tidal volume with no restriction on the pressures, that can itself produce barotrauma. So we always titrate that volume with respect to the pressures that are needed to inflate the lung to that particular tidal volume. So it is our duty to monitor the pressures. So which pressures is most important? It is the pressure in the alveoli, which are more important. That's called alveolar pressure. Okay, we have to monitor that. So we'll see how to do that in later slides. Whereas in pressure control, we are fixing the pressures. Okay, so a patient who is having a normal lung for a particular pressure of say 20 centimeters of water, he would get 500 ml tidal volume. But when the lungs become stiff, the same 20 centimeters of water cannot give that 500 ml tidal volume. It would be as low as 200 ml tidal volume. So it's our duty to see that the pressures that you have set is giving the target tidal volume, which we estimate by different equations. We'll see that later also. So always have in mind the target tidal volume, and the tidal volume is always decided with respect to the pressures that are developed in the system. So we would also prefer pressure control ventilation in patients who have or are allowed to breathe. Okay, so when the patient takes in spontaneous breaths with the help of the ventilator, they would very well appreciate being in a pressure control ventilation rather than a volume control ventilation. The simple fact is that you have an unlimited flows in pressure control ventilation. That is a concept. That is how the technology works, or the technique works. So in pressure control, the patient does not have any air hunger or air starvation. So we have decided to put the patient, maybe during the first initial hours, we would stick on to giving some muscle relaxant, so the patient does not breathe. But maybe if patient is recovering from hypoxemia, we try to give the work-up breathing to the patient also. During that time, the patient would appreciate being in a pressure control ventilation rather than in a volume control mode of ventilation. So I think this slide is most important. So when you put patient on ventilator, the thing that should be kept in mind is lung protective ventilation. As I've already told you that we are going to ventilate that small baby lung. Okay, it's not a normal lung volume at all. So you start with the tidal volume that has been recommended is varying from 4 to 8 ml per kg of predicted body weight. So what is this predicted body weight? You have to take the height of the patient, and you have formulas to calculate the predicted body weight. So it tells you that as we grow obese or bigger, our lungs don't grow. So our lung volume is basically dependent on the height of the patient rather than the absolute body weight. So you take the predicted body weight and start. Some of the guidelines will ask you to start from 8 ml per kg predicted body weight. Some guidelines will ask you to start from 6 ml per kg of predicted body weight. So if you're starting from 8, every hour you decrease the tidal volume by 1. So by the end of 2 hours, you would be ventilating the patient with 6 ml per kg predicted body weight. So as per the formula, a 60-inch male would have a weight of 50 kg only. 50 kg is the predicted body weight. So when you multiply that by 6, 50 to 6 is hardly 300 ml of tidal volume at the end of 2 hours. Okay. So, and once you start ventilating that patient with 300 ml of tidal volume, next thing you have to monitor is, as I've already said, you have to monitor the pressures that are needed to develop or give this 300 ml tidal volume. So what is the best pressure you have to monitor? You have to monitor the pressure in the alveoli, and that is what is called as the alveolar pressure. We monitor the alveolar pressure, and if it is more than 30, so 30 and below is considered to be safe. So once it's more than 30, what can we do? We have to give lung protective ventilation. So we have to decrease the pressures. Only thing that we can do to decrease the pressures is to decrease the tidal volume. Okay, so from 6 ml per kg we come down to 5. Look at the alveolar pressures. If they are still more than 30, come down to as low as 4 ml per kg of predicted body weight. So this patient, if the pressures are high, you would be ventilating the patient with hardly 200 ml of tidal volume. Okay, by the end of, but maybe after optimizing the tidal volume, you look at the alveolar pressures, you would be coming down to 200 ml of tidal volume. So as you can anticipate, we are actually hypoventilating this patient. So what happens? Carbon dioxide goes up. Okay, so to wash off carbon dioxide, we have the option to increase the respiratory rate, and that too to a maximum of 35 per minute. Okay, so in order to maintain the minute ventilation to wash off carbon dioxide, okay, with low tidal volumes, we have the option to increase the respiratory rate to as high as 35 per minute. Okay, this is the basic concepts of lung protective ventilation. So we talked about alveolar pressure, and this is the schematic diagram of the ventilator with the patient, and the patient being connected to the ventilator with a narrow tube. Okay, so this is the ventilator, this is the balloon that is representing the lung. So the main task of the ventilator is to increase the pressure at this end, okay, so that gases flow from high pressure to low pressure area. Okay, so when that occurs, suppose the ventilator pressure that is developed is 20 centimeters of water, and this high pressure makes the gas go through this narrow tube into the balloon. As you know, the balloon has a normal property of coming to the lowest volume because it is elastic. Elastance property is there for the balloon or the lung. So what happens here is that the 20 centimeters of water should also overcome the resistance that this tube offers, because when there is a flow of gas or liquid across a tube, there is resistance in the tube. So what does this 20 do? It should overcome the resistance as well as the elastic property of the balloon. Then only the balloon will get inflated. But here, so 20, suppose it goes here, it reaches 15. So what is that 5? 5 is just to overcome the resistance in the tube. What is 15 used for? 15 is used to inflate the balloon or overcome the elastic property of the balloon. So here, what we said about alveolar pressures. We talked about alveolar pressure should be less than 30. So how do you measure the alveolar pressure? You have to give a procedure that's called as an inspiratory hold, where the balloon is totally inflated, and at the end of inspiration, the flows are stopped. The ventilator stops the flows in both the inspiratory and the expiratory limb. So you have a situation where you have a ventilator at this end, but there is no flow. When there is no flow, the resistance part becomes zero. So if you measure the pressure here, that will reflect the pressure in the balloon. Okay, so that is how we measure the alveolar pressure, and this is the graph that you get when you do the inspiratory hold. That's a procedure you do on the ventilator to find the alveolar pressure. That's called the inspiratory hold. You look at the graph. Initially, the first graph shows there is no inspiratory hold. Okay, it goes down to exhalation, whereas the second graph, second breath, gives a inspiratory hold, and the pressures drop down and plateau. This is the alveolar pressure. So the plateau pressure is a surrogate for the alveolar pressure, and that should be always less than 30 centimeters of water. Then comes to the next point. What are your oxygen targets? Very hotly debated. Again, very difficult to do a study to allow the patient to go into hypoxemia and see the effects of hypoxemia on him. So it is currently unknown, and it's always said that you avoid very low or high levels. But we'll go into the studies and see what is their recommendation. In 2021, ICU was done in ARDS patients. They kept a low of 60 and a high of 90, PaO2, partial pressure of oxygen in the artery. There was no difference. Okay, so it suggested maybe a low is also okay. How about oxygen ICU? They had, the lower group had a benefit. So lower group was targeting around 94 to 98% of saturation, SpO2, and the higher group always 100. And they found that there was benefit on the lower group. And ICU rocks, no difference. And liberal oxygen versus conservative oxygen, that is again no difference. But secondary outcome analysis showed there was some patients who were developing mesenteric ischemia. Also, that 90-day mortality was higher in the low target group. Okay, so hypoxemia should be avoided. So keeping all these studies in mind, I think we would have a middle path. Okay, we target somewhere between mid 90s, so 94 to 96 is okay, it is acceptable. And remember, in ARDS, it will be very difficult even to get 94 to 96 percentage of oxygen. Next question is regarding your how much carbon dioxide is allowed to accumulate in the body. So that is called permissive hypercapnia. That is being recommended to some extent provided your pH is something more than 7.25. So 7.35 less than 7.35 and a carbon dioxide more than 45 is generally well tolerated. And you can increase the respiratory rate and try to wash off carbon dioxide, but it might not always work. And pH 7.25 should be treated. If you have option to increase the respiratory rate, you can increase the respiratory rate to more than 235 up to 35. And there is an option to give bicarbonate, but it's always time buying. It might not always treat the hypercarbia due to respiratory acidosis. And the REST trial, which came in recently, they did one procedure that's called as an extracorporeal removal of carbon dioxide. Like your ECMO, which helps in oxygenation. They kept a machine which is very similar, but the flows into the machines are very low. They had the removal of carbon dioxide being done by the machine, and they followed the low tidal volume lung protective ventilation. But the result was that there was no difference in the 90-day mortality. So that again cannot be used in most of our patients. But the secondary outcome was better in patients who were given the extracorporeal carbon dioxide removal. Then coming to PEEP. As you know, PEEP is the baseline pressure, and it is one of the methods by which you can increase the oxygenation. So whether we go for very high PEEP or very low or normal PEEP. So that was a question. And 2020, the guideline says that you can go for a bit higher level of PEEP. But remember, not one PEEP fits all. So the PEEP would, patients who have recruitable lung would appreciate higher PEEP. So it should be always individualized. See the effect of PEEP on the pressures. If the pressures increase by the amount of increase in PEEP you have kept, that means there is no much outcome. That tells you that the alveoli are not getting recruited with the higher PEEP. So optimal PEEP were previously recorded with the best compliance method, but again what the recommendation was during the COVID time is that don't go for technological things to find the best PEEP. But remember, you gradually increase the PEEP by 2 and see its effect on oxygenation, on the hemodynamics, because a higher PEEP can produce hypotension because it increases the mean airway pressure. So keeping all these things in mind, gradual increases in PEEP, and the usual recommended PEEP is say 8 to 12 centimeters of water. Some patients might benefit from higher PEEPs, but it cannot be a blanket cover for all patients. Another method to find the optimal PEEP or the PEEP the patient would need is to follow the ArdsNet PEEP FiO2 table. So it's an empirical or arbitrary combination of FiO2s and PEEP. So if the oxidation targets are not met in one of this, go jump to the right. So here the PEEP is increased by 2, the FiO2 remains same. So it can go up to 24, but remember the high PEEP might not be tolerated in all patients. Then come to our recruitment manual. So what is this recruitment? I told you that some of alveoli are collapsed, some are normal, some are overfilled, some are over-distended. So what recruitment does is to trying to open up the atelectatic alveoli. Okay. If you see this diagram is quite seems to be very good, and this recruitment manual we feel that it is very good. But what really happens is that the normal area, see, you can't apply PEEP or recruit this alveoli alone. All the alveoli will be exposed to the high pressures. Recruitment is basically high pressure. And what happens is the normal alveoli can get over-distended. That can do damage. So there are different methods to do the lung recruitment. And most of them are not practiced routinely. So the guideline says against the routine use of recruitment manuals, not as a routine, but select patients who might respond. And there are different studies showing there is no much advantage of using the recruitment manuals. Then comes the drying pressure. What is this drying pressure? Drying pressure is the pressure that is needed just to inflate the alveoli. Okay. So what they say is that drying pressure is Plato pressure, that's the alveolar pressure minus the PEEP. Just the pressure needed to inflate the alveoli. And as part of monitoring the lung drying pressure and keeping it less than 15 is part of lung protective ventilation. So it is optimization of mechanical ventilation to size of the aerated lung. So this has a lot of evidence, and but it has not come up in a guideline. And it's one variable that's stratified biophysical lung injury risk. That means any one increase in the driving pressure increases the mortality by 5%. So it's always safe to keep the driving pressures less than 15. Neuromuscular blockers, earlier studies said that they are good, but later studies found no advantages. But the guideline says that we can give, most probably you would be needing neuromuscular blockers the moment you intubate the patient. Actually, at least for 24 to 40 years, you would use neuromuscular blockers. We use atracurium, preferably over vecuronium, because vecuronium has high chance of critical illness, neuropathy, myopathy. Coming to last topic is the prawn positioning. How does this affect? So as you see in the first figure, your lower lung is much more collapsed than the first. And the dependent area, the posterior part of the lung, has more volume compared to the anterior. So when you keep the patient prone, both the upper and lower half are almost equally inflated. So the basic concept is that it decreases the ventilation perfusion mismatch. Early proning has been advocated in most of the studies. Also the COVID said we can do awake proning also. So ventilation perfusion is more homogeneously distributed. So when to prone and how long to prone is always early proning and for prolonged periods, and definite evidence is there. Okay, when to stop is the oxygenation has improved with a PEEP of less than 10. And the acute respiratory failure has resolved. That is the point you think of not to prone the patients further. Complications are many, and contraindications to proning include acute bleeding, fractures, raised ICP, relative or shock, air leaks, and major abdominal surgery. So coming to the last part, weaning, should we use a weaning protocol? Yeah, definitely a weaning protocol, something like this. All the weaning protocols take into considerations the recovery of the hypoxemic state. Okay, especially when you want to extubate, they look into the protective airway reflexes also, and there are some indices called the Tobin's index of the RSBI should be less than 105. So you can select one of the criteria, weaning criteria, for weaning the patient from ARDS. And I think that will I finished this topic. It's open for discussion.
Thank you. That was an excellent presentation. This topic is open for discussion. We'll have a few questions and comments.
That was an excellent talk, sir. Normally, what we follow when a patient with ARDS is you put the patient in volume control mode, then you try to wean them down to SIMV, then you go to pressure support, and then to TPs. How far do you think this practice is correct? And if not, is there anything harmful?
Okay, the only problem with the SIME was that, one study found out that, technique-wise SIME is difficult because you need the ventilator to give gases for the assisted breaths, for the spontaneous breaths. So it was difficult, and what they found was that the ventilator was not giving sufficient flows for the patient's spontaneous breaths in SIME mode. Okay, that was a well-validated study. So many of the ICUs have stopped using SIME. But theory-wise, it's a very good mode. It allows spontaneous breaths. It gives support to the patient. It's a weaning mode. So you can also use SIME, but we preferably start with volume control or pressure control, A-bar CME, and then switch to PSP when the patient is weaned. SIME is not a big problem, but you're very concerned with the research, and then you want to stick on to the good evidence-based medicine. We don't use that.
And how far do you think the patient can be put on a TPs without ventilation before extubating the patient?
Yeah, it's a very good question. So studies have shown that you have two options of weaning. One is low pressure support, 6 to 8, PEEP of 5. Okay, they compared that patients with TPs. Okay, and found that the end results, number of patients who passed this trial, failed this trial, were equal. So both the modes have the same success rate or failure rate. So it doesn't matter whether you wean the patient with pressure support or wean the patient with TPs. But one disadvantage of TPs is that, you have extra lengths of tube that lung outside the mouth. That is actually offering more resistance to the patient. So we would prefer going with a pressure support PEEP weaning. Okay, low 5 to 6 pressure support and PEEP of 5. Patient tolerates for 2 hours. We would try to extubate, and then you can also bridge with NIV. You can keep NIV.
I think we haven't touched upon it, but it doesn't happen in ARDS, a bit different. What is the definite situation which you go for a tracheostomy? How far, any recent changes that how long can you keep the tracheo tube, and then you had to go for endotracheal?
Yeah.
tracheostomy.
That again depends on the recovery of the patient, the disease process, how bad the lungs is. So we usually plan for a tracheostomy between the 7th and the 10th day. So anything more than that, better to do a tracheostomy. You decide by the 7th to 10th day whether the patient would improve and extubate by the 10th day. If not, we go preferably to do a tracheostomy by the 7th or 8th day.
Thank you. Let us give Anil a big hand.
Thank you, sir. Thank you.
Let us conclude the session. Thank you all.
That brings us to the close of our first session. I request Dr. Sojan Keskaria sir and Dr. Sajid Kumar sir to please hand over a memento of our appreciation to Dr. Anil Satyadas sir. Thank you, respected teachers. Thank you, Anil sir. This is true and conquer the world of ICU and ventilators. The following is for the kind information of all our postgraduate students. You can upload your poster material in the system which has been arranged at the Ambassador Hall on the second floor of the venue, and the free papers can be uploaded on the system to the left side of the hall facing the screen. Thank you. I am sure we all would like to take a break, clear our minds before the next session. I am informed that tea and snacks are ready. It will be made available in the next room. I request everyone to enjoy their morning chai and be promptly back in 10 minutes for the next session. All the members participating for the general body meeting kindly stay back at the main hall as we are conveying for the meeting now. I request all the members participating for the general body meeting to kindly stay back at the main hall as we are convening for the meeting at the moment.
Would you like to try lifestyle modification or some ചെറിയ ഡോസ് തുടങ്ങാം? കാരണം പല പേഷ്യൻസും പല ഇതിനാണ്. ചിലർ പറയാം ആദ്യമേ വളരെ ഒബീസ് ആയിട്ടുള്ള പേഷ്യൻറ്റ് ഒട്ടും എക്സസൈസ് ഒന്നും ഭയങ്കര എല്ലാം കഴിയും. ഒരു പേഷ്യൻ്റ് സാറേ ഞാൻ എൻ്റെ ജീവിതം ഞാനൊന്ന് കൺട്രോൾ ചെയ്ത് നോക്കി ഒരു 1 month 1.5 months ട്രൈ ചെയ്തു. അതല്ല ജനറലി പേഷ്യൻറ്റ് ഓക്കെ ആണ് സാർ മരുന്ന് തുടങ്ങാമെന്ന് പറയുകയാണെങ്കിൽ ഞാൻ സാധാരണ 10 milligram സ്റ്റാർട്ട് ചെയ്യും. ഞാൻ റോസ്വാസ്റ്റാറ്റിൻ ഒരു 20 ഡേ ഇക്വലൻറ്റ് 20 സ്റ്റാർട്ട് ചെയ്തിട്ട് ഒരു 1 month കഴിയുമ്പോൾ ഫോളോ എങ്ങനെയുണ്ടെന്ന് നോക്കും. ടാർഗറ്റിലാണെങ്കിൽ എന്നുവെച്ചാൽ നമ്മൾ ഹൈ കൊടുക്കണം 40 കൊടുക്കണം എന്ന് എഴുതിയിരിക്കുന്നതുകൊണ്ട് എല്ലാ പേഷ്യൻറ്റും 40 വേണമെന്നില്ല. പിന്നെ ഒരു ഇവൻ്റായിട്ട് വന്നിട്ട് നമ്മൾ പിന്നെ സെക്കൻഡറി പ്രിവെൻഷന് പോകും. നമ്മൾ വളരെ ഇൻറ്റൻസീവ് ട്രീറ്റ്മെൻറ്റാണ്. ചുമ്മാ ഒരാൾ കൊളസ്ട്രോൾ നോക്കി കൂടുതലാന്ന് കണ്ട് നമ്മൾ ആദ്യമേ 40 തുടങ്ങി. ഇറ്റ് ഇസ് വെരി ലൈക്ലി പേഷ്യൻ്റ് വിൽ നോട്ട് കണ്ടിന്യൂ. അപ്പോൾ ഇതിൻ്റെ ബെനിഫിറ്റ് എല്ലാം ലോങ് ടേം കഴിച്ചാലേ ഉള്ളൂ. 10 മാസം കഴിച്ചിട്ട് കാര്യമൊന്നും പേഷ്യൻ്റ് കണ്ടിന്യൂ ചെയ്യുന്ന ഒരു ഡോസ് നമ്മൾ ഒരിക്കൽ ചെയ്യുന്നു. ഇഫ് യു ഹാവ് സിംറ്റം ഒരു സജഷൻ ഉണ്ടെങ്കിൽ യു ക്യാൻ സ്റ്റാർട്ട്. അതപ്പോൾ ഒരു കാര്യമില്ല, ജസ്റ്റ് ഒരു 3 വർഷം കണ്ടു എന്ന് പറഞ്ഞിട്ട് നമുക്ക് സ്റ്റാർട്ട് ചെയ്യേണ്ട കാര്യം ഇവാലുവേറ്റ് ചെയ്യും. കാരണം ആസ്പിരിൻ അതിൻ്റെതായ സൈഡ് എഫക്റ്റ് ഉണ്ട്, ബ്ലീഡിംഗ് ബൂസ്റ്റർ ഉണ്ട്. അങ്ങനെ നോക്കിയാൽ സ്റ്റാറ്റിൻ ഈസ് സേഫർ ദാൻ ആസ്പിരിൻ. ഒരാൾ ചെസ്റ്റ് പെയിനായിട്ട് വന്നു, ചെറിയ 3 വർഷം കണ്ടു, നിങ്ങൾ കാർഡിയോളജിസ്റ്റ് എടുത്ത് വിടുന്നത് വരെ ഒരു പ്രൊട്ടക്ഷൻ വേണമെന്നുണ്ടെങ്കിൽ ഹോസ്പിറ്റലിലേക്ക് തുടങ്ങും.
APA members, please come back to your seats. We are starting the general body meeting. I request APA members to take tea and come back to their seats. We are starting the general body meeting.
I request all our audience members to please get back into the hall. We will start our next session in 5 minutes. This is a kind reminder to all the audience members. We will be starting our next session momentarily. Before we move on to the next session, I would like to make a small announcement regarding the RSSDI second quarterly meeting to be held on September 18th at Kottarakara. This meeting will also include scientific talks followed by e-poster and paper competition for UG and PG students.
Vishwan sir, വന്നിട്ടില്ല. Vishwan sir is there. പിന്നെ രമേശ് sir. പിന്നെ എന്തൊക്കെയുണ്ട് വിശേഷം? Going fine.
Welcome back. I hope everyone is feeling refreshed and energetic for the next session. To chair the next session, I would like to call upon Dr. Ramesh Nair, Senior Consultant Physician at Bharat Hospital, Kottayam, and our Honorable President of the Kerala Chapter of API, to chair this session. I request all the audience members to please get back into the hall. A medical teacher to be fondly remembered 30 plus years after his demise certainly speaks of the impact he has made in our general medicine community. He was the first MD medicine graduate from Kerala, and he is the founder of the first endocrinology department in the Government Medical College Trivandrum. He is commonly referred to as the big boss of general medicine, the founding father and the strong backbone of our internal medicine community in Kerala. I am speaking of none other than Dr. V.C. Matthew Roy. For his memorial oration, I would like to humbly invite Dr. Jabba P.K., another one of the greats in the world of diabetes, a professor of endocrinology at Government Medical College Trivandrum and the director and CEO of Indian Institute of Diabetes in Trivandrum.
A word about Professor Matthew Roy. Dr. Matthew Roy was a student of the second batch of Trivandrum Medical College. He hailed from Koranjeri in THIRUVALLA itself. Matthew Roy was a student of the second batch of Trivandrum Medical College, and he was the first person to get MD from Trivandrum Medical College. He also was the first person to get DCP from Trivandrum Medical College. And he had a training in endocrinology in England, and after that he had a training in endocrinology in Newcastle, England. He worked mostly in the Department of Medicine in Medical College Trivandrum, and he was the first professor of endocrinology in Medical College Trivandrum. And he is the most lovable teacher Trivandrum Medical College ever had, and he is usually referred to as teacher of teachers. And there are very few in the audience who were fortunate to be his students, and I was one of the students who is fortunate to be his students. And actually, he was the first person who initiated the APA to be started in the Kerala chapter, and he was the first secretary of the APA. So, in memorial of Professor V.C. Matthew Roy, who had a premature death at the age of 54 years, we have the V.C. Matthew Roy Memorial Oration, which is one of the most prestigious orations APA Kerala chapter is having. And for the oration, I know that. For the oration, we have none other than Professor P.K. Jabbar, who has been a good friend of mine for many, many years. He is at present the Professor of Endocrinology at Trivandrum Medical College, the post which Professor Matthew Roy was holding at the time of his death. He is also the Director of the Indian Institute of Diabetes, Trivandrum. Dr. Jabbar, please.
എന്താ പറയേണ്ടതെന്ന് എനിക്കറിയില്ല സത്യത്തിൽ. കാരണം ബിക്കോസ് വെരി സിമ്പിൾ റീസൺ. ഇന്ന് 10 വർഷം കഴിയാണ് ഡിപ്പാർട്ട്മെൻറ്റ് ഓഫ് എൻഡോക്രൈൻ ട്രിവാൻഡ്രത്ത് എസ്റ്റാബ്ലിഷ് ചെയ്തിട്ട്. എനിവേ വിൽ സ്റ്റാർട്ട് ദ ഒറേഷൻ നൗ. സർ ഈസ് ഹിയർ, റെസ്പെക്റ്റഡ് ചെയർ ആൻഡ് പ്രസിഡൻറ്റ് ഓഫ് API Kerala chapter, Ramesh sir, my teachers, Matthew Thomas sir, Sharma sir, Lekha ma'am, Vijaykumar sir, my dear friends. I'm extremely happy and feel humbled with this kind invitation. I was just thinking what to discuss today, because sir is of course he only started Department of Endocrinology at Trivandrum Medical College, and his knowledge was amazing. And he worked in all the fields of endocrinology, pituitary, adrenal, parathyroid, everywhere. So I was thinking, what topic we should discuss. So we thought, at least in our departments, took a decision that so we will present our own data, original paper from Trivandrum Medical College for this oration. So what I'm planning to do here for today, മാറുന്നില്ലല്ലോ സ്ലൈഡ് മാറുന്നില്ലല്ലോ. അതിലോട്ട് ആക്കിയിട്ടില്ലേ? ഇപ്പം മാറിയിട്ടുണ്ടോ? ഇനി കൊളാക്കോ? ഇല്ലല്ലോ. ഓക്കെ. So special thanks to patron of API, Matthew Thomas sir, Paulo sir, and other friends also. You remember these photographs, sir? Okay. Anyway, my topic, what I chose for today is adrenal insufficiency clinical challenges. This is my flow of presentation. A delayed diagnosis is a real problem for adrenal insufficiency. Last week also we had a discussion at Coimbatore. One patient planned for orthopedic surgery, need a knee joint replacement. Somebody asked for a cortisol. Cortisol reported as 0.5 micrograms per deciliter. That's very, very low. Patient was asymptomatic, totally asymptomatic, no issues at all. So delayed diagnosis is a real clinical challenge. And second point is issues related to assays, cortisol assay. We started our own laboratory in Trivandrum Medical College in endocrinology department. Then only I came to know that the challenges, assay challenges, and cost and availability of ACTH test and ACTH molecules, very exorbitant amount we used to spend for ACTH or classical Synactin. It was not available in classical market. It was available in grey market only. That too we had to give around 5,000 rupees for an ampule. Right? Okay. And diagnosis in special situation, and I'll say by after final slide. Diagnostic challenge. What I want to tell you that 40% of the patient had symptoms more than 1 year. 20%. So what I want to tell you, there is something known as subclinical hypocortisolemia for a long time. We are missing. Probably we are doing some investigation for some other purpose, probably for perioperative coverage. So at that time we are picking up diagnosis of adrenal insufficiency. All these so-called symptomatology related to adrenal insufficiency, like abdominal pain, non-specific abdominal pain, we'll put it as classical Madhu sir's comment. psychosomatic or amitriptyline deficiency, right? So we are all missing lot of case of attendance. So these things are happening in our clinical practice. Now, one important point I want to discuss, ASA has got its own problem. When my teachers or Sharma sir was practicing in Kottayam as tutor, that time we were using ELISA, probably very outdated methods. Now we have highly sophisticated, highly sensitive assays are available, and we are picking up lot of endocrinopathy. The classical issue I will discuss. Hypercalcemic disorder, hyperparathyroidism. I remember I got one patient from THIRUVALLA. So delayed diagnosis of hyperparathyroidism for a long time because see it was a laboratory issue. So we have lot of assay problems, especially hormonal assays problems in our clinical practice. So cortisol, if you discuss about the cortisol assay, there are lot of interference, lot of intermediate cortisol products which can produce assay interference. I will discuss all these points in detail. So this is very exhaustive list of assay interference, what is going to happen in our clinical practice. Okay? Now, we'll discuss a very simple case. We have a 34-year-old female. This is a phenotype of the patient. Obviously, this patient was having hyperpigmentation, which is classical of Addison's disease. Any doubt? Sharma sir, any doubt? No. Because you have pigmentation here, you have pigmentation here, not this one, right? Okay. So this was suggestive of a adrenal insufficiency. So generalized hyperpigmentation and treated with a lot of medications, including amitriptyline, all those things. Patient was menstruating normally, no history of tuberculosis to account an etiology for the diagnosis of adrenal insufficiency. What is the next investigation of choice? If you are suspecting the possibility of adrenal insufficiency, the investigations are, one is basal cortisol. If the basal cortisol is low, we'll discuss what is meant by this low. Just for the discussion, up to 5 is normal. Sorry, up to 5 is definitely abnormal. 5 to 10, we do not know where we stand. More than 10 micrograms, adrenal sufficiency state. That's clear, right? So the investigations are cortisol and ACTH as per the Endocrine Society position statement. Very clear, right? Okay, so we did investigation like this. The cortisol is reported as 0.05, practically speaking, not detected. So this patient has got adrenal insufficiency. Clear? Next investigation for this patient, ACTH. Is it clear? So ACTH reported as 1.5. What was the expected ACTH in this patient? Postgraduates, we expected sky high levels of ACTH, right? That was the expectation for me, for a clinician, because just for the first years here, if the patient has got low levels of cortisol, the ACTH will go up. This ACTH will produce a lot of hyperpigmentation. That is what is happening in the pathophysiology of adrenal insufficiency. So we were really confused. Is it a central pathology? What is the importance? Central pathology, there is no hyperpigmentation because there is no excess amount of ACTH, right? Okay. So these are the other investigation. Please note one point there. The patient has got an antibody positivity. So it's a marker for autoimmunity. And vitamin B12, it was okay to look for other polyglandular insufficiency syndromes. So everything was suggestive of adrenal insufficiency, but there was no documented elevation of ACTH. So we were really confused what to do. So we thought lot of, so always Mother sir used to tell us, in super specialty, discuss very vaguely. We don't know what is happening. So there are a lot of possibilities for these undetected or low levels of ACTH. Possibilities are bioactive molecule of ACTH. So which can produce hyperpigmentation, but you won't pick up this ACTH in your classical eclia. That is one possibility. So there are other factors, unknown substances also there which will inhibit the assay, and something known as hook effect. These are the three possibilities we considered, and we thought we'll go for investigations, further evaluation. This paper shows certain types of ACTH biologically active, immunologically inactive. Such a situation is also possible in this patient. So because of very high suspicion of Addison's disease, we thought we'll go for a diluted sample. So diluted ACTH reported as very high. So that clinches the diagnosis of adrenal insufficiency as evidenced by hyperpigmentation, low cortisol, and high levels of ACTH. That established the diagnosis of Addison disease. My dear friends, we did other investigations also to look for the etiology of this adrenal insufficiency. We presume that this could be an autoimmune phenomenon. Female autoimmunity marker was positive, that is ATP was there, and the patient has got a very atrophic adrenal gland. So these are the problems which can come up. So what I want to tell you, the take-home message is very simple. Always my teachers, Matthew Thomas sir, Sharma sir, all my teachers used to tell us clinical medicine, clinical medicine, clinical medicine, not laboratory medicine. Okay. Now second point I'll discuss, what is a cutoff for adrenal insufficiency? There are various textbooks. Some books says 3 micrograms, some books says 5 micrograms. There are a lot of controversy. Just for the discussion's sake, if you are taking 100% that indicates or strongly suggests your adrenal insufficiency, less than 5 also, probably you are in a very comfortable position. More than 10 micrograms, you can't entertain a diagnostic possibility of adrenal insufficiency. Now, these are the various forums, endocrine society recommendations. Less than 5 micrograms, yes, there's high possibility. If it is less than 3 micrograms, very strong suspicion of adrenal insufficiency. And in addition to that, if you want to make a diagnosis of Addison disease, check your post-ACTH sample also. If the post-ACTH cortisol is more than 18 microgram per deciliter, that clinches the diagnosis of adrenal insufficiency. So what is a confirmatory test? I was just mentioning ACTH test. ACTH test, there are 2 types. Of neurologist sitting over here, you have a deeper preparation of ACTH, which we are not usually used for the diagnostic purpose. You have a synactin, very costly molecule. It was around 3,000 in the INR. So it was not possible to do investigation for all these patients. Now, ACTH as a test is very simple procedure. Take 250 micrograms. Some book says, and we did a study for 1 microgram also. It was not picking up all cases of adrenal insufficiency. Take 250 micrograms, give injection, and collect the sample for cortisol after 60 minutes. That's a diagnostic test for adrenal insufficiency. Now, which is an accurate cutoff? Accurate cutoff, as per the data by Endocrine Society of Endocrinology, the level more than 18 or less than 18, that clinches the diagnosis of adrenal insufficiency or insufficiency. Now, the dosage pattern I'm not discussing because this forum probably you won't use ACTH in good number. Now, please remember in each age group your ACTH dosage is also different. Please remember that. Now, another challenge is coming up. I told you, Sharma sir, Sira, we were using classical ELISA. It was 20 or 25 micrograms as the cutoff for diagnosis of adrenal insufficiency. Now you have a clear ultra-sensitive method by which you can diagnose adrenal insufficiency even with a basal level of cortisol. If the basal cortisol is more than 14.5 microgram per deciliter, that indicates you are dealing with the sufficiency state if you are looking only for basal cortisol. Now you have different platform. Platform means a simple sentence is your machines. So depending upon the platform also, you can get changes in the basal cortisol. All these things are important. If you are in trouble, if you have clinical suspicion, but your laboratory values are not tallying, such a situation, all these points you should look into and you should discuss and you should do investigation. Synactin, I was just mentioning, synactin is a very costly investigation. Till now, probably now Sun is coming with the less costly synactin is useful. Now, cost is the major issue. It's a real issue for us. 3,000 for a patient for procuring ACTH is very costly affair, and you should do at least 3 to 4 cortisol assay also. It's very costly for a government servant or a person working in government sector. I think this is too much. Now, there are a lot of papers. This is our original work. Long-acting ACTH, of course, a neurologist's favorite molecule for the diagnosis of adrenal insufficiency. So the importance is you can reduce the cost. You can see here 1,500 and for 30 international units, okay, it's only 150 INR. So you can reduce the cost factor for the diagnosis of adrenal insufficiency. Now, we thought we'll go for the literature search again. So we got this information from Endocrine Society, and it should be noted that the acid test used in some countries, although evidence for its use much less. That's true. But still we thought we'll go for investigation, assessment or study in our department. So these are the other papers, like, a lot of papers were coming up and we got it, and finally we decided to go for synactin or actin prolongation test. I will discuss, this is one first study, this is from All India Institute of Medical Sciences. What they thought that this tip of preparation is also equally good. That was information we got it from All India Institute, and we decided to go for investigations. And we got one more paper from the Indian paper only, the Bangalore. There also they could document the actin value. Very sensitive investigation, very simple investigation. Within 30 minutes, we'll get the diagnosis of adrenal insufficiency if you are using this actin. This paper is by Nalini et al. So these are the data. And study established the efficacy of synactin plus actin. Actin means the less costly molecule, and testing the sufficiency of hypothalamus pituitary axis. So it was very useful, and this is our original paper published in the literature. This is an American paper which we published in this is Abhilash Nair, Jayagumari, Dr. Gina's paper. So we published this paper. I think she got prize also for this study. Now what we did was, we did a synactin test, and we wanted to compare the synactin test with the actin test. So I will straight away go for the information. So patient without adrenal insufficiency, the value here, serum cortisol by synactin is like this, 20, and actin is very good response. And if the patient has got adrenal insufficiency, please look at this area, adrenal insufficiency, it was significantly reduced. So this actin is very good for picking up adrenal insufficiency with 150 rupees per investigation. So it's very, very easy, and this was our conclusion. I don't want to discuss the details of the study, but cutoff was, as per the statistical method, the cutoff was 19.5 micrograms per deciliter. And this was the statistical method. Don't ask me the statistical details also. This investigation was useful for differentiating primary versus secondary adrenal insufficiency. How to, for postgraduates, my dear students, how to differentiate between primary and secondary now? See, just look into the ACTH level. If the ACTH level is high, that indicates you are dealing with a problem in the abdomen or primary or adrenal insufficiency. If the ACTH is low, that indicates patient has got a problem in the pituitary. This actin investigation was useful for detecting primary or differentiating primary from secondary adrenal insufficiency. Now a small question. Any adverse effects with this actin because of less costly, right? This is from Tattigada Lake, right? So we were having some concern, but fortunately there was no issues at all, no immunological problems. Till today, we are still practicing, we are continuing to practice this actin investigation. None of the patient had any issue. Now we thought we will extrapolate this investigation to the not only serum, to the salivary cortisol also. This is again the study from my department, Dr. Nandini's paper, which also showed very, very high yield if you are using salivary cortisol also. I'm not going to the details of all this study, but the merits are non-invasive, it's only saliva, very easy to collect, provided you have a system for that, and rapidly equilibrate with the changes in the plasma free cortisol, and stability is also very good because of many these factors. We thought we'll just change over to salivary. Now people are looking for salivary glucose also for the diagnosis of diabetes. So the things are changing very rapidly. So finally we got a beautiful result from salivary cortisol also. Now we feel that salivary cortisol is very, very useful in our clinical practice. Very non-invasive, accuracy rate is very good, sensitivity is very good, and false results are not very high in the list. So it's very useful. That was a conclusion from this study. Now, yet another area we should explore. Now, you to go to nephrology department or hepatology department. See, there are a lot of derangements in the proteins. What will happen? You will get false positivity. There are a lot of inflammatory things are happening. So all these situations like hepatology or hepatic disease or in the nephrology department, chronic kidney disease, everywhere you can get false positivity. So we thought we will do some investigation in the chronic hepatic disease also. So again, we were using salivary cortisol. Salivary cortisol supposed to be very useful and yield was very good. This is our paper that just in the publishing process only. So objectives were they compare the values of ACTH stimulated. ACTH means atom. Stimulated salivary cortisol at different stages of chronic liver disease or liver disease and prevalence of adrenal insufficiency. I told you will get false positivity, sometimes negativity also. Whether to give steroid, all those things, it's a different question. I'm not discussing that. My dear friends, this is one case. This case, again from our Department of Medical Gastroenterology. Patient is a male patient with the portal hypertension, chronic liver disease, and persistent hyponatremia. That was the triggering factor for investigation for cortisol profile. Of course, in hyponatremia, you can get in chronic liver disease also. Patient was having little hepatic failure also, and cortisol was 4.1. My dear students, immediate differential diagnosis adrenal insufficiency because the value is 4.1. Any value less than 5 microgram, you have a red alert. You should be very careful. So to rule out the possibility of adrenal insufficiency, that was the purpose of investigation. My dear friends, what is happening here? See, if you take serum cortisol, obviously see what's happening. This is adrenal insufficiency for child C category. And if you are using salivary cortisol, very sensitive investigation. Here, now see, what is the percentage here? Around 42%. Please concentrate on this point. If you are using plasma cortisol, it is 42.5. But if you are using salivary cortisol, that dropped down to 2.2%. So it's very sensitive investigation. So if you are using the bottom lines, adrenal insufficiency, if you are using serum cortisol or blood cortisol. But if you want to cleanse the diagnosis properly in case of chronic liver disease, the best investigation is salivary cortisol. So adrenal insufficiency is documented if stimulated cortisol cutoff is used in our clinical practice. And the giving steroids highly controversial. There are only two data, one French data and the approach data whereby steroid may be useful in this type of patient in critically ill patients. Now, again there are a lot of data here, lot of data for chronic liver disease in pediatric age group. There are various situations. All these investigations are really useful. My dear friends, what I want to tell you that this actum prolongatum investigation should be one of the best investigation in our clinical practice, especially in Kerala state. It's very useful, yield is very good. So I think now that's my last slide. And for adrenal insufficiency, good, there are a lot of challenges, starting from diagnosis, delayed diagnosis, misdiagnosis. Assay issues, please remember your clinical profile and laboratory profile is not tallying. Think about the possibility of laboratory or assay interference method. ACTH test is the time tested one. Synactin is the best investigation, but we have an alternative that is DIPA preparation or actum prolongatum test, which will give correct diagnosis in most of the situation, wherever, maybe in secondary adrenal insufficiency, maybe in primary adrenal insufficiency, maybe in other situations or clinical critical illness, all those things, very, very useful. Please remember, salivary or saliva is another body fluid you can utilize for the diagnostic purpose of cortisol issues, not only for cortisol issue, and good number of endocrinopathy you can pick up by using your salivary cortisol or salivary methods. And challenges certain situations already discussed, chronic liver disease and chronic renal disease also is a real problem. Okay, that's the end of my slide. This is my entire team. You can see my team. This is myself and Dr. Jayakumari, Dr. Abhilash Nair. These are all my residents. Thank you very much for the kind attention.
Thank you, Jabbar sir. Thank you, Jabbar sir, for delineating and enumerating all the clinical aspects of adrenal insufficiency, ranging from the postgraduate level to a consultant level. It was truly fascinating to listen to you, sir. I humbly request Dr. Ramesh Nair, sir, to present an award of appreciation to Jabbar sir. Let us please join our hands. I next invite Dr. Sunil Matthew sir, the organizing chairman, to hand over the prestigious Aranmulla Kannadi as a token of our gratitude, love and appreciation to Dr. Jabbar sir on behalf of the Central Travancore Physicians of India.
Matthew Thomas sir, Sharma sir, okay. എനിക്ക് എന്നെ വിളിച്ചതിന് എനിക്ക് വളരെ സന്തോഷം, എനിക്ക് വളരെ ഒരു നന്ദിയുണ്ട് സാറേ. ഐ എം ജസ്റ്റ് റിട്ടേണിംഗ് ദിസ് ചെക്ക് ടു API.
Thank you so much, dear sirs. We now move on to the first free paper session. Also kindly note, poster presentation will also be held simultaneously on the second floor. Poster presentation will be evaluated by Dr. Peter George, Professor at the Department of General Medicine, Al-Azhar Medical College, and Dr. Rajat KB, Assistant Professor at the Department of General Medicine, Government Medical College, Calicut. The poster presentation will be held on the second floor. Our first free paper session will be evaluated by none other than Dr. R.N. Sharma sir, Professor Emeritus and former HOD at not one but 3 prestigious institutes, Government Medical College, Kottayam, Amrita Institute of Medical Sciences, Cochin, and Pushpagiri Medical College, Thiruvalla. I also invite Dr. Radha T.R., Professor and HOD of Kottayam Medical College, who has also served as the past Secretary of API Kerala Chapter, to evaluate our first free paper session. At this onset, I would like to wish all the very best of luck to all the postgraduate students. The first paper session is titled An Interesting Case of Agitated Old Lady, and this is to be presented by Dr. Karthika Srinivas from Government Medical College, Kozhikode.
Good morning to all of you. We have got 5 cases. We have got 5 cases, and each one will carry a period of 7 minutes for presentation, 3 minutes for discussion. First, we thank the office bearers for giving us opportunity, to myself and Dr. Radha. Then we go to the first case.
Just a minute, timer adane.
Good morning, everyone. Good morning, everyone. I'm Karthika Srinivas, first year junior resident from Calicut Medical College. Respected faculties and teachers, this is a case of 61-year-old female brought by her son to our OPD, hailing from Calicut Medical College, from Calicut with no non-comorbidities. She came with the complaints of behavioral abnormalities for the past 1 year and recurrent backward falls and difficulty in walking for the past 2 years. History of presenting illness. She had, according to her son, she had history of difficulty in walking, which is gradually progressive and needs support to walk for the past 1 year. There was no history of weakness of limbs, and also she had history of recurrent backward falls, which was spontaneous without any warning signs, and there was no history of any loss of consciousness or any involuntary movements associated with the falls. And there was history of frequent tipping over obstacles in her path. And she had a history of behavioral abnormalities, especially in the form of personality changes, where she often get anxious and aggressive towards her family members, and she was found to use foul language without any provocation. There was no any significant past history or any medication history. So this is our patient, who is a 61-year-old female. On general examination, she had a very staring, worried expression with a furrowed brow, which is procedure sign, and reptile-like facies and masked facies were present. And other general examination finding was normal. Her vitals was normal, pulse was regular and 80 per minute, and BP was stable. There were no postural hypotension. Coming to the CNS examination, she was conscious, mental state could not be assessed. And coming to the cranial nerve examination, she was found to have a conjugate vertical gaze palsy, which was more in the upward gaze than downward gaze, and scorpial jerks were present, ocular cephalic reflexes were present, and her blink rate was reduced to 8 per minute, and her globular tap was positive. Motor examination showed tone was increased in all limbs, and there were no signs of any meningeal irritation or cerebellar involvement. Sensory system examination was normal, and she had a wide-based shuffling gait. Bradykinesia was present with axial rigidity more pronounced than the appendicular. Coming to the summary, this is a case of 61-year-old female who came with a history of difficulty in walking and history of frequent falls associated with tipping over the objects in her path, and also she had a history of behavior abnormalities in the form of aggressive behavior and often using foul language. On examination, she was found to have masked facies and reptile-like facies along with a staring look, and she was found to have a decreased blink rate and vertical conjugate palsy along with increased appendicular rigidity and wide shuffling gait. The possible DDs I consider in this case are Parkinson plus disorders, especially a possible progressive supranuclear palsy. Also, it can be other DDs are corticobasal degeneration or corticobasal degeneration or multisystem atrophy. So coming to the investigation, her blood routines, thyroid function test, lipid profile, and serum vitamin B12 were normal. X-ray and ECG were within normal limits, and CT brain showed just age-related brain atrophy. And MRI brain was done, and it showed signs of midbrain atrophy, especially the hummingbird or penguin sign, where there was flattening or concave appearance to the superior aspect of the midbrain. Actually, it should be upwardly convex, and it is under-specific, but it's less sensitive to progressive supranuclear palsy because it's a late disease pattern. And this is a, here in the image, there was the Mickey Mouse appearance of the midbrain, where there's a decreased anterior posterior midbrain diameter at the level of superior colliculus seen on the axial imaging, and interpendicular fossa to interpendicular groove is less than 12 millimeter. So here the interpendicular fossa to the interpendicular groove diameter, this diameter is less than 12 millimeter. And in the same image, you can see the morning glory appearance, where there is the loss of lateral convex margin of the tegmentum of the midbrain. So here the convex margin is reduced and become the concave in appearance, giving a morning glory appearance. So the final diagnosis is progressive supranuclear palsy or Steele-Richardson or Olszewski syndrome.
Now a discussion for 3 minutes. Any questions from the floor?
Is the pictures you have taken from the book or from the patient? Is it actual pictures?
it is for actual pictures I got from the MRI of the patient. Tau protein. Tauopathy. The patient here in the image, the patient is having an unblinking facies with the procedural sign positive, where the vertical in the globular area you can see the vertical wrinkles giving the appearance of a reptiles, and there is apraxia of the eyelids and decreased blinking, and she had a worried grimacing expression.
You are telling about square wave jerks, no? Square wave. Can you describe what it is?
When we ask the patient to fixate the eyes on an object, there's a sudden movement of the eye, saccadic movement of the eyes, and there's a pause, and then it comes back to the fixation position. This is a square wave.
In other words, it is unwanted intrusion saccades with intersaccadic intervals. Can you tell condition where there is unwanted intrusion saccade without intersaccadic interval?
In opistoclonus as well as
opsoclonus
as well as and ocular flutter.
What is the difference between the two?
There's an interval in between the to and fro motion. There's an interval in case of intrusions, that is the square wave jerks. Whereas in case of flutter and ocular flutter and opistoclonus, there is no interval. Goes and comes forward.
No, between opsoclonus and ocular flutter.
In ocular flutter, it's only horizontal component, whereas in the opsoclonus there can be torsional, vertical as well as horizontal component.
What is other name for opsoclonus? Any mania? Sarcoidomania.
What is a characteristic finding of a CBGD? You have said cortical basal ganglion degeneration. What is the characteristic or the typical presentation?
The patient will have a jitteriness or clumsiness of the hand, and often the patient will feel an alien limb phenomena where the patient does not feel the limb, or the affected limb will not be felt by the patient.
No, the one side will not know what the other side is doing. Okay. Are there any further questions?
Patient was started on Syndopa and rivastigmine, and this patient came to our OPD, and we are waiting for the further follow-up of the patient.
What is the prognosis?
Actually, the prognosis is poor, and death occurs within 10 to 12 years.
Responsiveness to DOPA?
In few patients, this responsiveness is seen, but after some time, the patient does not respond, and the disease progresses.
What is the incidence of square wave jerk?
Square wave jerks?
Almost constant. Every patient will have. Every patient. When you think of it, when the patient falls backward, patient with Parkinsonism will tend to fall forward after several years. Posterior instability comes after several years. Here it comes very early. So they fall backward and fracture. Okay. Thank you.
Thank you, sir.
Good presentation. Thank you.
Thank you, Dr. Kartika. The next paper is titled A Brain at War with Itself. Sounds interesting, right? I can't wait to listen more about it. I invite Dr. Faris K. Shamsuddin from Travancore Medical College, Kollam.
Good afternoon. I am Dr. Faris Shamsuddin, PG resident, Department of General Medicine from Travancore Medical College, Kollam. Our patient is an 87-year-old male from Kollam. He is a retired government employee by profession. The informant is his son and his daughter, and history is reliable. The date of admission is May 15th. So he is presented with a complaints of decreased response of 1 month duration, upper and lower limb stiffness of 1 week duration, involuntary jerky movement of 3 days duration. He was an apparently normal patient presented with decreased response, insidious onset, progressive over past 1 month, associated with cognitive decline and poor sleep. There is no history of any head trauma. There is no fever, headache, vomiting, loose stools, dysuria or cough. Then he developed upper and lower limb stiffness 1 week back. There is no history suggestive of any cranial nerve involvement, motor weakness, sensory impairment, normal bowel and bladder function, no history of any mood or behavioral changes. Then he developed jerky movements of upper and lower limbs, each episode lasting approximately 30 minutes, from which the patient improves, and similar episode recur twice or thrice a day since 3 days duration. There is no history of any loss of consciousness, uprolling of eyes, tongue bite or specific triggers. In between the episodes, the patient is otherwise normal. This is the upper limb and lower limb jerky movements the patient had. And he was treated outside as a major depressive disorder and was on tab, haloperidol and mirtazapine. And there is documented history of COVID-19 infection category B in March 2022. That is 2 months prior to this event. He is a non-smoker, non-alcoholic, no high-risk sexual behavior, no relevant past surgical or medical family history. No history of any travel outside state. Coming to the clinical examination, his general examination was unremarkable. On nervous system examination, he is confused, disoriented, poor sleep. On motor system examination, there was severe hypertonia of both flexors and extensors of upper and lower limb and the neck muscles, and myoclonic jerks involving the face, tongue, upper and lower limb. Rest of the examination were inconclusive. This is a video showing severe hypertonia of both upper and lower limb. His cardiovascular, respiratory and gastrointestinal system examination were found to be normal. So a differential diagnosis, delirium with multifocal myoclonus under evaluation to rule out, first one, the drug-induced extrapyramidal syndrome or encephalopathy related to due to a seizure disorder or a cerebrovascular accident, infective causes or metabolic or toxic encephalopathy to rule out paraneoplastic encephalitis or autoimmune encephalitis was made. So initially all the existing antipsychotic and tricyclic antidepressant medications were stopped, and unfortunately there was no significant clinical improvement in the first 2 weeks. The patient was started on pramipexole and clonazepam, and meticulous care was taken to monitor his temperature, blood pressure and pulse rate and urine output. This is a neuroimaging, and there was no evidence of any inflammation, ischemia, tumor or demyelination in his MRI. His electromyography has normal insertional activity with myochymic discharges of 20 to 40 Hertz. To rule out any subclinical epileptic form activity, the EEG was taken twice, which was found to be normal. To rule out the other infective causes, his blood routine, urine routine, and the CSF was found to be normal, except for a mild elevation in his protein. His culture sensitivity, herpes PCR in the CSF was found to be inconclusive. To exclude other metabolic causes, his urea creatinine were found to be in normal limits. His serum electrolytes were found to be in normal limits. There was no evidence of any hepatic encephalopathy. His other calcium, phosphorus, ammonia, and serum vitamin B12 were found to be in normal. His TSH and free T4 were also found to be in normal limits. His serum CPK was mildly elevated. So, the other cause, the paraneoplastic workup was done. His peripheral blood smear showed no evidence of any atypical cells. Serum calcium and serum protein electrophoresis showed no evidence of any myeloma spectrum disorders. Tumor markers, CE and AFE were also found to be normal. His CT chest showed no evidence of any lung malignancy, thymoma or bony mets. USG pelvis with the scrotum was done. There was only a grade 2 prostatomegaly, no evidence of any testicular tumor. Serum prostate-specific antigen were mildly elevated. No evidence of any mass lesion in the abdomen, free fluid or lymphadenopathy. Autoimmune workup. The last workup was done. ANA profile and anti-TPO antibody were found to be negative, but the serum autoimmune encephalitis panel was done, and which was positive for the Casper autoantibody. CSF autoimmune antibody workup was inconclusive. So he met the diagnostic criteria for an autoimmune encephalitis. There was subacute onset of symptoms suggestive of limbic dysfunction and new onset focal neurological deficit, detection of specific autoimmune antibody, and reasonable exclusion of other differentials. So at least 3 of the following criteria is met. So he was provisionally diagnosed to have autoimmune encephalitis. But what is the cause? We searched the international journals and the national journals papers for any relationship between the recent COVID infection and the presentation of the patient. This article was present in the recent June 2022 Journal of Association of Physicians of India, and there were also international journals showing the relationship between a recent COVID infection and post-COVID sequelae autoimmune encephalitis related to Casper antibody and also LGI1 antibody. So a final diagnosis of Casper autoimmune encephalitis, possibly due to a post-COVID-19 sequelae, was made. The patient was started on methylprednisolone and on oral prednisolone for next 2 weeks. And this is a patient after 2 weeks. As you can see there, his almost 90% of the neurological deficit has got improved. And there was a tremendous response to the steroids. So the take-home message is to have a high clinical suspicion of autoimmune encephalopathy in an appropriate clinical setting, especially in this post-COVID era, because the timely intervention has re-established the quality of life in our patient. This is a major antibodies which are documented for an autoimmune encephalitis: NMDA receptor, that is N-methyl D-aspartate receptor, LGI1, leucine-rich glioma inactivated 1, and Casper2, that is which was positive in our patient, contacting associated protein like 2, which is mainly associated with limbic encephalitis, myoclonus, memory loss, confusion, sleep disturbance, autonomic instability, with a coexisting autoimmune illness or preceding viral infection. About 70% have full recovery or substantial recovery on immunotherapy. Thank you.
It's a very interesting case, and the topic is open for discussion and questions. He has overshot the 7 minutes, so 2 minutes for discussion.
So the pulse dose steroid therapy was initially given for first 5 days, and the patient was later on changed into oral steroids for 2 weeks. 2 weeks.
When did he start improving? Even with your pulse or?
Even with the pulse therapy, almost 40% of the neurological deficit improved, madam.
Sir, comments on the
rate of relapse in the literature, what does it tell? How many patients can relapse?
So in the literature, it is said that the patient should be on the maintenance dose of immunosuppressants like rituximab or cyclophosphamide on long term to prevent the relapse. The exact rate, I don't know, sir. And he is now clinically very much better, sir. The exact incidence is not yet in the literature, sir. Yes, sir.
Yes, as you rightly said, the autoimmune encephalitis age group is not this, and we don't suspect the autoimmune in an 87-year-old male. We would have thought of a paraneoplastic or some other chronic meningitic or chronic infiltrative diseases, or some degenerations. So this COVID has opened up vistas which we never imagined possible.
So it was suggested for our patient, but due to the financial constraints, we just limited our investigations.
Is there any condition autoimmune will not respond to steroid? All the people respond, or what does the literature say?
So there are non-responders to the steroids, sir. Then secondary immunosuppressants like rituximab, cyclophosphamide, also plasmapheresis has also been tried, sir.
Describe literature.
Yes, sir.
Which tumor produces that? This NMDA receptors antibody.
So it is associated with ovarian teratoma, thymoma, and small cell lung carcinoma.
Thank you.
Thank you.
Thank you, Dr. Faris. This is for the kind attention of all the postgraduates. Poster evaluation is being conducted in the second floor of this venue. Our next paper is called Mediastinal Mass Presenting as Syncope, presented by Dr. Brinda S. from Holy Cross Hospital, Kollam.
Good morning to all. I am Dr. Vrinda, DMB resident from Holy Cross Hospital, Kottayam. I am here to present a case of mediastinal mass presenting as syncope. Syncope is a transient self-limited loss of consciousness due to global impairment in cerebral blood flow. The onset is rapid and duration is brief. Recovery is spontaneous and complete. The cause of syncope can be generally divided into neurally mediated, orthostatic hypotension and cardiac syncope. My patient is a 60-year-old male patient who is working as a clerk. Was admitted to our hospital on 20th April 2022. His chief complaint was an episode of dizziness followed by loss of consciousness. Patient was apparently normal when he woke up that day. He felt dizzy while he was combing his hair. He was standing then and fell on the floor and lost consciousness. He regained consciousness after a few seconds. The patient fell well shortly before and immediately after the event. There was no chest pain, palpitation, sweating, nausea or vomiting, visual blackouts prior to this event. There was no involuntary limb movements, urination or defecation. There was no confusion, weakness of limbs, paresthesia or headache after the event. There was a similar history 3 months ago and the patient did not seek any medical care at that time. He also gave a history of breathlessness for the last 6 months, which was insidious in onset and mainly exertional and slowly progressing. He currently experiences dyspnea while climbing the steps. He also gives a history of intermittent episodes of dizziness and lightheadedness for the same duration. He is a known case of systemic hypertension for the past 16 years and he is taking beta blockers. He is having some impairment in hearing and he is also a known case of dyslipidemia and diabetes for the past 5 years. There is no history of any heart disease or stroke or lung disease or thyroid disease in the past. His personal history and family history were unremarkable. To summarize, the 60-year-old male who is a known case of systemic hypertension and diabetes, dyslipidemia and hearing loss presented with an episode of syncope. He has history of intermittent pre-syncopal episode and exertional dyspnea for the last 6 months with an episode of syncope 3 months ago. On physical examination, the patient was conscious, oriented, moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or peripheral edema. He was febrile at the time of admission and his pulse rate was 60 per minute with regular rhythm and normal volume. His BP was 140/80 mmHg in the supine position. There was no postural hypotension. Respiratory rate was 16 per minute. Saturation at room air was 98% and DVP was not elevated. The systemic examination, including the cardiovascular system and nervous system examination, were unremarkable. So we admitted the patient and we proceeded with the further evaluation. Routine evaluation including hemoglobin, total count, platelet count were normal. The routine biochemistry panel were also within normal limits. An ECG taken showed sinus rhythm with a ventricular rate of 64 per minute and we observed an LVH with a strain pattern. His top T was negative. So routinely we took an X-ray. This is the patient's X-ray. It showed an increased cardiac silhouette with mildly widened mediastinum. So we performed an echo. In transthoracic echocardiography, we found out an extracardiac compression of left ventricle with the overall LV function was normal. So we decided to further evaluate this patient, what causes the extracardiac compression. So this was a patient's ECT. So here we can see a mediastinal. There is a mass on the left side of the chest. So the size of the mass was around 10.2 into 9 into 12.5 centimeter, which is involving the anterior mediastinum on the left side. The lesion was closely abutting the heart, causing a mild mass effect on the left ventricle. And there is a mediastinal shift to the right. The lesion shows some heterogeneous enhancement and calcifications within it. The lesion seems to infiltrate into the pericardium, likely a germ cell tumor. So we performed a CT guided biopsy The biopsy report was inconclusive. It showed only some necrotic tissues and tissues lined by mesothelial cells. Since the patient was symptomatic during the hospital stay, we planned for surgery. The patient underwent exploratory thoracotomy. During the procedure, he was found to have some variegated firm to hard mass arising from the left side of the pericardium. Infiltrating into the underlying myocardium could not be ascertained. Hence, we decided to debulk the tumor rather than removing the whole of the tumor. The tumor capsule was opened and most of the content is evacuated. The cavity was almost filled with some cheesy material and minimal blood. The multiple sections from the mass showed only some necrotic material with hemorrhage and occasional cystic spaces lined by cuboidal or flattened epithelium. So our final diagnosis was a mediastinal mass arising from the pericardium, probably a dermoid cyst. The patients likely developed the symptoms due to the compression of the left ventricle by this mediastinal mass. Our case highlights an atypical presentation of mediastinal mass as syncope and was incidentally diagnosed while workup for syncope.
Thank you. Questions?
Sir, there was no focal neurological deficit in this patient. Sir, first one was this. So this was first. So this is a chest X-ray PA view. It showed increased cardiac celerity and widened mediastinum.
So what are your reasons for cardiomegaly with the widened mediastinum?
Probably
Left hilum.
left hilum is enlarged. There can be probably a mass in the mediastinum or some cardiomegaly.
Mediastinal tumors are usually assessed, considering the germ cell origin, they are usually assessed by hormonal status to look for.
AFP.
Why was a biopsy initiated instead of a hormonal status?
Biopsy more.
No, there was a reason in your.
Sir?
The reason is there in the CT.
So this was a likely benign.
There were calcifications which are uncommon in hormonal tumors because they are fast growing. Thank you.
Syncope is related to the tumor itself. Are you sure about it?
So the patient.
How can the compression of the left ventricle produce this syncope?
Maybe.
Some postulation, irritation, producing arrhythmia. Anything was documented?
No, sir. They can be due to arrhythmias or left
Or
ventricular
is it independent? After removal of the tumor, there should not be any recurrence. That is on follow-up.
On follow-up, till now, patient doesn't develop any.
How many days after operation?
3 months till now.
That's not enough. Too short a time.
That is what Matthew Thomas has suggested. Yes.
Sir?
See, there is a left hilar mass. Sir is asking whether there was any evidence of recurrent laryngeal nerve involvement or phrenic nerve involvement. Diaphragm is almost at the same level.
Is there a diaphragmatic palsy? Evidence in the X-ray?
There is a diaphragm on the both sides is the same level.
Same level.
That is post-op.
Post-op.
Yeah.
And all the syncope was when he was combing his hair.
No, first episode was there. Second episode was during starting while he's combing hair. First episode was, he said while walking, he developed syncope.
Not while bending forward? Or
No
history like that.
What is the mechanism where the patient combing the hair? Why they produce?
Yes, he.
What did it indicate?
Any role for Holter?
Yes, any cause of arrhythmias rather than causing
No,
convulsions?
in this case, because it is infiltrating on left ventricle, maybe it will irritate some area and produce we don't know. So subclinical arrhythmia can occur, which may not reach into syncope. You have done it? Did you do it?
No, Holter.
I think should have been done.
What?
I think can close. Can close.
Pemberton maneuver pole ayipoyi alle, when he lifted his hand and combed his hair. It's like checking for a mediastinal compression. No, that was what Holter editilla. So probably we need a more detailed and prolonged follow-up to see the cause-effect relation with your mediastinal tumor. And like Neeraj said, that CT shows calcifications, so it is not a hormone tumor. Calcification of tumor is probably a dermoid cyst itself or a teratomas. Okay. Thank you.
Okay, thank you.
Thank you, Dr. Urinda. Moving on to the next paper, which is called Emoji Antibody Disease, a rare case, presented by Dr. Adira A. from Malabar Medical College and Research Center, Kozhikode.
Good morning. I am Dr. Adira, PG resident from Malabar Medical College. I am presenting a case which was recently admitted in our department under Dr. Prashov and Dr. Udayabhaskaran sir. I am presenting 49-year-old female who is a housewife hailing from Calicut, presented with complaints of numbness of the left side of body and paresthesia of the left side of the body for 2 weeks. There was no history of fever, headache, altered sensorium, weakness of limbs, visual disturbance, bowel or bladder incontinence. No history of recent vaccination, COVID infection, seizure, trauma, no similar illness in the past. Clinical examination, she was conscious and oriented, vitals were stable, higher mental functions were normal, extraocular movements were full, pupil was equal and reactive to light, cranial nerve examination were normal, fundus examination normal, motor system, bulk, no wasting bilaterally, tone was normal bilaterally, power, right side, upper limb and lower limb, power was 5/5. Over the left side, upper limb and lower limb, power was 4+. Reflex, superficial reflex were normal, deep tendon reflex were normal, plantar was extensor on left side. Coordination was normal, no abnormal movement, but there was unsteadiness on standing, no cerebellar signs. Sensory system examination, pain, touch, temperature was reduced over left side. Vibration and joint position sense was reduced over left side. There was no signs of meningeal irritation, no peripheral nerve thickening, skull and spine was normal, other systems were within normal limit. So, functional deficit, hemisensory loss, so involvement of the right spinothalamic tract and posterior column, then extensor plantar left, pyramidal lesion over right. So we came to anatomical localization, we came to localize it over right internal capsule and thalamus. Etiology, we suspected demyelination because it was gradually worsening towards the 2 weeks. So differential diagnosis, we came to central demyelination disorder like multiple sclerosis, NMOSD, emoji antibody disease, ADAM, para-infectious diseases and paraneoplastic syndrome. We came to do the investigation, the complete blood count, blood sugar, liver function test, renal function test, lipid profile were within normal limit. Chest X-ray, ECG, USG, abdomen was normal. We had done the MRI spine which showed enhancing linear T2 hyperintense signal noted in the cervical spine in the post-contrast enhancement suggestive of myelitis. MRI brain showed multiple T1 hypointense, T2 flare hyperintense foci noted in the right temporal lobe, bilateral periventricular area, bilateral centrum semi-ovale, splenium of the corpus callosum. So the MRI spine was suggestive of myelitis and brain was suggestive of white matter demyelination. We suspected demyelination disorder. And to rule out secondary demyelination, we had done the ANA profile, which was negative. Serum ACE level was normal. Evoked potential was normal. The antibodies were negative against rubella, measles, and herpes. The routine CSF analysis was normal with no cells. The CSF oligoclonal bands were negative. Serum anti-NMO antibody, aquaporin 4 were negative. We had done the serum anti-MOG antibody, which was positive. So the final diagnosis we came to myelin oligodendrocyte glycoprotein antibody associated disease. Cause in the hospital, she was initiated on methylprednisolone 1 gram infusion for 5 days. Patient symptomatically was better, numbness reduced. No visual abnormalities were noted during admission period. She was discharged with oral steroids, later which was tapered and stopped. Started on immunosuppressive therapy with oral azathioprine 50 mg OD. Now coming to myelin oligodendrocyte glycoprotein antibody associated disease. It is an inflammatory disorder of the central nervous system characterized by attack of immune-mediated demyelination, predominantly targeting optic nerve, brain and spinal cord. It is characterized by monophasic or relapsing course, which does not meet the typical criteria for multiple sclerosis or other non-neuroinflammatory condition. It occurs in the presence of serum MOG antibodies detected using specific cell-based assays. Steroids are used for the treatment of MOG antibody disease. Plasma exchange is more commonly used as a second-line treatment following steroid resistance. Now concluding, the diagnosis of MOG antibody disease is crucial to plan appropriate management since few conventional therapies used in multiple sclerosis can be harmful in MOG antibody disease. Thus, early diagnosis and treatment helps in improving recovery and minimizing disability.
So open for questions from the audience.
Interferon beta, natalizumab and fingolimod.
That affect smoke? Did it worsen smoke? Or?
It worsens smoke.
You said the differential diagnosis, the order of first you gone through the MOG and all you put first. Suppose somebody comes with a subacute onset of gradually progressing sensory and motor deficit, then limited to one side. What is your initial diagnostic priority? Will you consider these autoimmune disorders first?
No.
Then why do you put that like that?
Because as a first we tried to localize, and then because considering the patient had gradual onset of weakness progressing to 2 weeks. 2 weeks.
Yeah.
So if it is ischemic episode like that, then it would be gradually abrupt onset weakness. But this was gradually worsening, so it is more suggestive of demyelination disorder.
Okay. Why you put that in, why it's a multiple sclerosis? First, if you have thought of that, should have come first. That's a commonest disorder.
Because considering the duration, that is within 2 weeks, it was gradually worsening. And thus we had considered demyelination disorder.
Yeah, what is the commonest demyelinating disorder? Apart from the infection. Adam in this age, what is the age of the patient?
49, it is more common in children, and here she was not having any vaccination, recent infection history. So
then you, see, the is that there is no, maybe it's that what more disease and all, but when you put a differential diagnosis as a post-agit, what is common? Common things are common. Isn't it? That's the basic principle. So anywhere the differential diagnosis should come in the order what you get in the clinical. Isn't it? Your clinic history, physical examination, that will give the order of the order. Not that rare things you should first and get in trouble, especially for your examination.
Did
No, sir, we are planning to take after 6 months.
Okay, thank you. With that, we'll close this presentation. Go on to the next one.
Thank you, Dr. Adira. A final paper of the first session is presented by Dr. Ashna Sara Matthew, speaking on a case of cardiac tamponade from Pushpagiri Medical College, THIRUVALLA.
Please check it in the second session. കാരണം ഇത് പിന്നീട് ഷിഫ്റ്റ് ചെയ്തതാണ്.
Good morning, respected faculties. I am Dr. Ashna Sara Matthew, PG resident of the Pushpagiri Institute of Medical Sciences, Thiruvalla. Presenting the case of a 29-year-old male who is a painter by profession.
Timer, please.
29-year-old male who is a painter by profession with no known comorbidities, who presented with complaints of breathing difficulty, upper abdominal discomfort and generalized tiredness of 3 days duration. History of present illness is 29-year-old male presented to the emergency department with complaints of breathing difficulty, upper abdominal discomfort and generalized tiredness of 3 days duration. Breathing difficulty was acute in onset, progressive in nature and was present even at rest. No history of any fever, cough, chest pain, palpitation or sweating. He also gives history of weight loss, 8 kilograms in the past 6 months. Past history was non-contributory. Family history of tuberculosis in father. Personal history is married, taking mixed non-vegetarian diet with normal sleep, appetite, bowel and bladder habits and no addictions. Coming to the general examination, he was conscious and oriented. No pararictus, clubbing cyanosis, lymphadenopathy or edema. Pulse rate was 130 per minute, regular in rhythm, normal volume. So low volume. Blood pressure was not recordable and respiratory rate was 24 per minute. Saturation was 78% in room air. Coming to the system examination, chest bilateral breath sounds were decreased in the inframammary, infraaxillary and infrascapular areas with bilateral basal crepitation. Cardiovascular system examination, JVP was elevated with soft S1, S2 and no murmur. Per abdomen examination and CNS examination was within normal limit. This was the chest X-ray. Chest X-ray shows diffuse nodular opacities in bilateral lung fields with a with a heterogeneously enhancing lesion in the left upper and mid zone. And ECG showed a sinus rhythm with ST elevation in the leads to AVF and V2 to V6. ABG done was showing a high anion gap, metabolic acidosis and lactic acidosis. Considering the possibility of a cardiac tamponade, a screening echo was done from the emergency department, which showed evidence of pericardial effusion, collapsed right atrium, bilateral pleural effusion, and free fluid in the abdomen. He was intubated in the ED in view of obstructive shock and the impending respiratory failure. Started on noradrenaline and the dopamine infusion in view of hypertension. Then these are the blood investigations. Blood investigations revealed a leukocytosis counts of 13,800 with polymorphs 82 and lymphocyte 12. Platelet count was 1.8, ESR was 6. His PT and INR was elevated. INR was 3.89 and prothrombin time was 40 seconds. Liver function test showed elevated SGOT and SGPT, that is 5,000 and 14,300. Serum electrolytes and RFT showed a hyperkalemia, potassium 6 and acute kidney injury, creatinine of 1.8 and urea 77. We admitted the patient. After sending the cultures, he was started empirically on IV antibiotics and then we did a pericardiocentesis, which showed an exudative hemorrhagic fluid, polymorphic predominant with a negative ADA, and the pericardial fluid was negative for malignant cells. Supportive management was continued in the form of hemodialysis, IV antibiotics and fresh frozen plasma transfusion. We did a bronchoscopy for the patient and the bronchoalveolar lavage was sent for acid-fast bacilli, CB-NAT, which came as negative. And diagnostic pleural fluid aspiration was lymphocytic predominant with a negative ADA. And the patient was extubated on the day 8 of the admission. He was having persistent swelling of the lower limb post-admission. Therefore, we did a venous Doppler which showed evidence of deep vein thrombosis.
we did a CECT chest for the patient, and which showed diffuse nodular opacities in the bilateral lung fields with train bed appearances. Then and a mini thin rim of pericardial fluid was seen. Also left upper zone showing and diffusely homogeneous opacities. Then we considered a possibility of tuberculosis and malignancy. So UST guided FNAC of the lung was done, which was suggestive of malignant neoplasm, that is non-small cell carcinoma of the lung. Then we did a biopsy of the left upper lobe, which showed evidence of invasive adenocarcinoma lung with micropapillary lipidic and acina pattern, and the biomarkers like carcinoembryonic antigen and CA19.9 was elevated. Coming to the final diagnosis, invasive adenocarcinoma of the lung, malignant effusion with cardiac tamponade, ischemic hepatitis, acute kidney injury, prerenal, deep vein thrombosis of the bilateral lower limbs.
So the topic is open for questions and comments.
So actually in the emergency department, we was not able to record the blood pressure.
So that seems contradictory. Probably that was a pulse rate you got in the multipara.
Yes, sir.
So then you should say, because in clinical examination you get a pulse, then naturally you're going to get a blood pressure, be it whatever be the reading. Thank you.
Yes, sir. He was having elevated prothrombin time and INR with altered liver function test. We managed him with fresh frozen plasma, and at the time of discharge, which came back to be normal. So he was discharged and referred to RCC Trivandrum.
Why there was lactic acidosis?
So it may be due to the hypotension. His blood pressure was not recordable at the time of admission in the casualty.
Okay, later it got palpable or totally non-palpable? How many days the patient stayed?
So patient stayed for around 1 month in the hospital.
1 month? Yeah. But after that pulse did not, BP did not come back?
Yes, sir. Blood pressure after admission, it came back to normal, and he was started on noradrenaline and dopamine infusion. Then he was extubated on the day 8 of admission. He was better, but he was having this deep vein thrombosis, and he was evaluated further for the suspicious lung lesion in the left upper zone. Then he was discharged after around 28 days of admission.
What is Beck's triad? What is Beck's triad?
Beck's triad is the combination of elevated JVP, hypotension, and muffled or absent heart sounds, which typically seen in cardiac tamponade. Sir, I was not able to appreciate a pulsus paradoxus, which is characteristically seen in a patient with cardiac tamponade.
What is pulse paradoxus?
It's fall in inspiratory pressure, falling pressure during inspiration, which is characteristically seen in cardiac tamponade or in patient with exacerbation of obstructive airway disease. This is due to during inspiration, this fall is more than 10 millimeters of mercury in patients with cardiac tamponade. This is due to the bulging of the right ventricular wall into the left ventricle during an inspiration, reducing the stroke volume and the cardiac output. Okay. Sorry.
We close the session as we have run out of time. And we congratulate all the presenters for the wonderful cases you have presented. And both Sharma sir and myself thank the organizers for giving us an opportunity to share the session. Thank you, Ananda.
All are presented well, all are good cases. Thank you so much. Thank you for giving me this opportunity.
Thank you, Dr. Ashna. I request Dr. Sharma sir and Dr. Radha ma'am to hand over a small token of our appreciation and a certificate to all the participating postgraduate students. Dr. Karthika Srinivasan. Dr. Faris K. I request all the participating postgraduates to please come on stage. Dr. Faris K. Dr. Rinda S. Dr. Adira A. Dr. Ashna Sarah Matthew. Thank you, sir. Thank you, ma'am. I invite Dr. Lekha, Professor of Medicine at Travancore Medical College, to present our chairpersons with a memento to show our love and gratitude for guiding and evaluating our dear postgraduate students. Thank you, ma'am. Thank you, sir. We shall now move on to the third session of our scientific program. This session is chaired by Dr. Abdul Khader, sir, Professor and HOD of General Medicine at Pushpagiri Medical College, THIRUVALLA. Chairing along with him is Dr. K. Vijay Kumar, who is a former Professor of Medicine at Kottayam Government Medical College in Calicut and is currently serving as a Professor and HOD of General Medicine at Believers Church Medical College, THIRUVALLA. He has also served as a former President of the API Kerala Chapter and the Treasurer of API.
We are late now, so we will start with the session. Please, the first speaker, please, Dr. James. Dr. James is an intervention cardiologist working in Ards Hospital. He was my student. He had done his MD Medicine at Medical College Kottayam, DM Cardiology, Government Medical College Trivandrum, and he is Secretary of India Academic Electrocardiography Kerala Chapter, Cardiology Society of India Kerala Chapter. And not wasting too much time, please, Dr. James.
Thank you, Ramesh sir and Srihari, for this opportunity. In fact, speaking in an API meeting is always special because I always end up speaking in front of many of my dear teachers. I see so many of them, like sir said, in the podium and on the floor. So let me go straight away to the topic. That is ambulatory blood pressure monitoring. Why, when, and how to do it. Can you identify this? Even I am not sure who this is actually. Actually, this is nothing but how ambulatory blood pressure monitoring was done in the 1960s, how it was started. In fact, if you can see that the person had to inflate the sphygmomanometer cuff by themselves. So you can't call it automatic, but in fact this was ambulatory. This was how it was in 1960s. And of course it has come a long way. Now we can do it like this. And even we have apparatus which we can use it over the wrist, even though they are not as validated as the other machines. So the first question which we like to ask ourselves is, why should we do ambulatory blood pressure monitoring? It's because the most important or the most common cause is, we know that there is a big controversy between the societies. For example, ACC-AHA versus ESC and International Society of Hypertension. The controversy is regarding what is the diagnostic cutoff and what should be your cutoff or target for blood pressure treatment. So whether it is 130/80 versus 140/90, ACC-AHA for 130/80, ESC and ISH for 140/90. So leaving this controversy, there is one thing which all these societies agree upon. That is, they all agree upon the utility of what is known as the out-of-office blood pressure monitoring or out-of-office blood pressure measurement. Now we know that there are two methods of out-of-office blood pressure measurement. That is home blood pressure monitoring and ambulatory blood pressure monitoring. As we all know, home BP monitoring is the most simplest thing to do. It is easy, less costly, you can repeat it as often as possible. So why should we do this ABPM? It is because it really makes a difference in the outcome. So there are so many data. I'll just show one slide. In this study, they actually combine the incidence of, or how the blood pressure measured by various parameters, that is in the office versus home blood pressure versus ambulatory blood pressure, how was it correlating with target organ damage. So it can be seen that the evidence of target organ damage of hypertension like LVH, albuminuria, the correlation of home blood pressure monitoring was actually better than office blood pressure monitoring. You can see that here. And ABPM in fact had a much better correlation even compared to home blood pressure monitoring. So that is the reason why guidelines actually, most of the guidelines actually prefer ABPM as the most ideal way to do an out of office blood pressure monitoring. Now, what you do is often as not important as how you do it. So we should know how to do a proper ambulatory blood pressure monitoring. So that is the next part of the talk. The technique is important. Of course, we know that the apparatus has to be a validated one, of course with the correct cuff size and position. And it has to be tied in the non-dominant arm. Suppose if somebody is a right-handed, tie right in the left hand and vice versa. And better to avoid clothing in between, that is place the cuff on the bare arm, and preferable to keep the tubing around the neck and keep the device on the other side. And even more important is you have to tell the patient that he has to do his routine, daily routine. Suppose if he is going to work, he should do it on a working day. He should not put the ABPM and sit at home. So if one of us are going to do this ABPM, we should go to work like this. So we should go to work. You can see that the cuff of the shirt is raised. The cuff is on the left side because he is a right-handed person. You can see the tubings going across the neck onto the on the device on the other side. And the ideal measurement frequency, it should not be, usually it is between 15 to 30 minutes. Anyway, it should not be less than 30 minutes because at least in every 30 minutes, there should be one measurement. And it is not enough to just to tie it and leave it because we have to instruct the patients certain things. That's also important because we need to know what is the daytime BP, what is the nighttime BP, etc., etc. The patient should meticulously record at what time they are going to bed and what time they are rising, and of course if they are taking any drugs and if they are having any symptoms. The most important thing is they should record the time when they are going to sleep and when they are waking up. And they should remain still during the measurement and keep the arm at the heart level. Of course, they should not take a shower. Keep the monitor on bed or beneath the pillow during night when they sleep. But one very important thing is you should tell the patient to avoid driving. Why? Because this can be very uncomfortable because the inflational pressures usually go up to 220, 230 millimeters of mercury. So when we are driving, sometimes it can cause pain and sometimes it can cause accidents. If it is absolutely essential, it is better for the patient to pull over to the side when the measurement is happening. And even more important is also instruct the patients can malfunction and can repeatedly inflate. So this can be very painful. Patient is not going to forgive you for the rest of his life. So always tell that in case of any malfunctioning with repeated inflations, teach him how to remove it manually. And after you do it, once you start analyzing it, there are certain parameters which tell you whether you had a good ABPM study or not. So there are 2-3 criteria to see whether it is a satisfactory measurement or not. One is that we should have a 24-hour recording with more than 70% of the expected measurements should be valid. So 70% is the cutoff. So 24-hour recording with at least 70% valid recordings. It should include 20 awake recordings and 7 sleep recordings. So that is the criteria to say that this is a valid or this ABPM measurement was enough. You don't need to repeat that. And as I mentioned earlier, ideally it should be done at 30 minutes interval throughout the 24 hours. And often what we see is that just like the white coat hypertension we have, in ABPM also, if you see the readings, usually what happens is that in the first hour after you tie the machine, you have a higher reading. So this is just like the white coat phenomenon you see in the office. So what is being advised is that you exclude the first 1 hour of ABPM reading. So that is how we see whether you have a good reading or not. Now the second question is, that is how to do it. Now the third question is when to do, or which all patients should we do this ambulatory blood pressure monitoring. As we know, the most common or the most important the reason for doing this ABPM measurement is for diagnosing these two well common entities, that is white coat hypertension and masked hypertension. So what is white coat? We all know. That is, we know that around 30 to 40% of patients have elevated blood pressures in the clinic, but their out of hospital BP is normal. So you can diagnose this even by repeated home BP measurement, but in case you are doing an ABPM, we have to make sure that all the parameters are normal. That is, not only your 24 mean BP is normal, also make sure that your mean daytime BP is normal, and even more important is your mean sleep BP is also within normal limits. Only if all these parameters are met, you can say that the patient is indeed having a white coat hypertension. So when to suspect? You should suspect when you are having a patient with a mild hypertension, that is grade 1 hypertension, probably less than 160 by 100, and you expect some amount of target organ damage. You don't find any LVH, you don't find any albuminuria, his fundus is normal. In those situations, you should think that this patient may be having a white coat hypertension. And somehow it is seen more common in the elderly and also in females. So once we diagnose someone as having white coat hypertension, so should we label as white coat hypertension forever? Actually no. We have to reconfirm our diagnosis after, say, a period of 3 to 6 months. And preferably repeat yearly. But for this, actually we don't need to do ABPM yearly. We can even reconfirm by doing a good home BP monitoring machine itself. So that is also important, because someone who is having a white coat hypertension may later develop the frank hypertension. And we also have a white coat effect. White coat hypertension is in those patients who are untreated. This white coat effect is the same thing, but this happens in the treated patients. That is, when you have an office systolic blood pressure more than 20 millimeters of mercury and diastolic more than 10 millimeter above out of office BP measurement in a treated patient, that is called as white coat effect. And in fact, that is probably the most common cause of this pseudo resistant hypertension which we see in our clinics. And from this white coat hypertension, which we are all familiar, so let's talk slightly about masked hypertension, which sometimes we may miss in our day-to-day clinical practice. So what is this masked hypertension? This is just the opposite of white coat hypertension. That is, you have a normal office BP, but the out of office BP is consistently above normal. In fact, it is seen as common as in 10 to 20% of patients with normal office blood pressure. So here, any one of this, that is the 24-hour mean BP, mean daytime BP, or mean sleep BP, at least if one of them is above cutoff and your office BP is normal, that means that the patient is having a masked hypertension. Again, when to suspect this? It's just the other way around. That is, you find surprising evidence of target organ damage. You are finding LVH, you don't know what is the cause. You are finding hypertensive changes in the fundus, or you are finding albuminuria, but the office BP is normal. So that is one situation where we like to suspect masked hypertension. And also suspect this when the BP is on the higher side. It is not frankly abnormal, but the high normal BP is approved. And this is very common in patients with CKD and even more in patients with obstructive sleep apnea, because they have this nocturnal hypertension, and by the time they come to the hospital during day, their BP will be normal. This is mainly due to, as I mentioned, two reasons. One, because of this nocturnal high blood pressure and this early morning surge, because they will be having this high blood pressure during night or early morning. By the time they come to your OP, their BP will be normal. And also some persons may have workplace hypertension. Too much stress in the workplace, they are having hypertension, but in your clinic, the BP is normal. And probably ABPM, for the white coat hypertension, even a home BP monitoring is good enough. So one place where ABPM clearly scores above home BP monitoring is in the diagnosis of masked hypertension. So you can confidently diagnose masked hypertension using ABPM. In fact, it is said that There's one entity called masked uncontrolled hypertension also. That is in treated patients. Just like white coat effect, in treated patients we call this masked uncontrolled hypertension. In fact, there is data saying that the incidence is as high as 40%. So how to diagnose? We know the diagnostic cutoff of ESC. So this is the ESC 2018 guideline. We know that the cutoff of BP, for blood pressure for diagnosing someone as hypertension is 140/90. So what is the corresponding ABPM values? Here, the mean 24-hour blood pressure, the cutoff is 130/80. So mean 24-hour blood pressure of 130/80 is actually equivalent to 140/90 office blood pressure. The daytime mean BP, equivalent BP is 135/85, and the nocturnal mean BP equivalent to this 140/90 is 120/70. So 120/70, 130/85, and 130/80. That is the ESC 2018 guidelines. Of course, ACCH guideline, it is slightly lower, but we know that it is a slightly aggressive guideline. So basically, we all, I think, practice more of ESA guideline. So that was regarding when we should do. Now, another important aspect is how to identify abnormal BP patterns, because so many abnormal 24-hour BP patterns have been described. So this is the normal BP pattern. The third line from above, that is the orange line. So this is called as the dipper pattern. So what is this dipper pattern? This means that the nocturnal systolic and diastolic BP fall approximately 10 to 20% of the daytime values. That is, if you take the ratio, night mean BP by day ratio, it is less than 0.9. That is, there is at least 10% fall, but the fall is not greater than 20%. That is the normal dipper pattern. Now there is something called a non-dipper pattern. So what is this? Here also there is a fall, but the fall is less than 10%. That is 0 to 10%. So the ratio is obviously 0.9 to 1. So this is actually seen in almost 20% of patients with hypertension, and they do have an increased CVD risk, and the risk of stroke is as high as 23% when compared to a dipper. And it is seen more in patients with target organ damage. Now from this non-dipper, we have something called as the reverse dipper or the riser. Here in fact, the blood pressure actually rises in the night compared to daytime BP. So the ratio, obviously, the night by day ratio goes above 1. It has also got a very strong association with CVD. So non-dipper and reverse dipper. So those are two situations where you have got a very strong association with cardiovascular disease, especially stroke. And there is something called extreme dipper also. So that is, they dip more than 10%. More than 20%. So the night-day ratio is actually more than 8. Here actually, we don't have any strong evidence that it is linked to higher incidence of CVD, but it is controversial. And there is a normal morning surge also. We can see that is on the third, it's the orange line, that is the normal morning surge. Sometimes we can have an exaggerated morning surge. That is, within 2-hour period, the difference between the highest night BP and the blood pressure within 2 hours after awakening. So if it is exaggerated, that means that you are having a exaggerated morning surge. This has also got some incidence, some relation to higher incidence of stroke. So the second last session, that is from coming to this different patterns of nocturnal, different patterns of circadian changes in the blood pressure, whether does it help in our day-to-day clinical practice? Of course, you can diagnose hypertension, you can diagnose masked hypertension, you can diagnose white coat, you can see these different patterns, but does it, can we tailor our treatment based upon this pattern? In fact, we can. Suppose if someone is having an early morning surge, so what should be our ideal drug? Or what can we do about this? One thing is, as we all know, now people are moving from morning dose to night dose of antihypertensive if you are using a single drug. So if someone is having a morning surge, what you can do is, if the patient is on a single morning dose of antihypertensive, you can switch that to night dose or make an OD dose into BD dose. And we also know that this early morning surge is the mechanism is due to increased activation of the sympathetic system and RAS. So if you add a bedtime beta blocker or a bedtime RAS blocker, that is an AC inhibitor or ARB, that is the best drugs to tackle this early morning surge. Again, because of the sympathetic activation, bedtime alpha blockers and central sympathologic drugs are also effective. We have to remember that diuretics are not effective for this early morning surge. So other drugs, you can choose between the other drugs for tackling this early morning surge. And what if the patient is having nocturnal hypertension or reverse dipping, or if he is a riser, then of course we can change over to bedtime or twice daily dosing. Again, RAS is active during night, so you can take bedtime dose of RAS. Diuretics are useful in this situation, that is reverse dipping. Diuretics may convert a reverse dipper into a dipper. Alpha blockers are also useful. Of course, we have got other indications like OSA, CKD, ambulatory hypertension, dysautonomy, etc. So these are broadly the indications where we do ambulatory blood pressure monitoring. So that part is over. Now we have done the ABPM. Now the technician gives the report. Now what should you do with the report? Because this is one usual report which we have. So you see what percent of measurements are valid measurements. Here we can see that 93% measurements are valid. So that is a good enough ABPM. You know what is the active period, that is active when the patient was awake. You know what is the sleep period. They will give you the mean 24-hour systolic and diastolic blood pressure. So with this you can diagnose whether the patient is having hypertension, white coat, mast or anything. They also give active and passive period data separately, that is the daytime and the sleep BP. Again you can have the mean pressures. So again you can diagnose nocturnal hypertension, mast hypertension, whatever. You can see for if there are any incidents of any dangerous hypotension. And then there are few indices. That is, one is diurnal index. That is just like what I was mentioning. You can diagnose dippers by this. This is nothing but just a mathematical calculation. Mean day BP, the difference between daytime BP, nighttime BP divided by daytime BP into 100 doesn't make any difference. You can assess the morning surge. So all these parameters will be in the report. Then there are 2-3 other parameters which I'm sure that Matthew sir is very interested in. He used to ask me long back. So one such pattern is percent time elevation, that is PTE. It is also called as the hypertensive time index. This is nothing but the proportion of time, that is percentage of time. So in this 24-hour, what percentage of time was the patient having a high BP? So this actually gives you the load induced by the blood pressure on the patient's target organs. You also have something called a BP load, that is the number of recordings which are above normal. So this is another way which you can assess the blood pressure load on the given patient. But the best measurement is, that is something called as the hyperbaric impact or hyperbaric area index. This is nothing but, suppose if you see this graph, the shaded part, you can see two flat lines. That is, the two flat lines are the normal cutoffs. You can see the shaded part. So this shaded part is actually the hyperbaric area or index. So this gives the best index of BP load on target organs. And the unit is of course millimeter mercury into hour. You can analyze the trend. So here you can see on the, you can see two green lines. That is the day and night cutoff. So we can see whether our BP is going above that. The red lines are the individual readings. On the bottom part, you can see the mean BP given as a smooth curve. So we can analyze the trend. For example, in this, if you see the mean BP recordings are actually within normal limits. It is not going beyond the cutoff. You can see a normal dipping pattern. So this is nothing but a normal ambulatory blood pressure monitoring report, and the patient is a dipper. That is, it's a normal report. And what about this? You can see that we can see two gray lines. So those are the cutoffs. You can see that it is the upper line is above the upper graph. That is, systolic is above the upper line, and the diastolic is above the lower line. So it is clear that the mean BP value is above the cutoff. So the patient is a hypertensive. And you can see there is a non-dipping pattern. There is no nocturnal dip. So this is a hypertensive non-dipper. And of course, there are some complex calculations for assessing BP variability. There is a lot of controversy whether it is good or not, but we often do not usually do it. So that is when to do it, how to read the data. So I will leave you with this message. This is by the great Italian cardiologist, or one of the great experts in hypertension field. He was the previous president of International Society of Hypertension, Italian Alberto Zangetti. He said it is paradoxical that a condition like hypertension, which is actually defined or diagnosed in terms of blood pressure value only, we are actually measuring it casually just based upon one or two random blood pressure measurement. And in fact, maybe even a lifelong treatment is often instituted based upon these measurements over a few minutes. So to summarize, I'll say that ABPM is an invaluable but grossly underused tool in hypertension management. So just like the Nike ad, we don't have any excuses, we'll have to just do it. Thank you.
Thank you, sir.
Thank you very much, Dr. James, for the excellent presentation. So far, we thought that we are treating the hypertension with our office measurement, and we were happy. Now, regarding when you talk about the ambulatory measurement and all, now it is very difficult for me even to take a decision whether I should treat a hypertension or not unless I get the classical target organ features. So my question is how it is feasible to make ambulatory monitoring for every patient we suspect or diagnose hypertension.
We don't actually we don't need to do it for every patient. In those patients in whom you suspect that there is a chance that this patient may be having a white coat, rather than starting straight away with drugs, then you can try ABPM. Or you find, as I mentioned earlier, evidence of target organ damage, but you feel that the BP is not high. That is again one situation. And even more common situation is uncontrolled hypertension, or situation where you are finding that the patient, you have been following up the patient for a long time, and over the years patient is developing multiple target organ damage. The patient is developing LVH, albuminuria, you don't know what's happening. So that is again one situation. You don't need to do that in all patients.
Few questions, shortage of time.
No, in the non-dominant arm. Suppose if you are left-hander, preferably in the right.
Then would you advise, like in a busy schedule, even if you are supposed to take BP in both arms, normally you take it on the right hand. For the normal BP.
Okay.
So would it be preferable that you do that on the non-dominant arm?
You
mean routine we take it in the right arm.
Right arm, okay. Conventionally, I think that is the way. Why this is because you will be using the right hand when the BP is measured, because you don't know when the BP is going to be measured. So you may be using that and suddenly the apparatus is measuring, and so that may give an erroneous higher value. That only. That's all the reason. Because that is because probably the tubings and the connections, it is much better if you, rather than you put directly across, it will be, the tubing will be more stable and the connections will be more stable if you go. In fact, many of the senior cardiologists I have seen while doing echo previously, they used to put this echo, the wire of the echo probe across the neck, because the connections are more stable if the tubings goes like that.
Any comments?
Thank you. It was a very crystal clear demonstration. It was like reading a review article. He was my senior. Thank you so much. The point that you raised is very valid. I think for normal BP office monitoring, we use the dominant hand. That is what he asked, right? I think that is to improve the detection rate of hypertension, because normally up to 10 millimeter of BP can be higher on the right side. So if you use routinely on the right side, you are more likely to detect hypertension. Maybe you will overdiagnose, but then that is where ABPM comes in. And two other, you mentioned almost all the indications. Two important areas. One is people who have suspected orthostatic hypotension symptoms, especially elderly, which are very common in our locality. So many patients complain that they get symptoms, and when they check the BP, the BP is very low. So even for that, it may be useful. Another thing is to prevent over-treatment of hypertension in pregnancy.
Correct.
Because we shouldn't go to knee-jerk treatment of hypertension in pregnancy. So especially because we know that many of the drugs that we commonly use are contraindicated in pregnancy. Many require monitoring. Many have adverse fetal outcomes. So we should be doubly sure when we treat somebody for hypertension in pregnancy, and routinely should be recommended. Thank you so much.
I think there are two great points. Especially the first point is when someone, based upon just high BP in the clinics, it may be a white coat effect, like Sarjan said. You increase the BP, there is high chance that, especially in the elderly, they may develop a fall after developing a hypotensive episode. So, and in fact, Sarjan has wrote a beautiful article for, I think, CSI. He and Dr. George Koshi sir has wrote a beautiful review article on ABPM. In fact, I have borrowed some points from his article also. The two most common mechanism is that is nocturnal hypertension. That is, the patient is having high blood pressure during night. It can be a non-dipper, it can be a reverse dipper or riser. So that is one group. Second is early morning surge, because these two parameters you won't be picking up in our usual office BP recording. The third subgroup is workplace hypertension, which may be less common. Most importantly, and one point which I forgot to mention is that the importance of this nocturnal hypertension, it has been documented in multiple studies that the target organ damage, mortality, CVD events, everything actually correlates more with your mean night BP compared to daytime BP. Suppose if you get a risk factor based upon your mean night BP, your mean daytime BP is not going to add beyond that. But your mean nighttime BP is going to add whatever is the risk given by your mean daytime BP. So that is one importance of ABPM, because ABPM is the only way by which you can diagnose this nocturnal hypertension phenomenon. And like sir asked, I think why masked hypertension is important or why is it being missed is because you can't have the nighttime recording.
That's always continuing. It's a joke said about mass hypertension. When they are at home, they will be having hypertension. When they are at office, they are relaxed. We'll wind up the session, first session, because of shortage of time. We can have personal questions. Okay, we will go. Thank you.
Thank you for the invitation.
Thank you, sir. I'm sure we are all looking forward to practicing ambulatory BP monitoring for adequate management on our patients. I request Abdul Khadir sir and Vijay Kumar sir to present Dr. James Thomas with a memento of appreciation to convey our gratitude and to show our respect for his participation in this conference. Thank you, sir. I have been informed that the receipt books made for this conference has been misplaced in one of the conference files distributed to our delegates and audience. May I please request all of our audience members to please check their conference handouts to locate the same. If found, please hand it over to the MC desk. Thank you for your help. The second topic highlights the best practices in management of acute adenolymphangitis of lymphatic filariasis. I request Dr. Suma TK to introduce this topic. She is the Principal and Director of the Filariasis Research Center Unit, WHO Collaborating Center for MMDT in Lymphatic Filariasis, Government Medical College, Alappuzha.
Good afternoon to all. First of all, I thank the organizers for giving us the opportunity to chair this session. I am very much happy to chair this session because the presenter is my own classmate, my own colleague, and so I am very happy, and I don't think that anybody in this crowd is unfamiliar with Dr. Suma. So Dr. Suma, to me, is not only a classmate, she is a colleague, and I have to say that she is one of the stalwarts in the field of medical research in state of Kerala. When we know that in the olden days we are giving more importance for the patient care and probably students teaching, research was kept aside. But at a time, even at 80s and 90s, Dr. Suma, definitely under the training under Mathura sir, and after that, when she shifted to Alappuzha, Dr. Shenai, they made a change especially in Alleppey Medical College, we saw a surge of research papers in the field of filariology. I should say filariology. So not filarious. Only, and they gave excellent papers, research, and which was a model, world model, came in various journals, and the WHO has recommended their many proposals, and I was witnessing, though not actively involved, I myself and Lekha, all were witnessing her. So with these words, I asked Dr. Suma to present her case, and that is one of the most interesting part of her research, that is the adrenal lymphangitis. Back to Dr. Suma.
Thank you, Dr. Khader and Vijayakumar sir, for the nice introduction. Senior colleagues of the senior members of the profession, colleagues and friends. I am venturing into a neglected tropical disease. I know that neglected tropical disease are always being neglected. And I am very thankful to Dr. Neeraj for giving me this opportunity to present this topic, which appears very simple but has a lot of clinical implications and also sometimes mismanaged also. So this is a great opportunity where I can discuss with you a very common problem. Now in the outline, the coming next 20 minutes or so, I will be just touching upon what are the neglected tropical disease, what is acute adrenal lymphangitis, and what is the basic pathogenesis and pathology of lymphatic filariasis, clinical presentations of acute adrenal lymphangitis, treatment and lymphedema management and impact of lymphedema management, and along with what is the importance of, for a person with lymphedema or LF, lymphatic filariasis, what is the importance of this acute adrenal lymphangitis. I'll start with, there are 20 diseases identified by WHO as neglected tropical disease, and in that there are ectoparasites, disease involved by ectoparasites, protozoa, virus, non-communicable disease like snake bite, fungal infection, bacteria, and helminthiasis. And the recent additions were the scabies, rabies, dengue, and chikungunya, and snake bite. So among the helminthiasis is the lymphatic filariasis, which is endemic in 11 out of 14 districts in Kerala. The 3 districts which are not there is Wayanad, Pathanamthitta, and Idukki, because the vector is not there. But still there are patients seen with lymphedema there. So this case history, I think most of you might have came across such a case history. 60-year-old male patient with history of fever since 3 days, high-grade fever associated with chills and rigor and vomiting and pain in the right leg. Past history of swelling in the right leg since 10 years and history of similar fever episodes in the past. During these fever episodes, high fever associated with chills and rigor, vomiting, stupor, altered sensorium, etc. Pain and redness and swelling of the right leg, and after admission to hospital, patient becomes better in 2 to 3 days. After the episode of fever, there will be an increase in size of the swelling. So I think everyone might have come across this patient. This is maybe presenting as just like a cellulitis or maybe an infection or a fever for a short period of short fever like. And this is typical of acute adrenal lymphangitis, or what is called as acute ADL or acute attack. Because in this, all those people who are working in this disease, they know that the implication, the problems which can occur when there is an acute adrenal lymphangitis, and as the prognosis of the disease as well. So this is acute adrenal lymphangitis, which is otherwise known as acute ADL, and in the patients usually they say it as the acute attack. So what is acute adrenal lymphangitis? That is the commonest acute manifestation of lymphatic filariasis or LF. Usually we know that they come with the chronic manifestation like the lymphedema and hydrocele, and this is the commonest acute manifestation which usually brings patient to the hospital. It is an acute inflammation of the skin, lymph vessels or lymph glands associated with bacterial infections, often accompanied by pain, fever, and swelling. So it is a bacterial infection, and there is inflammation of lymphatics and lymph glands. And what is the importance of acute adrenal lymphangitis? Before saying that, I just wanted to bring your attention to the pathogenesis or the basic pathology in lymphatic filariasis. Usually the chronic manifestations are, as I have already said, the lymphedema and hydrocele. So when the mosquito drops the infective larvae on the skin of the person whom the mosquito has bitten, the larvae, which is called as the L3 larvae, find the spore and enter into the body. And it enters into the lymphatics, and then it becomes the adult worms. And the area of the adult worms more commonly seen in males in the inguinoscrotal area and also in the axilla and epitrochlear area, which is not very common but can also occur. But in females, the most common site is the axilla and epitrochlear region, and also in the breast and in the inguinal region also. So the adult worms live in these lymphatics and produces the basic pathology of lymphatic filariasis, that is the lymphocyte dilatation. It causes the adult worms, many of them live as nest. One nest sometimes may be having 40 to 60 adult worms, and these adult worms produce the dilatation of the lymphocytes. Actually, lymphocytes have a unidirectional valve where it directs flow from below upwards. So when, as in case of any dilatation, when there is a dilatation, the valve becomes incompetent. So when the valves become incompetent, there will be collection of fluid. And this collection of fluid produces the lymphedema, and when there is a collection of fluid in the scrotum, that results in hydrocele. And usually the lymphatic filariasis is said to be a disease of childhood. The infection first start in the childhood, and we have seen microfilaria positive even in children of 2 years. And it takes 10 to 15 years for the lymphedema or hydrocele to manifest. So it takes a lot of time to develop into the lymphedema and hydrocele. And so with the collection of the fluids, the patient may get lymphedema or hydrocele. No, why do they get the adenolymphangiosis? Because that's a common problem which brings the patient to the hospital and has a lot of suffering which happens for the patient. Usually in lymphatic filariasis with lymphedema, there will be skin changes. You can see that in, can I use this? Here there is lymphedema, mild lymphedema, but not much of skin changes. But when here also there is lymphedema, but there is not much of a skin changes. But at this stage, these are staged, but I don't want to go into the details of that. This is called as a stage 3, where there is a fold. This is called as a shallow fold, and there is thickening of the skin. And this is deep folds are there, and the skin is thickened, and there will be a lot of skin changes happening. And similar to this, anybody can understand that having multiple nodules, and even if you rub it or wash it, there could be an abrasion happening for this patient. So all these skin changes can occur in a patient with lymphatic filariasis, and because of these lymph changes, that they easily break. So when there is a break in the skin, that allows entry of bacteria into the body, and these lesions are called as entry lesions. So the entry lesion means it is any break in the skin that allows bacteria to enter the body. And this often occurs between the toes or in deep skin folds and through wounds on the surface of the skin, such as cuts, scrapes, and scratches. So cuts or small injury, maybe a thrown prick could be a entry lesion, because if you have a normal person with a normal intact skin and also a normal lymphatics, it will not produce any problem, and that even if the bacteria enters, that will be removed by the lymphatics. But when there is a lymphatic damage, that will produce the acute adenolymphangiosis. I am coming to that later. So all these are the cuts, small the breaks in the skin, and the insect bite, fungal infection, all could be you can see the wound there, then small abrasion. This is the interdigital fungal infection, candidal infection. This patient has a small abrasion here that is responsible for an acute adenolymphangiosis. This is also acute the interdigital candidiasis. So all these are entry lesions. And normally we know that lymphatics is a defense system of the body. Lymphatic damage leads to impaired transport of bacteria to the lymph nodes and region, reduced ability of the body to fight infection. That is why they get the infection. And moreover, lymph fluid is a good medium for bacterial growth, because there is lymphatic dysfunction is there, and there will be what is called as lymphangiectasia, the dilatation of the lymphocyte, and there will be collection of lymph. So once bacteria enters into the body, they thrive better on the lymph fluids. So they get the bacterial infection. And bacteria multiply, causing painful acute attack. This is a picture which we have looked at the acute adenolymphangitis seasonally, but that is every month. We have charted how many acute adenolymphangitis are occurring in patients, and we have found that it is more during the rainy season. We know that for us in Kerala, it is from June up to November, it is rainy season. What happens is that when these patients wade through water, they have thickened toes, so it will be opposed together, and there won't be any air between. So the water gets accumulated there, and that will lead on to fungal infection. And once the fungal infection is there, fungal infection per se will not produce an adenolymphangitis, but when the fungal infection is there, they tend to scratch. That will produce a break in the skin, and through that break in the skin, the bacteria enter. So during rainy season, it is very common to see acute adenolymphangitis. So what is the clinical presentation of acute attacks? That is, we all know that what happens when there is an acute inflammation. The patient can have fever, headache, vomiting. There will be increased swelling of the limb. There could be pain and tenderness, and also there could be, sometimes it could be depending upon the organism which is involved or severity of the illness. Patient can also have altered sensorium, or maybe having the drowsiness, and all those things can occur. And when the most important thing about ADL is that the bacterial infection, which is found to be more commonly streptococci and staphylococci, we also have done a study in our center, and it is found that the commonest organism is streptococci, but others can also occur. When a person gets recurrent episodes of ADL attack, the lymphedema increases. Each episode, during the episode, the size increases, the edema increases, and when they get recovered from that, some edema remains. So when they get few episodes, recurrent episodes, the edema increases, and even it can progress to elephantiasis. And so it is very important to promptly treat, not only to treat, but also to prevent further episodes of adenolymphangitis. That is to reduce the suffering of the patient and also to prevent progression of the lymphedema. So treatment of acute attack, because it is a bacterial infection, antibiotics is the first line of treatment, and it should be good coverage for streptococci and staphylococci. And if the patient has other comorbidities and all that, it could be a high, they might be needing a high-end antibiotics, maybe because the organism could be different. We had a patient which I showed with a injury in the toe, and that patient had an MRSA, and we have treated him with vancomycin. So anything can be, but usually it is a streptococci or staphylococci. And there should also be symptomatic management like analgesics, anti-inflammatory medication, and antipyretics and antiemetics whenever it is needed. Supportive measures are very important because they should not be working when they should not be walking around when they have the acute adenolymphangitis, because it will take a lot of time to recover, and also the pain increases. And the legs should be elevated, and the hydration should be taken care of, and if possible cooling of the affected areas, one of the things which will give relief to the patient. And management of ventilation. If there is an acute interdigital candidiasis, that also has to be treated, but because if it is not treated and if it is remaining like that, the patient may go to another episode of acute adenolymphangitis at any time. So this is the treatment for the acute attack: antibiotics, symptomatic treatment, supportive measures, and management of end relations. Now, the first line of treatment is penicillin group of drugs, because the streptococci is found to be the commonest organism, and if there is a possible staphylococcal etiology, the treatment should be given. And usually the patient becomes better with these, if these organisms are the responsible one, usually they becomes better with 5 days of treatment. And depending on the severity and associated comorbidity, high-end antibiotics may be needed as per the antibiogram or the antibiotic policy. But more important is early detection and treatment is important, because we train the patient how they get the acute infection, or how it's going to start and all that. So patients usually will say that I'm going to get an acute attack, because initially there will be a fever. Maybe there is a slight difference in temperature between the legs. Even without further manifestation, they will be able to say that. So the early treatment detection and treatment is very important. Now, this is one of the point I wanted to say it, and everybody should be taking this up, that is use of antifilaриal drug in acute adrenal lymphangitis. I know that even in our medical college, if the patient is admitted with acute adrenal lymphangitis, the first drug which may be given is the DEC and albendazole or DEC alone. But, in case of lymphatic filariasis, the use of DEC, albendazole, ivermectin is only in 3 situations. One is when the person is detected to have a microfilaria. By night blood examination, accidentally or in a cam or anything, if the person has a positive microfilaria, there they need antifilaria treatment. Then evidence of adult worms. The evidence of adult worm could be a presence of antigen, or sometimes superficial ultrasonography may bring out what is called as the filaria dance sign, which is due to the live adult worms, or as part of LF elimination program. Only these 3 situations, DEC, albendazole, ivermectin will be helping a patient with lymphedema. Because usually the lifespan of adult worm is 5 to 6 years. I have already said that the infection starts in children and the lymphedema occurs more than 10 years after the initial infection. So by the time the patient develops lymphedema, there won't be any adult worm or microfilaria present in the body. So then there is no point in giving drugs which will be acting on the adult worms or the microfilaria. We have looked at about 2,900 patients with lymphedema for microfilaria, and we could detect it only in 1 patient which is an early lymphedema. So other studies in other places also say that there is evidence that there is no adult worm or lymphedema adult worm or microfilaria in persons with lymphedema. So antifilaral drugs won't help, and use should be avoided. So now I have said that it is not only the treatment of acute adrenal lymphangitis, but prevention is very important. Why should we prevent it? I have said that the ADL hastens progression of lymphedema. It causes suffering for the person. It causes financial constraints for the patient. So the prevention is to alleviate suffering of persons affected with LF, to reduce or avert progression of lymphedema, to prevent economic constraints on the patient, to prevent out-of-pocket expenditure, and to improve quality of life of the persons or family. Because when the acute adrenal lymphangitis are prevented, they'll be able to work, they'll be able to look after the family. So the whole family, the life improves. For the person also, the life improves. So that is very, very, very important, that we should advise the patients and the family how they could prevent acute adrenal lymphangitis, and that will increase the quality of life of the person. And there is a WHO essential package of care for the morbidity management of the patient that includes the treatment of acute attack, management of lymphedema, management of hydrocele, and treatment of remaining infection. I'll just say about what is meant by the management of lymphedema. Management of lymphedema, or there are 5 measures for managing lymphedema, even without acute adrenal lymphangitis. These are simple measures done daily by patients, and if needed could be helped by family and friends. What we have seen is that in this lymphedema management, if the family helps or the friends help, there is a great advantage. The advantage is that there reduces the stigma. We know that the patients with the lymphedema has a lot of stigma, and they have a lot of problems, social, psychological, many problems are there apart from the physical problem, and the stigma could be avoided when others also try to help them. Otherwise, previously, there will be always social exclusion, and they will not be talked into, and they were not accepted as a family member. So by doing this, we have seen that the stigma has been reduced. So the first one is the hygiene. The hygiene is that every day the person has to wash the limb below the knee, lower limb below the knee, morning and evening, and if at all that's not possible, in the morning itself or evening itself, and dry the leg after the wash, so that there is any dirt or any, they can look for any injury lesions, and that could be managed. Then after the washing and drying, they can apply the antibiotics, whether it is antifungal ointment or antiseptic ointment, depending on the situation. Second one is skin and wound care, where because we said that even minor injury could be a end relation for producing an acute adrenal lymphangitis. So they should be careful to avoid injury. So for example, it's a farmer or a manual laborer, their work itself can make them prone to injuries. So they should be advised that they should be very careful not to injure their legs, and also taking care of the end relations. If there is if there is a fungal infection, they have to carefully use the antifungal ointments throughout till it is subsiding. And the third part is the exercise. There is some exercises which we advise to increase the flow of the lymphatics, but they are simple ones, and any patient will be able to do. One is the holding on to something. They have to raise on their heel, and after that they have to raise on the toes also. Tip on the toe, that's called as the standing on the toes, and also the standing on the heel. That is said to increase the flow of the upward flow of the lymphatics. But always the careful thing is that they should be careful that they should be holding on to someone, because there may be imbalance because of the size of the limbs. One may be large and the other one may be small, so they should not trip down, and so always they have to hold on to something. And then other thing is that the dorsiflexion, we won't tell the patient like that, but the dorsiflexion and plantar flexion at the ankle level, and also the circular motion at the ankle. These are the three simple exercise we always say the patients to perform, and the best time is when they get up in the morning. Then the elevation of the limb. Elevation of the limb is also helping them to drain draining of the lymph flow. And at any time when they are sitting, when they are slicing the vegetables, or when they are breastfeeding, or when they are sitting, they can keep the leg elevated on a stool or something, and every time that can be done. And during night they can use the pillow. But usually what happens is, if the pillow is kept on over the mattress, during sleep it may slip off, then it may not get a correct effect. So what we advise is, those who are using the mattress, the pillow should be kept underneath the mattress, so that during the entire sleep the leg will be in the elevated position. That is the exercise. Then wearing of suitable shoes. We say suitable shoes because we know that it will be difficult for a person to get the usual shops which they get from the shops, because both the leg will be of different size, so they may not be able to use. But here what we tell them is that they should use the shoes which is not very tight. It should not be producing the shoe bites, or it should not be very much closed, so that there will not be any aeration, and fungal infection could be there. So it should be most important is it should be a custom-made shoe, but that may not be possible by all patients. They may not be able to get it done by a cobbler. But in our program, we get it. But many of the patients prefer their own contraptions which they use. But they are not very happy with the shoe which we make and give it to them. But that is, whenever they are wearing, it should be comfortable. It should not produce any aberrations. It should not be too tight. So the objective of lymphedema management is not completely cure lymphedema, because the higher grades of edema may not completely cure, but it improves the lymphatic flow and skin integrity. That is very important. So it reduces the frequency and severity of acute attacks, and prevent lymphedema progression, and improve patient function and quality of life. So that is why I said, when we come across a patient with an acute adrenal lymphangitis, the treatment doesn't stop with treating that episode of adrenal lymphangitis. Always we should be able to advise them how to prevent it. And the prevention is with the very simple measures, and they'll be able to prevent it. And we have done, in many of our studies, we have followed up the patients, and we have found that when they are doing it, because they get the benefits, so they know that it is beneficial. So continue to do that, the lymphedema management, and the frequency of ADL attacks comes down, and also the severity comes down, and that improves the quality of life of the patient. This I think I hope. So usually when the patients follow these, what happens is there is a clinical effect and a psychosocial effect. because the decreases the prevalence and severity of entry lesion. So the number of days they are not able to go to work comes down. They'll be able to make money or make the living for throughout the month, and lot of advantages they have, and the stigma will be reduced and reduced incidence of acute attacks, lymphedema regression or prevented progression. And economically, there should be savings, and there may not be an out-of-pocket expenditure when they get the acute attacks. So the take-home message here, what I would like to say is that acute adenolymphangitis is a bacterial infection, and the skin changes in lymphedema lead on to increase in number of entry lesions. Lymphatic dysfunction favors growth of bacteria, and whenever there is an ADL, that hastens progression of lymphedema. And prompt treatment and prevention of ADL are important. Antibiotics is the mainstay of treatment, and antifilaral drugs should not be used for treatment of ADL. Lymphedema management reduces the ADL and improves the quality of life of the persons affected. Thank you.
You have not mentioned about Wolbachia association with, because it gives a scope for antibacterial treatment prolonged. So 4 to 6 weeks they are recommending all the textbooks. There is a rickettsial.
I wanted to answer that in 2 points. One is Wolbachia is an intracellular parasite in the adult worm. So I was trying to say that when the patient develops lymphedema, there will not be any adult worms. So in case situation of an acute adenolymphangitis, there is no role for Wolbachia. Second thing is that doxycycline. Doxycycline has been used many a times to improve in cases with 6 weeks doses are given. We have just completed a study, that is a 2-year-old study, that is there were 6 centers including India, Sri Lanka, Mali is Africa, and Cameroon and other countries. So we have just completed the study and it is analyzed. It's a double-blind trial with lymphedema doxycycline 100 milligram per day into 6 weeks, and a placebo, placebo. It's a placebo and doxycycline. And when we analyzed, we found that in all the centers, in all patients, and along with that, both groups were given intensive hygiene practices. So that was always reinforced during the follow-up visits also. So what we have found is that in all the centers uniformly, both groups the patients have improved. There is no advantage in the group where the doxycycline has been used. So the conclusion was that this is because of the hygiene practices. So over and above of the hygiene practices, and that includes all the lymphedema management, the exercise and all that. In addition to that, there is no role for the doxycycline. Actually, this study was done to, because in many centers they were using doxycycline. So whether that is to be accepted as a treatment, to develop a policy, that the study was done. But in all centers, in Africa, Sri Lanka, and the Cameroon, Tanzania, all these centers, both groups there were improvement, but that is irrespective of the doxycycline. So the doxycycline 6 week doesn't have an advantage than the hygiene practices.
Yes. One or two questions.
Thank you, sir. Acute adenolymphangitis. Because there is no adult worm or
there is no adult
microbe.
worm. Suppose the patient comes with the first ADL. So we are not sure whether it has been wiped out. So at that time, is there a point contraindicated or no?
It's not contraindicated. The first point is, sir, as sir said, the first episode of adenolymphangitis, person with a minimal lymphedema probably. And that case, there is a possibility that there could be an adult worm. So there is nothing wrong in that. But routine use, that is what I just wanted to get it.
It will not be useful. But you can give no harm. Thank you.
But the problem is that acute adenolymphangitis patients usually have vomiting also. So when you give DEC or Anvitsol, you are giving increasing number of tablets. So that could increase that. And without any benefit, this could be increased. Yes.
Hygiene, soap and water, the plain water.
Soap and water. The common soap and the water. I didn't go in detail because I thought there is the time may be less. Otherwise, it is cold water and normal water and normal soap.
What about long-acting penicillins? Like
yes, sir. Long-acting.
I have found it very useful, and people are without many years they go on without any infection with some hygiene.
Long-acting penicillins are not available now. Is it?
It's available.
Okay. But it is difficult for the patient
in
to
our
take
hospital, there is a day, Saturday from 8 o'clock to 12 o'clock. There are a lot of patients coming with rheumatic valvular heart disease, chronic filariasis, and they all get in that period of time, and they get.
So in government hospitals, I think it's usually not. About the question, sir, there is a definite role for prophylactic penicillin, but we usually give it for certain group of patients only, not for anybody. The patients, in spite of the hygiene measures, if they are getting recurrent episodes, especially the picture I showed with a lot of nodules, they get frequent episodes, because anything they do that can produce an abrasion. So they can go in for an acute radial. So in such patients, and large limb with deep folds and all that, there also the fungal infection will be there in the folds. So those patients also may get it. So in spite of the optimal hygiene measurements, if they are getting different episodes, acute recurrent episodes, there we definitely give it. And we give the oral penicillins, which they are better to get it, and daily they take it, and that is effective also.
Thank you, Dr. Suma. See, one question which is very commonly asked is, what should the relatives do? Do we do any screening or preventive advices for the relatives who are staying close with the patient who are exposed to the same vectors? This is a question which usually is asked by the relatives of people who have been diagnosed as having acute.
No, the thing is that in a family itself there could be 2 or 3 people. So usual thinking is that that's a disease which is transmitted, which is hereditary. But that's not there. But in the environment, suppose as you said, there are a lot of vectors, others can also get it. So what we actually during the program and following these studies and where the hygiene is found to be very useful, one of the things we have suggested is that, and the disease starts in childhood, and it takes some time for it to develop into lymphedema. So what is suggested is that all children in endemic areas should be trained on the hygiene practices when they are small. That is in the school health program and all that. Some countries are doing it, so that they will not go in for a further lymphedema when they grow, when they become the adults or teens or like that. So that is the one.
Do we have any specific anti-helmintic directives for the relatives?
Just hygiene practices, that's all. And the thing is that it will not be spreading from one person to other once the lymphedema is there. But that is also a doubt everybody asks. And usually what we see is that when the girl comes to the family after marriage, they will not go to the father-in-law who has had the one, or the children will not be allowed to play with the father-in-law. That's usual. But those things have changed now because of the better management of lymphedema and also the...
That stigmata was always there when somebody was going to for a marriage or some... I
am asking about the cases of acute lymphadenitis.
Yes, acute adrenal lymphadenitis.
Yeah, whether there is any point in screening relatives.
No, this is, they have to also do the hygiene practices. Yeah.
The incidence come down?
Yes, definitely. Yes.
Why?
Which one?
The incidence of filariasis itself.
That is because of the program, sir.
No, people are not getting
What?
filariasis.
Because they have, what happened is there is 7 years the program was running up to 2013. They were giving, I think many of us have not taken it, I have taken it. So, early albendazole and this one, DC and albendazole for us in Asia. So that is being done.
The vector is still there.
Yes. And what happens is this kills the microfilariae. So the microfilariae density of that population or of that area comes down very low. So the mosquitoes will not be able to pick up and transmit it. That's the reason why, that's the principle of the mass drug administration also.
That seems to be very effective, that the incidence have come down. That is right.
Because previously we used to conduct night blood examination camps to get the microfilaria patients for the studies. But we had to stop it after some time because we never get patients.
Okay, we will stop now because we give a big clap to Dr. Suma.
Thank you, ma'am. I request Dr. Abdul Khader sir and Dr. Vijay Kumar to convey our gratitude and to show our respect for ma'am. I also kindly request Dr. Tommy Phillips sir to hand over this memento to Dr. Abdul Khader sir and Dr. Vijay Kumar.
Thank you.
A small announcement. Forms provided for the associate membership of API to the concerned individuals must be returned to the registration desk at the earliest. Also, dear delegates, please put your signatures in the afternoon attendance column as well, which is kept in the registration counter for the purpose of KSMC creditors. This marks the end of our third scientific session. Let us break for lunch and we shall meet again soon for the final session. Lunch will be served in the 8th floor at the rooftop. Thank you. Once again, the receipt books made for this conference has been misplaced.
പോസ്റ്റ് കഴിഞ്ഞു പ്രൈസ് ലാസ്റ്റിലേ പറയത്തുള്ളൂ പോസ്റ്റ് എവിടെ വെച്ചേക്കും സെക്കൻഡ് ഫ്ലോർ പോസ്റ്റ് കഴിഞ്ഞു
ക്രിട്ടിക്കൽ കെയർ ഒരുമിച്ച് പഠിച്ച രണ്ടുപേരും അവരെ അപ്പോയിന്റ് ചെയ്ത് പിറ്റേന്ന് അവരായിട്ട് ഡിപ്പാർട്ട്മെന്റിൽ നിന്ന് ഡിക്ലെയർ പിറ്റേ ദിവസം അതായത് ജോയിൻ ചെയ്ത് അന്ന് തന്നെ മീറ്റിംഗ് വിളിച്ചു. അഞ്ജുവിനോടൊരു വാക്കുപോലും പറഞ്ഞില്ല. അവസാനം പുള്ളിക്കാരത്തി വിഷമിച്ച് സങ്കടപ്പെട്ടു പോയി. ആ കോവിഡിൻ്റെ കാലത്ത് മുഴുവൻ പുള്ളിക്കാരത്തി നമ്മൾ പറഞ്ഞ എല്ലാം ചെയ്തോണ്ടിരുന്നു. വിളിച്ചു എന്തെങ്കിലും ഒന്ന് പറയുകയും ചെയ്തു.
We shall begin our final session of the scientific program momentarily. I request all the students and the staff to please get back inside the hall. I request all the delegates to please be seated. Welcome back. A very good afternoon to everyone. I am sure we are all satiated and relaxed after that scrumptious meal, and we are looking forward to the final session of today's program. The final scientific session is chaired by Dr. G. Harish Kumar, who is a senior physician at IHM Hospital Baranganyanam and SN Hospital Kadapara. He has served as the immediate last secretary of API Kerala chapter and is a past joint secretary and treasurer of API Kerala. He is also the recipient of the second best API Kerala chapter award at Epicon 2022. He is joined by Dr. G. Vijay Kumar, who is the chief physician at Medical Trust Hospital and Diabetes Care Center, Kulanada. He has also held the post of the president of API Kerala chapter previously. I welcome you on stage, sir. Our first topic is mistaken differentials for type 1 diabetes, the not so magnificent 7. With this intriguing headline for the next topic, I request all of you to join your hands together to welcome Dr. Nihal Thomas, Professor and Head of Endocrinology at CMC Vellore.
Good afternoon, friends. It is my pleasure to be here in the APA forum for chairing this session, very important session, where none other than Dr. Nihal Thomas will be presenting his paper. Regarding the topic, I don't venture to elaborate on that because I don't have any idea what is he going to tell about it. We will hear from him. Regarding Dr. Nihal Thomas, actually he is not new to APA and not new to THIRUVALLA. Actually he belongs to a nearby place at Tumbavan. He is actually I don't venture to read his biodata. Only thing is that he is done research, lot of research. The youngsters should emulate from the research work he has done and has published. And that's the only thing I want to elaborate on him. Over to Dr. Nihal Thomas for his presentation.
Good afternoon and thank you for that warm welcome. It's really lovely to be here again in THIRUVALLA. I'll be talking to you about an aspect of diabetes which we should be considering, the differential diagnosis of people who are thin who have diabetes. And this whole terminology of lean is a very nebulous term. What do you mean by lean? Does it mean less than the Asian cutoff of 23? Does it mean less than 20? Does it mean malnourished, less than 18.5? So lean is actually a layperson's term, not a good word to use. So let's anyway look right across the spectrum, and let me tell you that when we say really lean, ultra lean or malnutrition related, it's a BMI of less than 18.5. So we look at the spectrum from 18.5 right up to 22.5. They say it's genes, not the blue variety. Environs have a role, and the lack of satiety. Epigenetics, low birth weight, problems for poor, dwindling secretions, and resistance for sure. So this is the only aspect of my talk which is not going to be scientific, and I apologize for it. There are 7 scenarios that we should commonly think about for type 1 diabetes as a differential, and these are the list. When you have type 1 diabetes, you should think of this list. You might think that some of these are exotic, but really speaking, it's not looking for a needle in a haystack, it's looking for a crowbar in the haystack. You need to actually keep a differential diagnosis open after doing your preliminary tests, and if they are negative. This is a 37-year-old man, known hypothyroid for 2 years on carbimazole, diabetes for 2 years, has osmotic symptoms, started on oral anti-diabetic agents, but within a year, the oral anti-diabetic agents, he was on 3 maximal doses of 3 medications. They started to fail, and he had weight loss and increased appetite and polyuria and polyphagia, and there was no history of diabetic ketoacidosis or family history in the past. So he had a lean habitus. Indeed, his BMI was 16.7, and he had a thyroid gland which was visible and palpable. His systemic examination was otherwise normal. So when you have someone who's lean and has diabetes, the first thing you think is this is an autoimmune cause. That's number 1 on the list. And when you're below the age of 25, you say type 1. But when you have someone more than the age of 25, you think of something else. You can have autoimmune disease more than the age of 25, but it's given a different label. So we do imaging of the abdomen, an ultrasound, and we should do a screening for autoimmunity, and that's the GAD antibodies. So his GAD antibody was more than 2000. The normal cutoff for JDF is more than 10, but kind of, when you think about type 1, they're usually more than 100, and the C peptides are low, indicating a secretory problem. And remember, this man is a full-blown adult who came with this problem. He also has hypothyroidism, which means he has another autoimmune disorder at the same time. And this is, by the current WHO classification, the old LADA, which we used to call latent autoimmune diabetes in adults, which I quite like the term, and I have no idea why they've called it slowly evolving immune-related diabetes. That's a new term which has replaced the term LADA. Now, how is this different from classical type 1? Now, another very colloquial term was type 1.5 diabetes. We should kind of abandon all these terms, even though it seems to fit in between type 1 and type 2. And it is a hybrid form of diabetes. According to the WHO classification, it's called a hybrid form of diabetes. The difference between this and type 1 is generally only a single antibody is positive. If you had the opportunity to check 3 antibodies or 5 antibodies, in 80% of type 1, generally at least 2 out of 5 antibodies will be positive. We check 2 routinely in Velo, the ICA and the GAD antibodies. So I think the other thing which you should be looking for is they will have some degree of insulin resistance, unlike classical type 1 at the beginning itself. So if you have an opportunity to measure the HOMA-IR, you can do that as well in the early phase before they go in for insulin beta cell failure. So classically, more than 30 years of age, lean BMI, low C-peptides, and imaging of the abdomen is normal, and they obviously require insulin. And classically treat like type 1 diabetes, you need to give basal bolus insulin for these patients. Scenario number 2, 33-year-old gentleman, laborer, has abdominal pain radiating to the back since 1 year, loss of weight 54 kilograms to 44 kilograms, normal bowel habits, diabetes of 3 years duration on oral antidiabetic agents, no diabetic ketoacidosis, no history of his smoking or alcohol. Examination, once again, a lean, malnourished individual, BMI of 20.5, no evidence of nutritional deficiencies, and on examination, mild epigastric tenderness. Now, the patient, the intern who saw the patient said this is a diabetic patient who's had weight loss and did a chest X-ray to rule out concomitant pulmonary tuberculosis, and calcification was seen in the upper part of the abdomen. You ask every senior physician in Kerala, they will talk about this condition a lot. I'm not sure whether the current generation, the backbenchers sitting over there, have seen much fibrocalcific pancreatic diabetes. Do you still see it in Kerala? People say the prevalence is coming down in Kerala. Very interesting. This was the home for FCPD in India at one time. But it's no longer as common as it is. But you should still look for it, because if you miss it, then you're missing a lot in forms of treatment. So it is still very much prevalent in other parts. We see a lot of it in Tamil Nadu. We see it in a lot of our patients who come from the north. It still is a problem which should be ruled out. So the top 2 causes for young onset diabetes, lean diabetes, is number 1, slowly evolving immune-mediated diabetes, and number 2 is fibrocalcific. It has to be ruled out by and large in most of India. So remember, this patient did not have symptoms of malabsorption, and many of them have a maladaptation. They stop taking fatty food and they don't have steatorrhea because they adapt to it. And so even though he had gross malabsorption according to the stool elastase, he did not have symptoms of malabsorption. Another thing which you need to be concerned about. This gentleman was even more unfortunate, because when we imaged him to classify the pancreatic, large, chunky duct dilatation is typical of FCPD. If you don't have duct dilatation, if you don't have chunky calcification, you should think of other causes for chronic pancreatitis, and that's a different story. The MRI showed a mass in the head of the pancreas, and this is obviously a malignancy, and his marker for pancreatic malignancy, CA 19.9, was also elevated. Endoscopic biopsy showed adenocarcinoma of the pancreas. Now, management perspective, you need to give these patients insulin, and you need to give them enzyme supplements, or they will never gain weight. And what we have, of course, classified this disease with its other features. You all know that they have low C-peptides eventually. If you see somebody with a calcified pancreas at the age of 55 who's on OADs, that's not FCPD. That is a man who has chronic pancreatitis who has concomitant type 2 diabetes. So generally within 2 or 3 years you need insulin over here, and they don't have features of insulin resistance. 70% are males, and some of our work which I'll tell you about is osteoporosis is common, and it's not due to vitamin D deficiency, it's due to the fat malabsorption. So you can prevent it by giving adequate enzyme supplements. Autonomic dysfunction is seen in 60%, probably because of the concomitant micronutrient deficiency which worsens the neuropathy. Energy expenditure by indirect calorimetry is disproportionately high, so you need to take a high diet intake of fat, carbohydrates, and overshoot to 2,500 to 3,000 calories in some individuals, and give as much insulin as required. Micronutrient deficiency is very common and problematic. And another thing, just don't mistake, because you have people who may lose weight later on, don't necessarily need insulin, but fat malabsorption can occur in autonomic dysfunction in type 2 diabetes. And so that should not be mistaken for FCPD in that situation. This is a collaborative study done with our friends in the STPGI in Lucknow. And when we looked at this population in Uttar Pradesh of young people less than 30, type 1, obese people with type 2, young type 2s, and FCPD number 3. And then we have the genetic causes of diabetes in this North Indian population. There may be a different epidemiological pattern in Kerala. 16-year-old girl diagnosed to have diabetes during routine testing on thrice daily insulin. Recurrent history of renal stones, chronic renal failure from 12 years of age. She had a baseline creatinine of 2.5. So the primary problem was a renal problem and renal stones. And from the age of 14 years, she had cyclical abdominal pain and had not attained menarche. No steatorrhea, mother pre-diabetic, paternal aunt is also a diabetic. So what's your diagnosis over here? Young lady, amenorrhea. Why Modi? Because I'm talking about it? No. Right. 3 generations. Okay, fine, maybe. Where's the 3 generations? Mother, paternal aunt. Only 2 generations. Anything else? Sorry? Anything else? Amenorrhea with diabetes, what should you think about? Primary amenorrhea. Any pediatricians here? No. Turner syndrome, right? Okay. So Turner syndrome, you can come with primary amenorrhea and you can also be prone for diabetes. You should think about that. But anyway, her physical examination is reasonably okay. Tanner stage 4 breast and pubic hair, indicating there is estrogen production, and FSH and LH were in the normal range, indicating that the ovaries are functioning. So this is a structural problem, not an ovarian failure or a pituitary problem. Yes, somebody said something. So anyway, so it's a structural problem, therefore we imaged the abdomen. We of course did an ultrasound, saw something odd over there, and then we confirmed with an MRI, and it's a bicornuate uterus, and the MRI abdomen also shows a grossly atrophic pancreas over there, almost like a sliver of tissue. So she has shrunken pancreas without calcification and a bicornuate uterus. So this is a Mullerian defect along with a atrophic pancreas. So this is indeed, you were right, you had the foresight and you thought about MODY or maturity onset diabetes type 5 in this patient, and they can have renal cysts most commonly, and in males they can come with infertility with absent vas deferens and pancreatic atrophy, but not calcific pancreas. Atrophic pancreas is different, and that is why the whole story of atrophic pancreas is a story by itself. And if you see a small pancreas and a CT with diabetes, don't think it's only FCPD, unless you have the classical features of chunky calcification and duct dilatation. It could be something very different. Here's another one. 16-year-old boy, progressive weight loss over 1 year, high sugars, ketones positive. We swore this is type 1 diabetes. He was grossly malnourished. He had some early cataracts, put on basal bolus insulin, but the GAD antibody was negative. C-peptides were low, indicating beta cell failure, and even stool elastase was abnormal. So what are we dealing with? So we image the pancreas. Pancreas is borderline in size, mild atrophy, and so no calcification. And so we did the genetic test, because we said smallish pancreas, GAD negative, C-peptide negative, we go for the next generation sequencing, and it ended up being another MODY5, a different kind of presentation of MODY5. So these are things which you should think about, especially if diabetes has been diagnosed and you're GAD negative, C-peptide negative, imaging normal, think about other conditions which may come in over here. 29-year-old lady have diabetes in the first pregnancy, 5 years back. At the age of 27, complained of oily stools, definite steatoria. Ultrasound showed chronic calcific pancreatitis. Stool elastase was very low. But the pancreas was atrophic and it was replaced by fat, no calcification. Some, well, minimal calcification, not the chunky calcification you would see in FCPD. So this is another condition wherein you have, it's a form of MODY, though no longer in the classification of MODY, but a particular mutation called CEL, which can also have monogenic diabetes. And the histopathology over here, and this is, sorry, the slide is not taken from this patient, to be honest, because I would have to do a postmortem biopsy to do this. The patient is well and alive after the mutation was detected on insulin, but you can have profound fibrosis and staining, which is positive for glycogen in this in addition. So these patients are another important DD. We have done a fair amount of work on MODY, and the Indian MODYs, from what we see, is different. A number of women with gestational diabetes in the who require insulin, particularly the pre-gestational ones in the first trimester, could actually have MODY. About 15% of our insulin requiring. Of course, we are a quaternary care referral center and there may be a bias, but it still is seen in some of our lean women in Tamil Nadu, and of course there is a fair amount of consanguinity as well over there. So the most common MODYs in the West are 1, 2 and 3. The ones in India are actually different, and these particular forms which can present in a neonate are very sensitive to sulfonylureas. Some of them need massive doses of sulfonylureas, like the ABCC8 and the KCNJ, sometimes up to 40 to 50 milligrams of glibenclamide, big doses. Whereas the other ones need standard doses for treating the condition. If you have an atrophic pancreas without calcification and you have diabetes, this is the differential diagnosis, the mutations, and maybe some other day we can take a lecture on this itself. It's a subject by itself which is extremely intriguing, and we're doing some work on this at the moment. So 38-year-old lady diagnosed with diabetes at the age of 19 years, came with hyperosmolar symptoms and diagnosed to have type 1 diabetes. Lean habitus, BMI 17.4, had enlarged veins on the limbs and markedly reduced subcutaneous fat. Fundus showed diabetic retinopathy. When you see the word phlebomegaly, you should think about something. And she had a very sallow, flat, abnormal distribution of fat. So what is your diagnosis here? Anybody? Okay, so that's what it looked like. And the triglycerides are also very high, indicating severe, this is a state of insulin resistance. And she was started on insulin, and like any other young lady who's totally fed up, after 2 months stopped the insulin for 5 days, sugars went up to 500, but she didn't develop diabetic ketoacidosis. So, and her C-peptides were elevated, right? So what is the condition? This is something called lipodystrophy. They have abnormal body composition distribution. As you can see over here, the head has more fat, whereas the rest of the body has less fat. It's a partial lipodystrophy. And you can have other mutations which are the complete lipodystrophies, wherein they are stunted and have a total loss of body fat all over the laminin gene mutation is responsible for the partial lipodystrophy, and the AGPA2 mutation is responsible for the complete lipodystrophy. 20-year-old gentleman, polydipsia, polyuria at 4 years of age, on basal bolus insulin, being treated at type 1. Now the odd thing is, right from the early phase of diabetes, mind you, very early, 1 or 2 years, he had frequent urination with bedwetting, and he was being managed as type 1, and of course there were no other features of neuropathy over here at that point of time. When the patient was first screened, the A1C was markedly elevated. One of the other features, when sugars were checked, they checked the electrolytes, and you can see that sodium is borderline high. When do you have a high serum sodium? What are the conditions you think of high serum sodium? Very intellectual backbenchers. I can feel the vibes, but I can't hear the voices. Right. Everybody told me in Kerala they ask you a lot of questions. Okay. Show your activism. Come on, ask some questions. I mean the youngsters. Okay. People over here know everything, so they're not asking anything. Come on. Okay, right. What do you think about, the senior citizens and the senior, not senior citizens can also answer. What? High sodium, you think of dehydration, right? Yes? Correct. Okay, thought about insipidus. So the guy has diabetes mellitus and diabetes insipidus. Now what do you think of? Fantastic. Brilliant diagnosis. So if you were there, the patient would have been diagnosed in 1 year's time. This took some 6 or 7 years late, unfortunately. So GAD negative, and even though the phe peptides you can see are low, and the urine osmolality is also low. So it's diabetes mellitus and diabetes insipidus. It is Wolfram syndrome, but it's very subtle. He didn't have any visual problems, optic atrophy, Didmode syndrome, right? That's what you're describing. That was not there. So this is the sister. Picked up later, 8 years of age, normal child, then suddenly started developing visual defects, recurrent seizures, deafness, recurrent hypoglycemia, and passed on at the age of 26 years. Right, severe disease. And remember the other boy, he also had a bladder dysfunction. You can have neurological involvement in Didmode syndrome. Okay, so this is a clinical diagnosis that you made, but then we want to confirm it. We did the Modi screening, that is the 14 gene panel, and then we went next to expand the panel to 31 genes, and we go up to 62 genes now for young onset diabetes. So we can pick up a number of conditions, and this ended up being positive. This is a Wolfram syndrome type 1, And the boy actually had a Wolfram-like syndrome. He doesn't have the deafness or the optic atrophy. So this is published recently in the Journal of Clinical Endocrinology and Metabolism. And if you look at the classical features, I don't know if you can see it from there, but there are a lot of other things which can happen: intellectual disability, psychiatric conditions. So the family history and the pedigree chart is very important to try and see if other members in the family, or maybe 20 years ago, had some other presentations over here as well. The diagnostic criteria, so you have minor criteria and major. Two major: easy diabetes mellitus, optic atrophy, and then a set of minor criteria, and therefore you can still make the diagnosis with minor criteria, or if you have the mutation positive over here. So you can, this is the Wolfram-like syndrome. We should look at it in patients who have normal imaging, normal GAD antibody, low C-peptide, and then start thinking about other conditions for young onset diabetes. So the Wolfram-like syndrome is milder, has minor criteria positive, or maybe one minor criteria and a mutation positive as well. Treatment, there are things you can offer, particularly for the neurological symptoms and some of the other developmental issues. Dantrolene has been tried, valproate, and in fact now this phenylbutyric acid, tosodiazoxycholic acid concoction has been FDA approved for treating the condition. Okay, now finally we'll come to this particular condition. It was described, and once again the very senior physicians will remember that this condition was part of the WHO classification in the 1980s and then got erased in 1996 because they said it doesn't exist. There was not enough physiological testing to prove it, and but these were the criteria which were laid down: severe diabetes, onset below the age of 30 years, BMI less than 18, no ketosis on withdrawal of insulin, but no features of lipodystrophy, poor socioeconomic status, insulin requiring up to 60 units per day, rural origin, absence of radiological features to rule out pancreatic disease. Okay, and this is one of our patients who's from rural town Tamil Nadu, hardly about 15 kilometers away from our hospital in CMC. And so we actually ventured to establish, because it's a very controversial thing, it's not in the WHO classification, and we have this collaboration with the Albert Einstein Institute in New York. I should get Meredith to come and talk to you sometime over here. She's never visited Kerala. Fascinating person. But anyway, we actually spent 9 years doing this experiment because it was very intensive. We did hyperinsulinic euthyroid clamps, which is the gold standard for insulin sensitivity, indirect calorimetry, and we measure the micro quantities of the fat in the liver with NMR spectroscopy. And we did the mixed meal challenge test to look at the secretory capacity. Now you can see over here, and in this particular condition, the I'm trying to use the pointer, but anyway, the blue line is basically the condition which malnutrition modulated diabetes, and the red one hugging the baseline is the type 1 diabetes. So we have controls, 20 controls of each group where we did all these experiments. So they have low C-peptides, low secretory capacity, but not as low as type 1 diabetes. The other thing which is striking is that you know that in type 2 diabetes, the major pathogenic feature is hepatic glucose output is greater, right? You know that. Metformin works on that and all that stuff. But here the hepatic glucose output is much lower. Many people from India like to call this lean type 2 diabetes. It's not lean type 2. Their BMIs are really low, less than 18.5, and the hepatic glucose output is actually not elevated. Unlike type 2 diabetes, you can see the controls over here, and in the type 2 it is actually elevated. And peripheral resistance is not a feature in this lean group. Now the intriguing thing is, even though they're so lean, 50% of them, and thank God for that, they respond to oral anti-diabetic agents. We're still trying to study and see which ones work better, but 50% respond to oral anti-diabetic, and the remaining 50% need insulin. So they have some kind of sensitivity to maybe sulfonylureas, which seems to work. DPP4 may be working. They are deficient of protein malnutrition. May I have another 3 minutes to wind up, chairpersons? Their micronutrient intake is poor. And more recently, and this is not yet published, the initial part has been published in Diabetes Care, we are going to publish this and we're really excited, is that their incretin levels, the blue line, GIP is really low and GLP is also low. We don't know why. But we think that because of chronic malnutrition, that perhaps in tropical sprue what happens is the intestine atrophies, the villi atrophy. And perhaps the enterointestinal endocrine cells do not recover as much. And maybe that is the reason for this. We need to prove this by doing a sample of 2 or 3 biopsies in these patients to see whether it's actually happening. But it's so profound, there is really no other condition which has such profound incretin deficiency. Somebody argued and told us this is a variant of cluster forms of diabetes. This is a big argument which we are having right now. Well, the clusters which are described, you heard about the clusters for type 2, have much higher BMIs. Even Mohan's study on the INSPIRED study, the BMI is 24.9 for the severe insulin deficient diabetes. So it's not the same disease, it's something very different from that. This is another all India study on the clusters, and again you can see it's not very clear, but the BMI is actually 25 median, not 18, not like us, 18.5 median. So we will redefine protein deficient diabetes. Some of the features which are described 30 years ago are still there, but I would like to delete so-called severe diabetes because very often they don't have very high fastings, and I will also delete this insulin requirement because so many of them do not require insulin. And it's, I mean, something which all of us as very proud Indians don't like to admit, but there is an element of undernutrition in India, and this is a problem. You may not see much of this in Kerala, probably not. Do you? Yeah. But there are, and I know colleagues who work in mission hospitals, Orissa, Bihar, Chhattisgarh, that this disorder is a problem. And how does it happen? Only theoretically, but in malnourished rats, rat models, you have islet cells which are much smaller, micro islets, and this may be partly the reason why this is happening. Okay, let me wind up. So when you have a lean person with diabetes, this is how you work them up: detailed history, pedigree chart, physical examination, C-peptide measurements, GAD antibodies, ICA antibodies, ultrasound. That's what you can do. Now if you really have a problem, you're really intrigued and you want to find out, then you need to get genetic testing done to take things forward. Differential diagnosis, these are the ones which I've listed over here, and I've not talked much about HIV lipodystrophy, but it's obvious if you have HIV lipodystrophy, you think about that as well. I'd like to thank all my people in the department, my collaborators for the work that they've done to reach this algorithm for diagnosis. Thank you very much.
Thank you, Dr. Nihal, for a very interesting presentation of the rare cases. Actually, at this time, we should remember the Dr. P.J. Givargis, who was the HOD of medicine when I joined Medical College Kottayam in 1972. Sharma sir and Jayamar, we all were students at that time. Actually, he has done the maximum work, and we were excited to see his name in Harrison. Maybe the only name in Harrison's textbook of medicine from Kerala. That's I remember. Now, at that time it was, we were really excited to see his name at that time. The topic is now open for discussion. Any questions on that?
Right. So we still don't know what really caused it. I mean, I think the tapioca theory has not stood the test of time. But I still acknowledge the fact that Givargis did fantastic epidemiological work in that area. What it is that has changed in Kerala and some other parts of India, we don't know. It probably is something to do with in the environment and the diet which has changed over this period of time. Not sure what it is. Yeah, so that's the problem with Africa. I mean, if you go to Africa, I've been to Tanzania and Uganda. I think, if you want to see about healthcare a few steps down, unfortunate, they're very nice people. But, even to do an ultrasound is a challenge in many situations. There's no question of doing GAD antibodies or measuring C-peptides. So, everyone will be treated with type 1 diabetes, insulin, and making these diagnoses is very, very, very difficult to do it. We wanted to replicate some of these studies in Africa because they seem to have a lot of this malnutrition modulated, and it is very unfair to put all of them on insulin when they don't necessarily need it. But doing anything even quarter, maybe 1/10 of what in terms of research in Africa is very, very difficult. So it is probably seen. It was reported in post-mortem studies in Tanzania, Kenya, many years ago, 30 years ago, but they've forgotten about it. Yeah.
So regarding the C-peptide, actually in the discussion, C-peptide has come several times.
Yes.
Actually, what is the current placement of C-peptide in day-to-day practice? Has it come to the lab level, whether to see whether the patient is insulin deficient or not, and to see whether the insulin is needed for a particular patient or not? Has it come to that level? Because I was actually following this C-peptide, use of C-peptide. Earlier it was, when I asked the question 20 years back, the answer was no, it is not, it's only a research thing. Has it come to the lab level?
It's a very important diagnostic test. So it's not for seeing whether a type 2 should require insulin at some point of time. It is not to prove that type 2s are insulin resistant and check C-peptides. I mean, if you're doing that, that's a research study. But in these situations where you're trying to figure out whether they do have full beta cell failure or a suboptimal beta cell function like MODY, the C-peptides at baseline may be suboptimal but not very low. And when you give them a sulfonylurea, the C-peptides actually go up. It's a bit of it's a kind of a test, and so it goes up a little bit. In patients with type 1, they will invariably be extremely low. And I've mentioned the other conditions. In lipodystrophy, the C-peptides can be high. Actually, if you look at the textbook, they'll say they should be high. But we are finding patients who are atypical who don't have very high C-peptides. It's a different story. But the classical textbook description is that the C-peptides are usually elevated.
Sir, clinically, a patient comes with diabetes. What are the clinical criteria which you can suspect this patient may be? What are the clinical criteria in which you suspect this patient you may be dealing with a MODY?
Yes, okay. So first question was, do we do the genetic tests in Velo? Yeah, we're doing the entire thing in Velo. We're not outsourcing it. We have a NGS system, we have an entire, and we have, more important, I have a fantastic scientist who's very dedicated and a good team, so that's what makes the difference. Because the thing about genetic testing, those of you who know something about genetics, is that it's not that straightforward. If you start doing a whole array of genetic testing in this crowd, you'll probably get even non-diabetics having MODY mutations, benign variants in some of you. So that's not the way to do it. And also there need to be a constant dialogue and discussion with your scientists to try and differentiate. It's a clinical science by itself which has to be. The second question, Dr. Sunil Matthew was on the aspect of how to use the criteria. Now the classical criteria of 3-generation family history is there, certainly. If you have that, it is very useful. 3 generations where 3 generations have an onset probably less than 35 years of age is very useful. But that's going to become increasingly difficult. With half your relatives living in US and UK, you have no clue as to whether they have a 3-generation family history or not. So that's going to be another issue over there. So you can look laterally. I haven't shown you some of the pedigree charts. We draw the pedigree charts laterally and look at the cousins. That's also another way of looking at it as well. And then some of them have the phenotypes of a particular MODY, like MODY 5 has a particular phenotype, right? There are other forms of MODY also, like the earlier neonatal diabetes, they have particular phenotypes which are useful as well. So the early onset, family history, and C-peptides which are preserved but maybe suboptimal, not as low, and never have gone into ketoacidosis by and large. Having said that, there are forms of MODY which can go in for decay. I mentioned MODY 5 occasionally, MODY 4 occasionally can go into decay. Yeah. Okay, so, okay, now I'm the fan of metformin in pregnancy for GDM, okay? So I'm going to say that for GDM, give metformin. There are 5 guidelines which say you can give metformin, and you have to do it in this country. There were studies on glibenclamide in pregnancy, you know that as well. In fact, it was proven before metformin, but we would not like to give it because generally fetal outcomes are not good. Now to use glibenclamide for MODY in pregnancy, I need a separate study to prove that. So I have to give insulin. For my MODYs, I can use metformin if they are got a little extra fat and they have concomitant resistance in pregnancy, you can give metformin. And you have to give insulin in addition. But knowing it is very useful in a pregnant woman because it helps in predicting the next generation much earlier.
There are no more questions, I think. I will ask one more question, sir. Actually, we had a lady, 69-year-old lady, came to us today, 2 days back, with a history of she was diagnosed to be type 1 diabetic, 1.5 months back.
Type 1? Type
1 diabetic, at the age of 69, because 3 months back, her blood sugar was normal. She had COVID-19 2 months back. After 1 month, she was found to be unconscious and taken to a hospital where she was admitted in the ICU. Blood sugar was 1,000 and managed with IV infusions, and now she is on insulin. Her C-peptide was 0.13 and low insulin. No other investigations were not done actually. I'm going to follow it up. How do you explain that?
So, I mean, okay, so what's in the name? Perhaps better to label it as slowly evolving immune-mediated diabetes rather than type 1. So it is LADA and slowly evolving immune-mediated, not type 1.
69
and
69 years.
Yes, I have seen the same kind. That's why I want to highlight that. I have seen this in 70-year-olds coming, and I followed them up, and they behave a lot like type 1s, like, you know, the brittleness and the need for insulin and basal bolus I've seen. So it can happen. Look around for them. They can happen occasionally in elderly people above the age of 60.
COVID-19, any relation?
Association. We know that autoimmune phenomena can be provoked by COVID-19, and not just COVID-19. We know that other viruses also can provoke autoimmune phenomena. It is well known, Coxsackie B, rubella, all that can provoke autoimmune phenomena. And because everyone has been working ad nauseum on COVID-19 for the last 3 years, we know a bit too much about it. So I'm sure there are other viruses which can also provoke this kind of an autoimmune phenomena.
Thank you, Dr. Nihal, for a nice presentation. Give him a big clap.
Thank you, sir, for a truly wonderful talk and clarifying the much-needed debate on the varied nomenclature used in diabetes. I request our chair people, Dr. Harish Kumar and Dr. Vijay Kumar, to please extend a certificate and memento as a gesture of our appreciation to Dr. Nihal, sir. Thank you, sir. As we near the end to a beautiful program, I invite Dr. Raghunath to talk on the very last topic of the day, from bedside to microscope, tales from nephrology. Dr. Raghunath is an associate professor and consultant nephrologist at Amla Institute of Medical Sciences, Thrissur.
Good evening. Thank you, the organizers, Dr. Sunil Matthew, and the team for giving me and Dr. Vijay Kumar an opportunity to chair this session. This topic is given by Dr. Raghunath M. I think from clinical bedside to the microscope. So, and I think and to deal with the clinical features of any renal disease like edema of the feet and also facial puffiness must be and also we have so many of connective tissue disorders, so we have to clinically find out what are the connective tissue disorders we are dealing with, and with microscopy. So to enlarge on this topic, we had Dr. Trinadmab, originally from Ernakulam, now settled in Thrissur. It is MBBS and MD from Government Medical College, Trivandrum, MD Nephro from Kozhikode Medical College, DPMD as well, working as Associate Professor and Consultant Nephrologist at Amla Institute of Medical Sciences, Thrissur. I presented papers in the state and national conferences. Areas of interest include all aspects of acute kidney injury, critical care, nephrology, and glomerular diseases, especially IG and nephropathy. Over to Dr. Raghunath M. for your topic.
Warm good afternoon to you all. Thank you, respected chairpersons, for that warm introduction. And I'd like to extend my thanks to Dr. Neeraj and the organizers of this August CME for extending an invitation to me to be a part of this prestigious gathering. And it gives me great pleasure as well to see some of my teachers among this crowd, as well as some of my students whom I've taught during MBBS. They have become physicians now, so that is a double pleasure. So let's move on to the topic. The title is From Bedside to Microscope, Tales from Nephrology. So basically during the next 25 to 30 minutes, what I want to share with you are certain clinical weakness or cases from our nephrology practice that we have seen. Basically, they have some things in common. What is common is that they've all started at the bedside with a history and physical examination, went through the investigations, but at some point of time, in one way or other, a microscope has contributed to the culmination, that is helped us in formulating the final diagnosis, either with the help of a urinalysis or with the help of a renal biopsy examination. So urinalysis, it's a simple, cheap, easily available investigation, but its importance is not to be underestimated. It has been called a snapshot of what is happening in the kidneys. So a properly done urinalysis can give you so much information as to what is happening inside the kidneys. And at the same time, the renal biopsy is often a make or break investigation if you want to confirm a diagnosis or rule out differentials. So in that way also the renal biopsy is very useful in the appropriate clinical scenarios. So let's go on to the cases. So the first case is actually a 62-year-old male. He's a diabetic and hypertensive for the past 10 years. Now he has presented with around 1 week history of GI upsets, anorexia, nausea, vomiting, and some amount of pedal edema as well. Now he does not have any history of renal disease in the past, either in terms of laboratory abnormalities or in terms of clinical symptoms. And obviously, as presented to the nephrology department, he has a renal dysfunction. But when we went through the initial history, we couldn't get anything positive regarding what could have caused the acute kidney injury. No drug intake, no dehydration, no history of fever, etc., etc. But when you probed into the history further, he did give the history that he had consumed 2 large glasses of the bilimbi juice, that is our irumban-puli. Some well-meaning relative had advised him to take it in one sitting so as to bring down the cholesterol very rapidly. And he reluctantly admits that probably the GI symptoms started after taking this irumban-puli. So there itself you had a possible clue from the history. His investigation showed a severe renal failure. Urinalysis, what we are interested in, showed only a trace proteinuria, 1 to 2 RBCs and WBCs, and 1 plus granular cast. The ultrasound ruled out an obstruction and showed normal sized kidneys. So from the urinalysis, it's not a striking urinalysis finding. So that means that probably glomerular disease is lower down on the cards. So you are more likely thinking of a tubulointerstitial pathology. And in the background of bilimbi juice consumption, what you are thinking of is probably an acute tubular necrosis. So this is a urinalysis from that sample, which shows this is the muddy brown granular cast that you can very well read in the textbooks. This is the same film, this is another sample, another film from the same sample, but that's not very clear. And the same thing, this is taken from a textbook, of course. So this clearly shows the fine granular cast, the coarse granular cast, the muddy brown granular cast. So it is the darker, coarser, muddy brown granular cast that are typically said to be pathognomonic of acute tubular necrosis. So the result, you have the confirmation that it is probably, not confirmation, but strong presumption that it is probably an acute tubular necrosis. Now we can confirm this only with a renal biopsy. So that's what we have done. And just before we go into the biopsy of this patient, this is what a normal glomerulus and tubular indecision looks like. The kidney biopsy shows this beautiful glomerulus, the thin-walled capillary loops which are patent and open, a few bit of cells here and there, some mesangial matrix in pink, and this is what the tubules look like. All nice tubules packed back to back, not much space in between them, and you can see the pink brush border tubular epithelium beautiful in this. So this is what is normally seen. As opposed to this, in this patient on the right side, you can see that the tubules are larger, dilated. There is some separation between the tubules, meaning there is some interstitial edema, and the tubular epithelium has sort of lost its pink nature and width. So there is simplification of the tubular epithelium. That is again confirmatory of acute tubular necrosis. So your suspicion is correct. It is acute tubular necrosis that is responsible for AKI in this patient. So what could have caused the acute kidney injury, and how do ATN, and how does it relate to the bilimbi juice? This is the same patient's kidney biopsy under polarizing microscopes. So that is showing a positive birefringence within the tubules. So these are actually calcium oxalate crystals which have gotten deposited within the tubular epithelium, and that has gone on to damage the tubules, resulting in ATN. So the final diagnosis would be acute oxalate nephropathy secondary to bilimbi juice consumption. So the thing is that this bilimbi irumban-puli is very rich in oxalate content. So probably he took a large dose of this in one sitting, which delivered a large oxalate load to the kidney, and to compound with that, he probably had nausea, vomiting, which led the way to some hypovolemia, dehydration, and this in turn sort of amplified the damage. So that could have what is happened in this case. But all's well that ends well. Even though creatinine went up to 9, he could be managed conservatively because it is an ATN. You just have to be patient. There is no specific therapy. The renal functions gradually improved over the next 1 to 2 weeks. It never reached normal baseline, but still fluctuating between 1.5 to 2. So that was a costly advice. So second case. So this is again a 58-year-old male. Now he has presented with 2 to 3 weeks history of oliguria, edema and gross hematuria. He is also a diabetic and hypertensive, and his past medical history is also significant for the fact that he has a recent carbuncle which is undergoing treatment. IND and antibiotics are being taken. And he has now presented to the nephrology department with a creatinine of 8. The urinalysis is significant in that it shows plenty of proteinuria, plenty of RBCs and lot of WBCs as well. So what do you think? Is it a diabetic nephropathy? We don't have any baseline creatinine for this patient. Ultrasound again ruled out obstruction and showed bulky echogenic kidneys. So there are certain red flags which should make you suspect that a patient with diabetes and kidney disease need not have diabetic renal disease. It can be some non-diabetic renal disease also. So these well, it is a possible differential, but not in this case, sir. So these are some of the red flags which you should keep in mind when treating a patient with diabetes and renal dysfunction. Gross hematuria or persistent microhematuria, absence of proteinuria, abrupt onset of nephrotic range proteinuria, rapid progressive loss of GFR, asymmetric kidneys, small kidneys on ultrasound, etc. make you think of ischemic nephropathy or chronic glomerulonephritis. No target organ damage elsewhere, no peripheral neuropathy, no microangiopathy, and of course signs and symptoms which are suspicious of systemic illness otherwise in this patient. So in this background, even in this patient, even though he has a diabetes of long standing, because of the abrupt onset of symptoms and the gross hematuria, we should be thinking of a condition other than diabetic kidney disease in this patient. So hematuria in this patient, is it glomerular or is it stone or infection or something like that? So how will you say that the patient is having a glomerular hematuria? We know the classical teaching. What helps to differentiate between this is actually the cellular morphology of the RBCs in urine. Presence of dysmorphic RBCs and acanthocytes means the patient has glomerular source of bleed. On the other hand, if it is coming down from a urological source, say a stone or a tumor or something else, cystitis, there will be isomorphic RBCs along with clots. So what are these dysmorphic RBCs and acanthocytes? This is taken from a textbook. On the right side, you have the urological cause producing bleed. All the RBCs are uniformly appearing. That is what you mean by the isomorphic RBCs. Contrast that with the left figure, where you see the RBCs of different shapes and sizes, some with bizarre appearances. And in the inset, you have the characteristic Mickey Mouse cells. The Mickey Mouse appearing cells, also known as acanthocytes. So these RBCs have got sort of blebs or projections on the cell membrane. So these two are classical features of glomerular hematuria. The dysmorphic RBCs and the acanthocytes in urine. So if you have a phase contrast microscope, it is easier to detect this. Otherwise, with the usual low field illumination, it is very difficult to find this out. But at least you can see the difference in appearance and shape and size. So this patient had evidence of glomerular hematuria. So if the hematuria is glomerular, what are the differential diagnoses you would like to consider? Especially in the background of infection. Obviously, infection-related glomerulonephritis would be your top differential. And infection, hematuria. Again, IgA nephropathy also comes under the differential diagnosis. Then C3 glomerulopathy also can present in this manner. Of course, in the appropriate clinical scenario, a patient with active urine sediment and renal failure, you should also think of the possibility of SLE vasculitis, but probably not very applicable in our case. And we did the complement levels in this patient. So this is actually low. A low complement in this patient should make you think about possibility of infection-related glomerulonephritis. So how can you confirm this? Do a renal biopsy. Of course, it is to be remembered that you don't need to have a renal biopsy in all patients with IRGN. Basically, it's a clinical diagnosis. But in this patient, he had so much renal failure, so we wanted to be very sure. So This is what happened with the patient's kidney. You can see a lot of cells are there. Instead of the normal glomerulus which we have seen earlier, here you see lot of increased number of cells. These are both neutrophils. You can see few neutrophils here, which is pointed by the red arrow. So this is an exudative endocapillary proliferative glomerulonephritis. This is very typical feature of typical appearance of infection-related glomerulonephritis. But surprisingly, patient's biopsy, few glomeruli also showed this finding. This mesangial nodules within some of the glomeruli. This is pathognomonic of the Kimmel-Steele-Wilson nodule indicating diabetic nephropathy. So that means that this patient had both pathologies, diabetic nephropathy as well as infection-related GN. Immunofluorescence is also a part and parcel of the kidney biopsy examination nowadays, and there again, there was a bit of a surprise. Usually expect IgG and C3 only, but here we had some amount of IgA as well. So that again sort of led to slight modification of the diagnosis. This is an infection-related glomerulonephritis, but a subtype of that, IgA dominant IRGN, which is usually associated with alcoholics, diabetics, and Staph aureus infection. Why is it important? They tend to have more severe proteinuria, more severe renal failure, and the prognosis is also much less, worse compared to the usual kind of IRGN. And of course, he had some background diabetic nephropathy changes also. So that was the final diagnosis in this case. So what's new in IRGN? We have sort of done away with the terms of PIGN and PSGN because it is not limited to streptococcal infection and it is not post-infectious alone. And we probably initially thought it was more in the pediatric age group, but we know that it has an increasing incidence in the elderly, where the outcomes are also poorer compared to the pediatric population. And these are some of the antigens that are associated with the development of IRGN. So these are believed to promote a sort of molecular mimicry or autoantibody formation. So that is regarding infection-related GN in this patient. So the third case. This is a 52-year-old female. Again, 2 weeks history of edema, oliguria and nausea, but she has been feeling unwell for the past 1 to 2 months with feverishness, joint pains, fatigue, cough with scanty sputum, etc. In fact, she was being treated as a case of COPD with inhalers. She is not a diabetic or hypertensive. So the investigation showed a rapid worsening of renal functions over the past 3 weeks, anemia, elevated ESR. Again, significant urinalysis findings showed 2+ proteinuria, numerous RBCs, 15 to 20 WBCs and CAS. Ultrasound showed a normal sized kidney with no obstruction. So with this syndrome, a rapid deterioration of renal function, active urine sediment and normal sized kidney. So the clinical syndrome that we are dealing with is RPGN or rapidly progressive glomerulonephritis. So we know that when you say RPGN, you actually mean crescentic GN, where the kidneys are throttled by presence of crescents within the glomeruli. So what is a crescent? So this is a crescent. The crescent, as the name implies, is a sort of half moon or crescent moon shaped proliferation of parietal epithelial cells of the Bowman's capsule. They are normally not supposed to proliferate. They do not have the dividing capacity, but when there is an external insult, what happens is there is a break in this and they proliferate. And when they proliferate, what happens is the glomerular capillary tufts get sort of strangled. So if this is happening in several glomeruli at once, the GFR rapidly gets worsened and the patient goes into renal failure. And this can be considered as a sort of medical emergency, because if you do not pick this up and treat it properly with immunosuppressants, usually this crescent evolves over stages. It becomes chronic, fibrocellular, and then becomes a fibrous crescent. Once it reaches a fibrous transformation stage, the glomerulus is lost, you cannot regain it back. So that is why you call it a sort of medical emergency. How do you investigate this RPGN? You can either start with a renal biopsy or with serological investigations. Now, if you were to start with renal biopsy, you would utilize the immunofluorescence appearance to categorize this. You can have either a linear positivity, which you know is typical of the anti-GBM disease, or sometimes there will not be any immune deposits, which should make you think of vasculitis, ANCA-associated vasculitis. And if you have immune complex deposits within the renal biopsy, you should still resort to serological findings or serological investigations to further subclassify into different types. So keep in mind, C3 will be normal in all of these RPGN cases except the first. Only this group will have the low C3, rest all of it will have normal C3. So if you want to bypass the renal biopsy, you actually do these investigations initially. You send for a C3, C4, you do an ANA, you do an ANCA, anti-GBM. In our case, we did all these investigations and it showed CANCA positivity. So that was a positive finding. Anti-GBM was negative, complements were normal, ANA was negative. And interestingly, the chest X-ray also showed nodular and cavitating lesions in both lungs. So by now the diagnosis should be clear. It is a case of granulomatosis with polyangiitis or GPA, the previously known as Wegener's granulomatosis. So again, to confirm the diagnosis, to prognosticate and to know the extent of damage, you have to do a renal biopsy. So in our patient also, the renal biopsy showed the crescent, which is throttling the glomerulus, but there was a significant amount of chronicity also. The immunofluorescence, as expected, is negative, not much immune staining. And the diagnosis in this case would then be a crescentic GN, post-immune crescentic GN, and in the background of CNCA positivity, it is suggestive of granulomatosis polyangiitis. So this patient was given steroids and cyclophosphamide, but since there was some amount of chronicity already there, she did not recover renal function fully. She went into a partial remission, but then had relapses again, ultimately succumbed to infection. So if we had been dealing with an anti-GBM disease, this is what the immunofluorescence would have like, the linear ribbon-like pattern of immunofluorescence in case of good pastures. The fourth case, 65-year-old nun sister, no comorbidities in the past, no significant medical history except for new onset edema, generalized edema associated with proteinuria for the past 3 weeks. So that is why she has sought medical attention. Investigations show normal RFT, significant urinalysis findings in the form of 3+ proteinuria, some RBC, some WBC. Notably, the serum albumin is very low, 1.8, cholesterol 354. I haven't written the 24-hour urine protein, which is more than 10 gram, but that's not, I mean, that is a moot point in the face of a low serum albumin and elevated cholesterol. So the diagnosis should be obvious, the syndromic diagnosis. It is an adult nephrotic syndrome. But that diagnosis itself is not enough. It is just like saying pneumonia. Is it bacterial, fungal, viral? So what is the etiology of nephrotic syndrome? So you have to have a priority list of differential diagnosis of what is causing the nephrotic syndrome. Obviously, this depends on the age at which the patient is presenting with nephrotic syndrome. If you are seeing in the infant, you will think about congenital nephrotic syndrome or other genetic causes, and sometimes congenital infections rarely, the torch infections. But in the pediatric ward, it is minimal change disease, and minimal change disease, 90% of the cases. Rarely you might get an FSGS, a diffuse mesangial sclerosis, some secondary to hepatitis B, etc. And in the usual adult population, 20 to 50, the nephrotic syndrome is usually due to primary diseases like FSGS, C3 glomerulopathy. Minimal change disease can still be there, although it comes lower down in the differential diagnosis, and also significant proportion could be due to underlying other diseases like SLE, infections, etc. And in the elderly, still elderly, that is more than 50, you keep membranous nephropathy, amyloidosis as the first differential diagnosis. Rest would be diabetes. If the patient is diabetic, that is also needs to be considered. FSGS, fibrillary immunotactoid are all rare diseases, but in the appropriate clinical context, you have to keep these also as the possible culprits. So in this patient, you would keep membranous nephropathy, amyloidosis, etc. as the differential diagnosis. Most of this can be proven or disproven only with a renal biopsy. So this renal biopsy in this nun sister, you can see the capillary loops. They are open, but they are very thickened. The walls are very much uniformly thickened, cord-like, refractile. So this is due to the subepithelial deposition of immune deposits, and the GBM has went into remodeling and reduplication along these immune deposits, leading to the thickened appearance. So this is suggestive of and this immunofluorescence also, this is not from this patient, this is from the net. This is what this should have shown, granular deposits of IgG and C3. And in this patient, we have sent the PLA2R antibody also, which has come as positive. So the final diagnosis in this case would be membranous nephropathy, the thickened cord-like appearance of the glomerular capillary loops. And that combined with the PLA2R positivity means that it is possibly an idiopathic or primary membranous nephropathy, because membranous nephropathy can be due to secondary conditions also. So this is also worth remembering. Autoimmune diseases, malignancies, infections and drugs, they can also cause membranous nephropathy. So keep these differentials in mind and work up for malignancies, especially malignancies because the patient is elderly. Because in these cases you do not need immunosuppression, whereas in primary membranous nephropathy you will have to probably go give the patient immunosuppression. So the secondary causes have to be kept in mind. What's new in membranous nephropathy? PLA2R is considered as a diagnostic marker for idiopathic or primary membranous nephropathy, so much so that if you have PLA2R positivity, you don't need actually a biopsy to say that it is primary membranous nephropathy. So if the patient is having a normal creatinine, you don't actually need to do a biopsy as per the guidelines now. But remember that it is positive only in 80 to 85%, so still 10 to 15% of idiopathic cases you may not have this, and this lacuna is being filled up by a lot of other antigens. So there are thrombospondin variants, exostocin, NEL1, semaphorine, protocadherin. The list is increasing day by day. So most likely in the near future, you will, just like you do for an ANA profile, you will have a list of antigens to work up or send for in a case of membranous nephropathy. So some of these are associated with secondary diseases like SLE and malignancy, and some primary. So that is a new development happening in membranous nephropathy. The second last case, this is a 62-year-old female, again long-standing diabetes and hypertension. Her creatinine was sort of normal, 1.4 6 months back. She was on OHS, telmisartan, amlodipine and hydralazine, but she has now come for a nephrology consult for edema legs with 2 weeks and oliguria. And the history is uneventful otherwise. The urine showed again significant findings in the form of 2+ RBCs, significant microhematuria, leukocyturia and granular cast. And the creatinine has jumped from 1.8 to 2.4 to 4.8 over this period of time. Again, clinical syndrome would be RPGN. So rather than going for a biopsy straight away, we send the serological investigations for this. The complements are normal. The ANA-IF turned out to be weakly positive, but that can be false positive in the elderly population. The P-ANGA, C-ANGA was negative, anti-GBM was negative, but because the ANA was weakly positive, we decided to do an ANA profile also. Surprisingly, that came as strongly positive for dsDNA. Antihistone were also positive. Smith was negative. So what to do? Again, renal biopsy. So this is the biopsy slide from that patient. You can see the glomerulus is enlarged, more larger than normal, lot of pink stuff, mesangial expansion, lot of dots, blue dots, that is endocapillary hypercellularity is there. So this is again an endocapillary proliferative glomerulonephritis. And this is from the textbook. Some of these glomeruli did show this appearance. So this is called the characteristic wire loop configuration, the thick and refractile appearance of the glomerular capillary loops. This is due to the subendothelial thrombi present in the capillaries. So this is very strongly suggestive of lupus nephritis. And the immunofluorescence showed a full house pattern. What do you call a full house pattern? You have positivity for all the immune reactants, including and necessarily the C1q. So C1q should be positive to call it full house pattern. And if you have a full house pattern on renal biopsy, it usually means lupus nephritis. Very rarely MPGN can produce this, but by and large it is lupus nephritis. So the final diagnosis would be lupus nephritis class 4. But it's still not clear, is this a case of late onset SLE, or could it be a drug-induced SLE due to hydralazine? She was started on hydralazine around 1 month back. Antihistones were positive. But typically the drug-induced SLE will not have so prominent renal manifestations. And she did need immunosuppression for recovery of renal function. So it is more likely that this is late onset SLE rather than drug-induced SLE. Coming to the final case, this is a young boy, 17-year-old male, with no comorbidities, no other illnesses, presented with 3 weeks history of fever. He was initially admitted in medicine department and later transferred to nephrology because he had a prominent AKI. No localizing symptoms or sign with respect to any clues for fever, just a prominent AKI. He was extensively investigated for fever in the medicine department. All the blood cultures, echo, everything was negative. ESR was high, CRP was high, procalcitonin was negative. Only thing is his creatinine kept on climbing, 1.7, 2.4, 3.6, 6.7, 8.4, it went up to that. But remarkably, despite this alarming creatinine, he was practically stable throughout this illness, except for the time when he had the fever. He was non-oliguric, no volume overload, no hyperkalemia, no acidosis, absolutely normal. So that again makes you think that it is less likely to be a glomerular pathology, more likely a tubulointerstitial thing. And in the background of an infection, possible fever, you think about the possibility of acute interstitial nephritis in this case. The urinalysis showed trace protein, 5 WBCs, no RBCs, granular cast. Leukocytes in urine, you think about the possibility of infection first, but in this case cultures were negative, ultrasound did not show any pyelonephritis. So in that scenario, you think of the possibility of acute interstitial nephritis. The other serological markers were all negative. This is what you see when you get a WBC cast. So this WBC is deposited on the cast matrix. This is from the net, showing beautifully the same thing, the WBCs which have deposited on the cast. So when you get WBC cast in urine, you think about the possibility of acute interstitial nephritis and pyelonephritis. But in the appropriate clinical scenario, if infection is ruled out, you think about the possibility of AIN. And if you have WBC cast, RBC, WBC all together, it is more likely to be proliferative glomerulonephritis. So again, we proceeded, we need a renal biopsy. And this is what the biopsy of that young boy showed. There is lot of blue in this region featuring interstitial edema, lot of blue dots, meaning interstitium is infiltrated with inflammatory cells. These are all lymphocytes, and this confirms our diagnosis that it is acute interstitial nephritis. So that is a final diagnosis, and he responded beautifully to steroids. As if we had thrown a switch, within 48 hours, the fever completely subsided. Over the next 2 weeks, creatinine completely normalized. So what are the take-home points that I want you to take away from this session? Few points. One, a diligent history taking goes a long way in finding out the cause of the renal problem in many cases, especially because physical examination may not yield much clues. It's not as exciting as in a respiratory, CVS or CNS case, but still sometimes you get the clue as well as confirmed diagnosis from the history taking itself. Remember the Bilimbi juice consumption. Urinalysis, simple, cheap, inexpensive and easily available, but still it again helps you in lot of ways if properly done. It helps to narrow down the differential diagnosis and helps you to formulate a sort of algorithm as to how to investigate further. And in many cases, not all cases of course, many cases biopsy also becomes invaluable in finding out the diagnosis as well as helps in prognostication and also monitoring response to treatment. So thank you.
Thank you, Dr. Raghunath, for very nice presentations. I think he has gone through different clinical scenarios in nephrology and how to evaluate and how to come to a proper diagnosis. I think we can have a lot of discussion on this topic, and I will invite from the chair the discussion.
Thank you, sir. Yes, sir. Yes, sir. I don't know, sir. The NA profile came as positive for antihistones, and anti-DSNA 2+ was positive, but Smith was negative.
Smith was negative. But Smith occurs only in 30%, no?
Sir?
Smith occurs only in 30%.
30%. Yes. Usually the drug-induced SLE, they are said to have a normal complement, even if it is a lupus nephritis, as has happened in this case. But usually drug-induced SLE is said to spare kidneys. So, but this patient had real renal manifestation. Sir? Spared. No CNF manifestations.
The case with the GPA, I think now we have got better investigations like MR, anti-MR, anti-PR3 and anti-MPO, which is much more specific than this thing. And that patient did not have any lung involvement?
Yes, sir. He had lung involvement. She had lung involvement. She had some X-rays showing nodules and cavitations.
You should have said that. Then it makes it complete. And now there are machines for urine analysis. Do you think they are good?
Yes, in fact, our hospital started using auto-analysis.
So, what do you say about that?
It does give you a lot of information, but in fact there was some debate in our hospital also regarding the utility of this. So when I read upon that, the judgment, the final conclusion is still out. I mean, it can be compared to manual analysis. It saves time, it is quicker, it avoids a lot of manual errors. But regarding finding out cast and crystals, manual analysis is said to be slightly better than the automated analyzers.
Sometimes we get a reading like RBC 8221.
Yes, sir. So exactly.
Like in Indian we have a lot of Ayurvedic preparations also because we are getting renal failure patients.
Yes, sir. But it's difficult to conclusively prove the etiology in such cases. That is a problem. But very many of them are putatively associated with renal as well as hepatic manifestations. Some may have adulterations with heavy metals, and those things are well known to produce chronic as well as acute renal damage. The problem is proving that it is due to that. Except for the temporal association, we may not have much.
The last case which you have discussed with interstitial nephritis, referred from medicine, any particular treatment from nephrology?
Yes, he was treated with antibiotics. If you are referring to that, he was treated with ciprofloxacin, piperacillin, tazobactam, and amoxicillin clavulanic acid prior to that. So the question is he it infection induced? Could it be just a viral infection which has gone on like this, or is it an antibiotic or drug induced interstitial nephritis? The fact that the renal dysfunction started, actually I forgot to mention a twist in the case. He responded beautifully to the course of steroids. We tapered and stopped the steroids over a period of 6 to 8 weeks. Immediately, within 2 weeks after stopping the steroids, he again presented with the same fever, again the same AKI. And this time we restarted steroids, again the same excellent, beautiful response. But this time we are continuing him on low dose steroids plus additional immunosuppression with mycophenolate. We are planning to continue this for around 6 months. So that makes you, think more likely that it is idiopathic acute interstitial nephritis rather than a drug induced or infectious agent being responsible for that. Revert back, but if you are giving steroids, it is said to have an excellent response. So the thing regarding steroids is that if you are going with steroids, hit early, hit big. That is what they say. If treatment is often delayed, sometimes incomplete recovery can occur. It can respond to steroids, sir. Especially NSAIDs can have. Yeah. Yes. Yes, exactly. It is only because we had a similar episode the second time after stopping steroids. That is why we are thinking it is probably. No other causes. Classical teaching is that, of course, you have to have eosinophiluria, you have to look for eosinophils in urine, but actual real-time studies have shown that it is not that useful. In fact, plenty of cases which ultimately turned out to be biopsy-proven ATN had eosinophils, and plenty of biopsy-proven AINs did not have eosinophils in urine. So, classically, for asking students, it is a good investigation question, but in real-time world, it may not be that useful. Yeah, eosinophiluria.
I think we had a very good discussion. Thank you for the very nice presentation and poll discussion, all the good discussion by the seniors.
Thank you.
Thank you.
Thank you, sir. I kindly invite Dr. Harish Kumar sir and Dr. Vijay Kumar sir to hand over a token to Dr. Raghunath sir for his wonderful talk. I am sure we were all regaled with his tales from nephrology. I take great pleasure in inviting Dr. Alexander, Chief Physician from Holy Cross Hospital, on stage to thank our chair members and to hand over a small token of our appreciation and gratitude. I would like to invite Dr. Ramesh Nair sir, our President of the API Kerala chapter, to address the delegates.
During our general body meeting, we unfortunately forgot to mention about the untimely death of Professor Joy Philip. On behalf of the API Kerala chapter, we should pass a condolence message for Professor Joy Philip. I think all of you agree to that. Thank you.
Let us observe a minute of silence. With this, we move on to the next set of exciting free paper sessions, which will be evaluated by Dr. Tommy Phillip, Principal and Professor of Medicine, Pushpagiri Medical College, Thiruvalla, and Dr. Abraham Etichin, Professor and HOD of Medicine, MOSC Medical College, Kolanchery. To begin our paper session, I invite Dr. Alna Merin George, who will present recurrent hyponatremia, a leading sign of hyperpituitarism from Pushpagiri Medical College, THIRUVALLA.
Good morning, everyone, respected faculties and my dear teachers. I am presenting the case from Pushpagiri Medical College, and my sincere thanks to my guides, C. Abdul Qadir, HOD General Medicine, PIMS, THIRUVALLA, Dr. Raji Philip, HOD Endocrinology, PIMS, THIRUVALLA, Dr. Sarojini Amma. So my case is recurrent hyponatremia, a leading sign of hyperpituitarism. Coming to the case, Mr. K, 70-year-old male who is a retired teacher from Elantara, presenting with the complaints of recurrent episode of vomiting, generalized tiredness since 5 days. Coming to the history of presenting illness, patient presented with complaints of insidious onset of vomiting of 5 days duration, which was non-projectile and vomitus was not blood stain, not bile stain, and vomitus contained food particle. It was associated with generalized tiredness and no history of loose stools, weight loss, fever, abdominal pain, hematemesis, and no recent history of taking food or travel to outside. So coming to the past history of the patient, he is a non-case of CAD for 18 years back, and he was on ecospirin and atorvastatin and CVA 22 years back, and he is also the non-case of dyslipidemia, and BPS started in 2005 and he was on tamsulosin. Patient had similar complaints in the past and treated as gastritis, multiple hospital admission due to hyponatremia since 2017, and he was on tolvaptan. No other surgical history. So coming to his family history, no relevant family history. Personal history, he is normal sleep, appetite reduced, bladder and bowel habits, bladder is normal and bowel is he was constipated. So from this history, the professional diagnosis we come across is acute gastroenteritis. So from this, we move on to the general physical examination. Patient was conscious and oriented, pallor was present, no uterus clubbing, cyanosis, lymphadenopathy or edema, dry skin was present, there was absence of axillary hair, chest hair was absent, and pubic hair was also absent. Coming to his pulse rate, vitals, pulse was 72 per minute, regular in rhythm and normal in volume. BP was 110/70, in right arm supine position, no postural fall. Respiratory rate is 118 per minute, others were normal. So coming to the systemic examination was non-contributory, and also the CNS examination was also within normal limits. So coming to the investigation of this patient, HB came to be 10.5, total count was 5,500 with polymorphs of 64, lymphocyte 30 and monocyte was 3, ESR was 40, platelets was 1.5 lakh, LFT was normal. Then come to serum electrolytes, we found that sodium of 118 millimoles per deciliter, potassium was 4, and RFT was normal, URE was normal. Then come to the course in the hospital. Patient was admitted with provisional diagnosis of acute gastritis hyponatremia. Later the hyponatremia workup was initiated, and urine spot sodium found to be 76 milliequivalents per liter, and serum osmolarity was 271 milliosmol per liter. Urine osmolarity was 455 milliosmol per liter, and serum cortisol was 19 nanogram per liter, and TSH was found to be normal, 2.5 micro international per milliliter. So, however, the clinical examination finding revealed there was a loss of axillary, pubic and chest hair, and there was a testicular size of 8 ml, which came to be low, and further hormonal workup was done. So here we suspicious of a hypothalamic pituitary axis insufficiency. So we went ahead with the other investigation, FSH, which came to be 0.6, and LH 0.3, which was low, and free T4 was 7, which again is low, and T3 was 0.51, and testosterone also less than 0.05, which came to be very low, and prolactin was normal, which is 13. So from this, we found that there is evidence that the involvement of hypothalamic pituitary axis involving the two axes. One is patient having central hypothyroidism, other one patient having gonadotropin axis insufficiency. So we went ahead with the MRI after discussing with the endocrinology department. So in MRI brain pituitary protocol was taken, which showed a well-lobulated region involving the cellular and supracellular region with signal characteristics possibility of a pituitary macroadenoma. So we found it was a pituitary macroadenoma. So after finding the pituitary macroadenoma, perimetry was done, which came to be normal. We started the patient on steroid, later on levothyroxine, and we plan to follow up adenoma growth with increase in size or decrease in visual field to decide about the surgery. So this is a case report regarding the pituitary macroadenoma presenting as severe hyponatremia, a case report. So our final diagnosis, patient having pituitary macroadenoma causing hyperpituitarism. So what is the take-home message from this case? High index of suspicion is needed for the diagnosis of hyperpituitarism. Hyponatremia may give you the clinical clue. Include free T4 and TSH as the initial investigation for screening hypothyroidism. Pituitary hormone deficiency leading to hyponatremia as a result of non-functioning pituitary macroadenoma is quite rare presentation. Under resolution of clinical symptoms of hyponatremia, even after correction of hyponatremia to a reasonable level or labeling as SADH, it has to be thoroughly investigated and complete hypothalamo-pituitary adrenal gonadal hormone profile have to be evaluated with imaging of pituitary. Thank you.
This is a patient of hyperpituitarism. Now let's say you have another patient with Addison's disease and hyponatremia. How will you clinically differentiate between the two?
So in this case, if the patient having Addison disease, there will be like ADH.
Clinical. I am not asking you
Patient having
investigation.
hyperpigmentation will be there for the patient having.
Very good.
Any questions from the floor? Why the TSH is normal? What's the explanation for the normal TSH in this sort of patient?
So in central hypothyroidism, the TSH will be normal. The FT4 will be normal, usually very less, because the TRH secretion from the hypothalamus, the releasing hormone, which will inhibit the free T4 production.
Not exactly. Physiologically, the abnormal, the TSH coming from the abnormal pituitary stays in the blood for a longer period of time. So you may overestimate it. So it can be normal in that. So if you just do TSH alone, you may miss it. That's why you have suggested you have to do the T4 along with TSH. Was this patient evaluated for hyponatremia in the past with cortisol and thyroidase?
No, sir.
Just not evaluated. Any questions from the floor?
Okay, thanks.
We will wind up. Good presentation. Thank you.
Thank you, Dr. Balna.
We will now move to the next case, a case of invasive candidiasis by Dr. Anila Elsa. Okay. I will this order. Is it the next one? No.
You can tell the next case.
The next paper is titled A Rare Case of Splenic Thrombosis, presented by Dr. C.P. Biju Thomas, a PG resident at Believers Church Medical College, THIRUVALLA.
Good afternoon. I am C.P. Biju Thomas, first year PG resident at Believers Medical College, THIRUVALLA. I will be presenting a case of splenic vein thrombosis that came to our hospital. So basically my patient is a 51-year-old male, a resident of Chennai, Madurai, who's an SI by profession. He had fever since 1 month, which was high grade and intermittent. He had cough since 15 days, which was non-productive, and there was associated reduced appetite. And since 4 days, he had generalized myalgia, for which he came to the hospital, to a local hospital. He was a non-case of diabetes, but was not on any regular medication. And in the hospital, it was found that his vitals were normal, and on examination, he had bilateral Krebs and hepatosplenomegaly. And blood investigations revealed hyponatremia and borderline hyperkalemia The creatinine was high, HbA1c was 9.7 and CRP was 78.5, and he had deranged LFT as well. And chest X-ray showed bilateral lower zone haziness, and USG abdomen revealed hepatosplenomegaly with multiple splenic cysts, bilateral renal calculi, bulky kidneys, and mildly enlarged prostate. Dengue IgM was positive, and malarial parasite and lepto IgM was negative. And the CT was CT basically confirmed the ultrasound findings, showed few small nodular opacities in the visualized lung region, and hepatomegaly and splenomegaly with multiple round to oval shaped hypodense lesions were seen, and there were bulky kidneys with perinephric fat stranding, few tiny bilateral renal calyceal cysts, and homogeneous nodular lesion adjacent to the upper pole of spleen with surrounding fat stranding was also seen. So he was treated initially with cefoperazone, sulbactam, levofloxacin, acidose, actrapid based on GRBS, and 100 ml 3% saline was given to correct the hyponatremia. And on the third day of admission at that hospital, he was referred to our hospital. And in my hospital, on initial examination, his vitals were again normal, and the systemic examination was also normal. There were no creps in the respiratory system as it was in the beginning, but here also there was palpable hepatosplenomegaly, and at the ED COVID test was done, which was negative. So the blood investigations in VCMCH revealed almost the same as the ones in the beginning. There was deranged LFT and RFT, and there was a raised CRP which was higher than the previous value, and PTINR value was also deranged. Manto's test was negative, and we sent for blood cultures, and iron studies showed a picture of iron deficiency, so he was supplemented with iron, and brucellosis agglutination test was sent and negative, and the hyponatremia was also evaluated. AC levels were evaluated, and that was normal too. So he was empirically started on Piptas and doxycycline. In spite of the antibiotic therapy, he had fever spikes almost up to 103, 104, and he has sinus tachycardia with all T waves. And an echo was done which showed no clots or vegetation, but there was an ejection fraction of only 45%, and proBNP was elevated to 11,317. And so he was started on carvedilol, and lepto IgM was equivocal. All other tests for a tropical fever was negative. Viral markers were also negative. And the ultrasound was repeated here, again showed a spleen to be enlarged to 18 centimeters with multiple hypoechoic lesions, largest measuring about 1.5 centimeters, and HRCT chest was done which showed multiple randomly scattered pulmonary nodules, largest being 1.2 centimeters, a band of atelectatic change over the left lower lobe, thin left pleural effusion, and the spleen on CCT abdomen, spleen appeared enlarged with a size of 13.4 centimeters and multiple hypodense splenic lesions, and the largest was 2 centimeters. And there were ill-defined hypodense lesions measuring 3 into 3 centimeters along the anterior margin of spleen, and small similar lesions along the posterior margin of spleen. CCT, as I explained before, it also showed abscess formation and intrahepatic portal vein and splenic vein thrombosis. And the kidneys, as was defined before, was bulky, and multiple nodular opacities were seen over the lower lung parenchyma. This was the CT picture. So the case was discussed with an interventional radiologist and was planned for cytological evaluation from splenic and lung lesions. And during this time, his blood cultures actually grew Burkholderia pseudomalae, and he was diagnosed to have melioidosis, and IV antibiotic was changed to injection meropenem 2 gram IV stat and followed by 1 gram Q8H, and he clinically improved immediately, and his repeat blood investigation showed an improvement in the total count, platelet count, and sodium levels. So this is the growth that was found in the Ashdown selective agar. So in this case, there was melioidosis as well as splenic vein thrombosis, and literature review showed that there have been a few cases that were reported earlier as well. One was again a case, a patient a Thai farmer presented with fever and right upper abdominal pain for 1 month, and with deranged LFT and leukocytosis. And the CT study as well as blood culture revealed that he has biliardosis and splenic vein thrombosis. And a similar one was published in International Journal of Medical Microbiology and Tropical Diseases, where a 40-year-old gentleman with hypertension and recently diagnosed type 2 diabetes came with similar history, and blood culture revealed Burkholderia pseudomalae, and CT abdomen showed numerous variable sized abscesses in the liver and spleen. Yeah, thank you.
Why did you choose meropenem once you confirmed the diagnosis? What's the drug of choice for?
Higher order penicillins and third generation cephalosporins can be given. Actually, this patient had a penicillin allergy, so that's why this was chosen.
What was the occupation of this patient?
Sub-inspector, police.
So he didn't have the classical risk factors for melioidosis?
No. Just that he's from Madurai.
Any follow-up on how long you gave the antibiotic, and what's the follow-up and response to the treatment?
He's actually symptomatically better now. He hasn't had any fever spikes after the second day of initiation of meropenem. Actually, I'm not sure about the follow-up, sir.
How long you gave the antibiotic? What's the recommendation?
It was given for 7 days initially, and he was asked to review.
You need prolonged antibiotic treatment.
Yes.
Any?
No. There is a selective media where a wrinkled growth can be seen.
Sir is asking whether you sent the blood culture specifically
we just sent for a normal blood culture, but they, after the gram staining, the microbiologist actually decided to go for the special.
Did you suspect biliardosis before you sent the blood culture? That is the question.
To be frank, no.
But you can suspect, but any abscesses which are not diagnosed anywhere, one of the DD, especially hepatosplenic, and one of the DD will be melioidosis, along with fungal and other infections.
It can present with skin lesion, splenic abscess, liver abscess, even brain abscess, and upper fibrotic cavities. Sometimes it can be chronic. Yes, it can.
Thank you, sir.
Splenic thrombosis we have seen several times is a chronic disease, and we incidentally find it. So you cannot say that this is due to melioidosis. And have you worked up for a thrombophilic workup?
Initially the PTINR was deranged, but then later on it...
No. Splenic vein thrombosis is a condition where there is an increased coagulation of blood, and that's called thrombophilia. There are many conditions.
Okay, so many, battery of tests are there.
So this may be an incidental finding. I think you'll have to follow up the case. I think, I do not know whether it has happened due to melioidosis. And as somebody said, the treatment is prolonged. Had we have treated for 6 months with ceftriaxone and other drugs.
Sir.
Okay, thanks.
Thank you, Dr. Sippy. Moving on next presentation, I invite Dr. Sumit from Government Medical College, Thrissur. He will be speaking to us on Silk Road disease, 2 presentations.
Good evening to one and all present here. I'm Dr. Sumit Riyang, junior resident from Government Medical College, Thrissur. I'm going to talk on 2 presentations of Silk Road disease. Presentation 1, leg swelling. For a 45-year-old male, daily wage worker from Chalakudi, Thrissur, presented with left leg swelling for past 3 months. He was apparently all right 3 months back when he noticed swelling of left leg, which was gradually progressive and associated with mild pain on walking. There is no history of fever, there is no history of other system involvement. And coming to past history, he has history of blurring of vision of left eye and right eye pain with photophobia 3 years back. Then he was seen by ophthalmologist and then found to have posterior and intermediate uveitis in both eye. Then patient was diagnosed as presumed ocular sarcoidosis and started on oral steroids, and patient clinically improved. There is no history of other systemic diseases, and there is no significant personal and family history. Coming to physical examination, patient was conscious oriented, no vitals were stable, and there was on general examination, there is pedal edema on left leg, and tenderness was there, pigmentation, local rise of temperature was there. There was no redness, no ulcer. Systemic examinations were within normal limit. With the available findings, we kept the differentials as left lower limb DVT, and second possibility may be cellulitis, presumed ocular sarcoidosis. And initial investigations were normal, except counts were slightly on the higher side. And USG Benner's Doppler of left lower limb was done, which showed DVT in left lower limb. And provisional diagnosis kept as left lower limb DVT, presumed ocular sarcoidosis. And as a risk of developing DVT is found to be 3 times higher in sarcoidosis than normal patients. Hence, patient was started on heparin and warfarin for DVT, and target INR was achieved, and patient was discharged. But patient came to our OPD for the second opinion, and uveitis and because of this combination DVT, we have reconsidered the other possibilities. Can be sarcoidosis malignancy. And we have revisited the history, and he gave history of tongue ulcers on and off multiple episodes for past 2 years. And on further inquiry, he also gives history of scrotal ulcers 1 year and 6 months back, which healed. And hence we have reviewed all the investigations, and there is no diagnostic pointer towards sarcoidosis. And the investigation was sent, and which supported our diagnosis, and HLA-B51 was positive. And according to international study group for Behçet disease, which it fulfilled our satisfied the criteria. And hence our final diagnosis kept as Behçet disease, also known as Silk Road disease, with ocular oral genital involvement, left lower limb DVT. The patient was started on azathioprine, and patient was kept under follow-up, and patient is currently doing good and doing better. And this is case reports where Behçet disease is associated with deep vein thrombosis. And presentation 2, a 46-year-old male farmer hailing from Palakkad, Thrissur, he presented with dysuria and fever for past 1 week. And dysuria was associated with lower abdomen pain, mild dull-aching type, and fever was high grade, associated with chills and rigors. There was no cough, no chest pain, no loose stools, no vomiting. He is also known case of diabetes for past 10 years, CKD, diabetic kidney disease, and stage renal disease for past 3 years, and he is on dialysis since 2 months. And dialysis was done 4 days back before admission. And he is also known case of CAD, moderate LV dysfunction, severe MR, severe PH since 1 year. On general examination, he was conscious oriented, he was febrile, vitals were stable, and there was bilateral non-tender repeating edema, conjunctival redness was there, and on examination he had hypopine. Systemic examination were normal except CVS, where apex beat was hyperdynamic at 6 intercostal space and mid-clavicular line, and pansystolic murmur present in mitral area was suggestive of mitral regurgitation. And provisional diagnosis kept as complicated UTI with volume overload with his previous comorbidities. And also hypopine right eye for evaluation. And initial investigations is suggestive of UTI. And the patient was started on antibiotics and diuretics, SG hemodialysis was continued, supportive measures were given, patient clinically improved, fever and dysuria subsided. And meanwhile, ophthalmology was consulted, and patient was found to have hypopine uveitis. And based on the possible causes of hypopine uveitis, non-infectious and infectious cause, we have again revisited the history again here. And patient gives history of recurrent oral aphthous ulcer, history of papillobascular skin lesions over the lower limb and chest. There is no history suggestive of other causes of causing hypopine uveitis. Hence, a combination of hypopyonephritis, recurrent oral ulcers, and papulopustular skin lesions. We have considered diagnosis of Behçet disease fulfilling the international study group criteria. And actually V51 was also positive. And final diagnosis kept Behçet disease. However, patient on the second week of admission, patient develops intractable cough with blood-thin sputum. At that time, his vitals was BP 200 by 110, saturation was 86 at room air, and pulse rate 104, regular rhythm. Chest was bilateral crepitations were had. And hence, initially we thought it might be pulmonary edema, and hence we managed with antihypertensive. However, immediately patient had massive hemoptysis followed by dyspnea. There was no history of chest pain, and patient shifted to ICU. But however, patient succumbed to his illness, and patient died. Here we cannot prove the cause of massive hemoptysis. But however, in this case, probably it can be hemodialysis related pulmonary hemorrhage or acute pulmonary embolism, or in the background of Behçet disease, it can be pulmonary artery aneurysm rupture. So, in massive hemoptysis, it has been associated with atypical Behçet disease. And so, take home message is Behçet disease should be suspected in young patients with DBT who has history of mucocutaneous ulcers or uveitis. DBT and hypopyonephritis could be the rare presentations of Behçet disease, and sarcoidosis can closely mimic especially the intraocular findings. Actually, B51 has been strongly associated with Behçet disease, and mainstay treatment of DBT in Behçet disease is not anticoagulation but immunosuppression. History taking is core to the clinical diagnosis in Behçet disease, paramount in management and anticipation of possible related complications of the disease. Hence, periodic follow-up with CT chest and with contrast to detect arterial aneurysm is advised. Early diagnosis and recognition of organ involvement with immediate intervention can help decrease mortality and morbidity. Thank you.
Your second case, the patient already had so many comorbidities, so how can you be so sure it's Behçet's disease? The first case, I agree, they don't have any other comorbidities. There are so many other reasons why the patient should have these problems. Second case, you told CKD, SRD is on dialysis.
Sir, can you repeat the question?
You presented two cases. Yes, the first case, the criteria was okay. The second case, the patient had so many other comorbidities.
Yes.
So some of them, they're actually confirmed us. They can itself come with these presentations, these problems. So how can you be so sure that's a case of Behçet's disease, even some of the criteria which you mentioned in the second case?
According to the international study group criteria, it fulfills the criteria because recurrent oral ulcers along with any of the four diagnoses, either skin lesions, your ocular findings, and pathology test.
Did you do all of them?
No, I have not done pathology test.
No, the skin lesions you can get in ESRD, eye findings can be there. So there are so many other reasons. The first case,
actually B51 is No, not included.
HLA-B5, I think it's not included in the diagnostic criteria. So instead of going for that one simple test like pathology test, which is actually included in the minor criteria, could have been done. Okay, any comments from? Okay, we'll wind up. Anyway, interesting cases. Thank you.
Thank you, Dr. Sumit. I invite Dr. Shahrukh Mohammed from Travancore Medical College, Kollam, to talk to us on a case of stress.
Good evening, everyone. Respected teachers. Here I present a case of a 48-year-old female housewife hailing from Kollam, presented on 31st March 2022. Presented with cough, breathlessness, skin rash and fever for past 15 days. Fever was associated with cough and breathlessness. Cough was non-productive in nature. The rash, which was maculopapular over the proximal extremities, lower back and the buttocks. Was initially treated in local hospital for 10 days in OP basis and later IP basis with oral and IV antibiotics and was referred due to worsening dyspnea. No history of chest pain, loss of consciousness or vomiting. This was the rash, the palpable blanching maculopapular rash over the proximal extremities, lower back and the buttocks. Patient is a known case of type 2 DM, one abortion in the second trimester, recently diagnosed systemic hypertension, history of fever and cough 1 month back. On examination, patient was conscious, oriented, tachypnic, mild pallor was present, lymphadenopathy over the right axillary region which was mobile and approximated about 1 into 1.5 centimeter, and the cervical area which was mobile and approximated about 1 into 1 centimeter. The pulse rate was 98 per minute, BP was 110/70, respiratory rate was 38 per minute and the saturation was 87% in room air. On auscultation, bilateral fine crepes over the posterobasal area was present, per abdomen was soft and distended and other systems were within normal limits. On the initial investigations, it showed neutrophilic leukocytosis, elevated inflammatory markers and raised LFT values. Then we took a chest X-ray which showed bilateral consolidations more in the right upper and middle aspect. Then we admitted the patient to the ICU with a provisional diagnosis of bronchopneumonia, possibly COVID or other infective causes. Patient was started on IV antibiotics, oxygen support and other supportive measures. After admission, we took a CT chest which showed multifocal peribronchiolar ground glass opacities, interstitial septal thickening and consolidations in the bilateral upper and lower lobes, more in the right lung and also present in the right middle lobe. After the CT chest, we kept in mind the following differentials. Since the patient had antibiotic therapy from outside and IV antibiotics that we initiated, patient's condition was again worsening and was going into a ventilator mode. Since we kept aside, the possibility of an infective cause, and we thought of more of a non-infective cause because the symptoms were not relieving even after the antibiotic therapy. Then primarily we thought of a cryptogenic organizing pneumonia, an autoimmune related pneumonitis, pulmonary edema and a possibility of DRESS syndrome was considered. Since the patient was worsening, we needed to act immediately. So the treatment options in front of us was to start the steroid therapy. But there was two problems in front of us. The first problem was we didn't rule out the cause of the possibility of a mycobacterial infection or a fungal infection before starting a steroid therapy because it may flare up the tuberculosis and fungal infection. The second problem was the patient was having a non-productive cough. So we couldn't get the sputum sample to study the fungal and mycobacterium. So an immediate bronchoscopy was done and a BAL was taken. BAL, AFB and BAL fungal stain was negative, and we did a COVID RT-PCR monospot test which was negative, and a sample for skin biopsy was sent, and echo showed normal study, and in the peripheral smear it showed microcytic hypochromic anemia, neutrophilic leukocytosis. Then we worked upon the differentials and the patient was started on NIV as the patient was desaturating. Steroid pulse therapy and supportive measures were started. IV medial prednisolone 250 mg IV was initiated. And then the possibility of DRESS was considered in our differentials. So we traced back for the drug history. We inquired the previous clinics she visited and took the drug history, that she took in the past 1 month. She took tab aceclofenac and tab serratiopeptidase for injury to the right big toe 3 weeks before the symptoms arise. Tab paracetamol, tab cetirizine for a fever and allergic reaction 1 week back, and tab paracetamol, tab mefenamic acid and injection ceftriaxone 4 days back before the symptoms arise. And on consequently, we followed up with the cultures, and the blood culture showed no growth. Urine culture showed also no, urine culture and sputum cultures were also showed no growth. Viral markers were negative, and BAL studies were also followed up. With the BAL CBNAT was negative, BAL fungal culture, BAL staining and BAL cytology was also negative. And at the time, initial day itself, we sent samples for autoimmune workup to rule out any autoimmune related pneumonitis, and the autoimmune studies like ANIF, PNK, CNK and beta-2 glycoprotein cardiolipin antibodies were all found to be negative. And initially, before starting the steroid therapy itself, we sent a sample for skin biopsy. The skin biopsy showed perivascular inflammatory infiltrates and marked spongiosis, which were features were suggestive of DRUS syndrome. And we referred about the Register criteria, which is a scoring system for the diagnosis of DRUS syndrome. And we applied our science and the clinical investigation reports into the Register criteria. And finally, we got a total score of 6. And if the points are greater than or equal to 6, it's definitive DRUS. We had a fever greater than 101, rash suggestive of lymphadenopathy, rash suggestive of DRUS, rash greater than 50% body surface area, skin biopsy suggestive of DRUS, organ involvement, disease duration greater than 15 days, exclusion of the other causes. Then the follow-up CT chest was taken after 7 days of that, and the drastic change was found. The take-home message is in clinical practice, a diagnosis of DRUS is frequently overlooked and easily missed due to its variable complications. Unnecessary use of NSAIDs should be avoided. I sincerely thank HOD Dr. Lega Madam and Dr. Arundhati sir for guiding me to take this case. Thank you.
Now, show you that blood count, that slide. There is no significant eosinophilia, so how did you say that it is DRUS syndrome? The second thing is that biopsy report of DRUS, is that, how sensitive is that report? Is it specific for that, or are there any differential diagnoses?
There are differential diagnoses also. Skin biopsy report shows this perivascular infiltrates.
Could it have been a case of COVID-19? What test did you do for COVID? Was it antigen or?
Initially, at the emergency department, we did the COVID Corat antigen test, and it was negative, and we admitted the patient to the ICU.
The patient has responded to high dose steroids also.
Yes, sir.
And your eosinophilia count is normal.
Yes, sir.
And you have not done RT-PCR. Now I'm just exploring how the
RT-PCR was also done. Done, sir. Later, after admission to the ICU, samples were sent for COVID RT-PCR, and the results came by that evening. It was found to be negative.
PCR was also negative.
Yes, sir.
Well, going through the case, initially it doesn't come to, because eosinophilia is lacking and all, but the main thing you mentioned is a skin biopsy, that's the main point. How common is the organ involvement like lung as a predominant manifestation in DRUS syndrome?
When this case presented, the thought of DRUS syndrome came when this maculopapular rash with an organ involvement and a lymphadenopathy, we thought of a possibility of DRUS syndrome, and lung involvement was present and altered LFT values were present, and this maculopapular rash is suggestive of DRUS syndrome and lymphadenopathy, and atypical lymphocytes and eosinophilia was not present.
Yeah, all these things need not be there. That's why you said the diagnostic criteria was
yes, sir.
satisfied.
So we applied the points in and the factors into this GISCAR criteria and got a score of 6. So possibility of DRUS.
When pneumonia comes with skin lesion, anything else you will consider as a cause of pneumonia? Which pneumonia comes with erythema multiforme and mycoplasma pneumonia?
Yes,
yeah, one of the DDs when predominantly pneumonia and skin lesion. Just saying, just to consider a few DDs for that.
Yes, sir.
Any?
Lymphadenopathy was positive.
Lymphadenopathy.
But in your score, I think you had put it as 0.
Sir, but in the GISCAR criteria, if lymphadenopathy is present, I forgot to add one, added total scores and into 6.
Okay, thanks.
Thank you, sir.
Thank you, Dr. Shahrukh. Now I invite Dr. Ashida S. from KIMS Trivandrum. Effectiveness of oral anticoagulation in venous thrombosis, a prospective observational study.
Good afternoon all, respected chairpersons, distinguished delegates and my dear friends. So I am here to present my research work titled Effectiveness of Oral Anticoagulation in Venous Thrombosis, a Prospective Observational Study, which I have done under the guidance of my sir, Professor Dr. Matthew Thomas, sir. So anticoagulation treatment, it has become quite common in clinical practice now. One main indication is venous thromboembolism. So there are different types of venous thrombosis and two major clinical entities are DVT and pulmonary embolism. So safety and effectiveness of oral anticoagulation therapy, it depends on regular INR monitoring to maintain INR within a narrow therapeutic range of 2 to 3. So time in therapeutic range or TTR is a reflection of the overall quality of anticoagulation achieved on warfarin, which measures the time when patients' INR are within the desired range. So patient with a lower TTR, that is less than 65%, are at higher risk of poor outcomes. So there are 3 different methods of estimating TTR: traditional method, cross-sectional method and Rosenthal method. So in our study, TTR was calculated using the traditional method, which measures the proportion of in-range INR values to the total number of INR values. So to make you understand regarding this TTR, I will give you an example. So in case you have total 30 INR values, of which 20 INR values are in the desired range, then that means TTR by traditional method is 20 over 30. That means 66, nearly 66%. So it means TTR of 66% means 66% of the time patient's INR is within the desired range over that particular period of time. Now the primary outcome of my study was to estimate TTR and to find out the percentage of orally anticoagulated patients with TTR more than 65%. And the secondary outcome, I had 2 objectives. First one, to find out the percentage of patients reporting with hemorrhagic and recurrent thromboembolic complications with INR outside the therapeutic range. The second one was to assess the patient's knowledge regarding this oral anticoagulation and factors associated with patient knowledge, for which I have utilized a questionnaire. Now, why this study? The key reason for carrying out this study was a lack of literature regarding TTR values in Indian patients. There were so many international literatures, but there was lacking in Indian literature. And also to provide an extra hand to the doctors involved in the treatment of patients on oral anticoagulation. This study will also emphasize the need for setting up of more oral anticoagulation clinic throughout India to improve the standard of anticoagulation treatment and the quality of living of anticoagulated patients. Now coming to the methodology, a prospective observational study was carried out at the oral anticoagulation clinic of our hospital. Sample size was 96, study duration was 1 year and 3 months. Participants were men or women more than or equal to 20 years of age who had the clinical diagnosis of venous thrombosis on oral anticoagulation, warfarin or acetron, being followed up at our anticoagulation clinic. And patients were excluded if they were an oral anticoagulation after mechanical heart valve surgery, non-valvular atrial fibrillation, and those who were on novel oral anticoagulants. Now, eligible patients, they were monitored with INR test done, which was done once in 4 to 8 weeks in our NABL accredited lab. New patients were monitored more frequently. So total of 15 random continuous INR values were recorded for each patient, and it was used to measure the TTR value. So given table shows 15 INR values which I have collected from my patient included in my study. So it shows that 3 values were out of range, so 12 values in the desired range. So TTR by traditional method for this patient is 12 over 15, that is 80%. Now, to assess the safety and relevant knowledge regarding the oral anticoagulation of these patients, a 13-item instructions questionnaire was used and graded as excellent, good, moderate, and poor. So these are part of the questionnaire which I used for my work. So one such question, I give you an example. So I asked the patient, do you know the complications associated with taking warfarin? If yes, what are they? So I will grade them according to the scores. Now, statistical analysis, qualitative variables were summarized using mean and standard deviation. Categorical variables were represented using frequency and percentage. Pearson chi-square test and Fisher's exact test was used for comparing categorical variables between the groups. Now, coming to the result, between December 2020 and March 2022, a total of 96 patients were enrolled in my study. Total of random 15 continuous INR values were collected for each patient, and thus a total of 15 into 96, that is 1440 INR values were collected. Now this shows a patient baseline characteristic which shows a major type of venous thrombosis was found to be DVT and a major underlying medical disease was found to be antiphospholipid syndrome. 4 important factors were associated with poor anticoagulation control with associated lower TTR value, that is BMI above 30, with a history of smoking, with history of diabetes mellitus and dyslipidemia. Now primary outcome, among all measured INR values, 75.2% were in the therapeutic range, while 19.4% of INR values were below 2 and 5.2% were above 3. The mean value of estimated TTR in my study was found to be 75.11, which was a very excellent outcome because it was almost comparable to the international standards as well as search literature. The percentage distribution of the sample according to TTR, of the 96 patients, 75% have the TTR more than 65 and only 25% have TTR less than 65%. Now 4 variables significantly predicted worse anticoagulation control: 1 BMI above 30, 2 type 2 diabetes mellitus, 3 dyslipidemia, and 4 a lower score on oral anticoagulation knowledge. All these factors were associated with lower TTR value of less than 65%. The secondary outcome, a total of 15 patients of the 96 patients had complications, 3 patients reported with hemorrhagic complications and 12 patients reported with recurrent thromboembolic complications. Another important observation which was noted was these complications were found to be seen in patients with TTR value of less than 65%, which might have contributed to these complications. And on follow-up, it was found that 100% of the patient had a warfarin therapy booklet and most of the patients had adequate knowledge regarding its content. So this was a study which was done in US with almost comparable TTR value of 65%. This was another study done in Poland, also same, the 65% of TTR value. Now this study was done in UK, which showed that multiple comorbidities and also history of smoking associated with a lower TTR value adding to a study. And this study was done in UAE, which shows that poor adherence of patients as well as medical staff to warfarin treatment guidelines, which led to the warfarin treatment failure. Now to conclude, the study reconfirms the fact that assessing TTR allows physicians to estimate the success of warfarin therapy in patients because it is a major determinant of warfarin's efficacy and safety, with the maximum benefit evident when TTR is more than 65%. Maximizing TTR has been shown to provide the most benefit for preventing stroke, major hemorrhage and death. Identifying the patients in whom INR control will be poor remains a challenge. Our data show patients with BMI above 30 might be at greater risk, but a strong predictive tool does not exist. So after all, at the end, prescribers must ultimately rely on the clinical acumen. And compliance of patients that require long-term therapy is a crucial problem and represents an important factor in the variability of both quality of treatment and patient management. So to conclude, in this scenario, we recommend the establishment of more oral anticoagulation clinics in hospital-based management and adequate monitoring of INR values, which help to overall improve the effectiveness of oral anticoagulation worldwide. Thank you.
That's a very good study actually. It's a novel study also, novel setup. Any questions?
It's a good study, I agreed, but how does it extrapolate to clinical utility? Can you do something to improve? Suppose you find the TTR is below 65%, you are predicting some bad outcomes in terms.
Yes,
so how can you improve this TTR?
So like in our study, the patients with lower TTR were found to have, one important thing is lower score on oral anticoagulation knowledge and poor adherence. Majority of the patients, so we have our oral anticoagulation clinic, so we have our in-charge physician, nursing staffs, everyone. So they try to maximum, they try their best to improve the adherence of these patients. But that is one factor, sir. And other factors that we could find is BMI above 30, it was associated with lower TTR, but as I said, a strong predictive tool does not exist. Definitely a lifestyle changes can bring about a change in improving the TTR value. But after all, even if multiple comorbidities, for my study, diabetes and dyslipidemia were found to have a significant association, but still, at the end, main important thing is patient adherence and compliance, sir.
Okay, so by health education,
yeah, definitely,
you can improve
yes,
that. Okay, thank you.
Thanks.
Good.
So Matthew Thomas, any comments from your side because you are the expert?
I think this is a very important study, probably done for the first time in India, and many of our patients are on anticoagulants, and monitoring of the anticoagulation is very important. So we have got a setup by which the patients are called every month to see whether their INR is checked, and there's a registry in which we enter all the patients who are on anticoagulants, and strict follow-up is there, and that is why probably we got this excellent result of a TTR above 65%, and if you can maintain this INR values between 2 and 3 in a majority of the patients, they will all do well, and there will be less complications of any thrombosis. And on the other hand, complications were less, and so our aim is, our thinking is that more and more anticoagulation clinics should be set up in the hospital to monitor the anticoagulation treatment so that they can have a very good result. Mostly warfarin.
Thank you, sir. Thank you, Dr. Ashida.
Thank you.
Now I invite Dr. Chris Alves, PG resident, Pushpagiri Medical College, to present his paper titled An Asymptomatic Lady with an Unusual Presentation.
Respected chairpersons, esteemed faculty, and everyone present here, good evening to one and all. I am Dr. Chris Alves Shaji, PG resident from Department of Medicine from Pushpagiri Medical College, and under the guidance of Dr. Abraham Varghese sir, Dr. Sunil Matthew sir, and Dr. Sajit Varghese sir, we are presenting our case of an asymptomatic lady with an unusual presentation. Here we have a 66-year-old female with a history of cervical spondylosis for the last 10 years who had worsening of symptoms in this past 1 year. Due to agonizing pain and being allergic to multiple non-steroidal anti-inflammatory agents, she consulted a homeopathic practitioner. And she was initiated on certain indigenous medications by him. After a routine blood test done after 1 week of treatment by that practitioner revealed low blood counts, following which she was referred to us for further evaluation. She did not have any history of fever, no history of swelling over body, no history of bleeding tendencies, no history of weight loss, no history of loss of appetite, no yellowish discoloration of skin or hematuria, no oral ulcerations, no history of rashes over body, no history of photosensitivity, joint pain or hair loss. She did not give any prior history of blood transfusions, any surgeries, radiation exposure, cytotoxic drugs, recent or recurrent infections. Past history, she is a diabetic for 14 years, dyslipidemia for 14 years, she has history of cervical spondylosis for the last 10 years, and she is a hypothyroid patient for the last 8 years. She did not have any history of chronic kidney or liver diseases. Family history, there is history of diabetes among parents and siblings, but there is no history of malignancies or coronary artery disease. Personal history, she consumes a mixed diet, her sleep is normal, appetite is normal, bowel and bladder habits are regular, and no addictions. Menstrual history, she attained menarche at the age of 15, she had regular cycles, her menopause was attained at the age of 52 years, and she did not have any history of abnormal uterine bleeding since then. Drug history, she is on metformin, rosuvastatin and levothyroxine 75 microgram. Coming to the examination, she was conscious and oriented and cooperative at the time of examination. Her body mass index was 19.2 kilograms per meter square. She had pallor but no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. She did not have any skeletal abnormalities. Her breast and thyroid gland was normal. Hair and nails were normal. She did not have any evidence of any bony tenderness. Her vital signs were stable with a blood pressure of 130/80 millimeters of mercury. Pulse rate was 92 beats per minute and it was regular. Respiratory rate was 14. She was afebrile at the time of examination. Coming to systemic examination, cardiovascular system S1 and S2 were heard equally. She did not have any murmurs. Gastrointestinal system, oral cavity was normal. Per abdomen was soft, non-tender. Liver and spleen was not palpable. Bowel sounds were heard. Respiratory system, there was normal vesicular breath sounds in all fields, no added sounds. Central nervous system examination was normal with a normal high mental functions and no focal neurological deficits. Coming to the investigation of this patient, we found that the patient had a hemoglobin value of 9.8, PCV of 27%, total count of 2,400, of which differential count revealed lymphocyte predominance of 88%, polymorphs of 9%, eosinophil 1 and monocyte 2% respectively. She had an absolute neutrophil count of 216 cells per millimeter cube. Platelet count was towards the lower limit of normal of 1.5 lakhs. ESR was 42 millimeters in the first hour. We had done an extensive investigation with a renal function test showing normal, electrolyte, sodium, potassium was normal, urine routine was normal, stool, occult blood was normal, liver function test was normal with a total protein of 7.2, of which albumin was 4.4 and a normal ALP of 64. An X-ray chest showed normal, ECG was normal, X-ray spine, AP and lateral view showed no metastatic lesions. Her coagulation profile was done and was found to be normal with an INR of 1.1. LDH was 470 international units per liter. Her reticulocyte count was 1.2%, and of which the absolute reticulocyte count was 0.8, and the reticulocyte production index was calculated to be 0.5, which was indicative of an hypoproliferative marrow. We had done a Coombs test was negative, TSH was normal with a 2.34, calcium uric acid was normal, viral serology markers for HBsAg, HCV and HIV was negative, RA factor and ANA was done for autoimmune or vasculitic panel was negative, iron studies, vitamin B12 levels were normal, and her USG abdomen revealed fatty liver only. She was evaluated with a peripheral blood smear which reported as mild normocytic normochromic anemia and moderate leukopenia with severe neutropenia and a suspicious atypical cell. We repeated her counts again, showed a dropping hemoglobin value of 8.8, total counts were decreasing again to 2000, and platelet counts became 1.4 lakhs with a ESR of 50. We re-evaluated her peripheral blood smear again, and this time we saw the RBCs showed anisocytosis, normocytosis, microcytes and elliptocytes were seen, but there was no evidence of increased Rouleau formation. WBC counts were reduced and neutrophils decreased in number and predominant cells were lymphocytes, and 2% of blast cells were noted. Platelets were seen adequately and singly scattered. The patient had undergone a bone marrow aspiration, and bone marrow aspiration showed increased blast cells, about 50% of composed of high, medium to large size cells with a high NC ratio. They had open chromatin, prominent nucleoli, and occasional one showing ore rods. Bone marrow biopsy showed marrow spaces showing hemorrhage and variable cellularity ranging from 20 to 70% with diffuse infiltration with atypical large cells and involving few marrow spaces with round to ovoid irregular nuclei and high cells with high NC ratio. The patient was referred out to further investigations for which she underwent karyotyping and cytogenetics. Karyotyping showed 46XX. She underwent test and showed AML ETO gene was found to be negative. Inversion 16 was found to be negative. FLT3 and ITD gene mutation was found to be negative. BCR ABL also was found to be negative. The patient underwent immunophenotyping for which the patient was found to be positive for CD13, 33 and 170, which are myeloid markers, and surprisingly the patient also was found to be positive for CD64. So we saw that the patient was positive for myeloid markers and the monocytic marker CD64 was positive in our patient, while other cell lineage markers were negative. Hence, we came to a conclusion of an acute myeloid leukemia, possibly myelomonocytic M4 type of leukemia in this patient with diabetes, dyslipidemia, hypothyroidism and cervical spondylosis. She was started on the 3+7 daunorubicin and cytarabine regime, and she is on therapy and on follow. So my take-home message from this message is AML is a very heterogeneous disease with over 160 structural chromosomal abnormalities are observed, and I would here again like to emphasize the importance of a very simple investigation such as peripheral blood smear, which can be the stepping stone and be crucial in clinching an important diagnosis if carefully evaluated. Thank you for your patient listening.
Not going into the hematology part because it's already clear. I only curious about one thing. You told the patient was asymptomatic.
Yes.
How did you convince the patient to undergo a bone marrow examination, a bone marrow biopsy?
So it was very difficult. We had showed her the reports, the lymphocyte predominant leukopenia, and yes, it was difficult to convince them. But we had She was totally asymptomatic. She had no clinical signs except for pallor.
Any unexplained pancytopenia needs evaluation. Okay, thank you. Thank you for the presentation.
Thank you, madam.
Lastly, bringing a sad end to our collection of interesting papers, drawing the curtain call is Dr. Adra Via from Pushpagiri Medical College, THIRUVALLA, to present her paper titled A Case of Hidden Carcinoma.
Respected dignitaries, I am Dr. Adra Via from Department of General Medicine, Pushpagiri Institute of Medical Sciences, and this case has been worked up under the guidance of Dr. Abraham Varghese, Dr. Sunal Matthew, Dr. Sajid Varghese, and Dr. Anna Mary Thomas. So going on to my case report, I have a patient who is Mr. V, 68-year-old male from THIRUVALLA. He initially presented with symptoms of weakness of both lower limbs and pain over bilateral lower limbs, which has been increased over past 1 week. Going on to history of presenting illness, patient had generalized tiredness in 6 months but was able to carry out his routine activities till 1 week back. He gradually found it difficult to walk, especially climbing stairs, and difficulty to get up from commode, and he needed the assistance of a person to do so. Bystanders also noticed that he was having difficulty in maneuvering accelerator and brake pedals due to pain, and he needed the support of his one hand while doing so. No history suggestive of any altered sensorium, loss of consciousness, or any cranial nerve abnormalities, but he has been giving a history of generalized tiredness, loss of appetite since 6 months, but no weight loss was appreciated. Going on to past history, he was a known case of migraine since childhood on drug therapy, known case of systemic hypertension for 2 years, and he has been recently detected for monoclonal gammopathy of uncertain significance 6 months back, which has been evaluated due to an altered LFT due to reversal of AG ratio, and he has been on follow-up under GIPMR. No history of any type 2 diabetes. Personal history, diet is mixed with decreased sleep and appetite. Bowel and bladder habits were normal with no addictions and nil significant family history. So we have a 69-year-old male who is a known case of migraine, hypertension and monoclonal gammopathy of uncertain significance, presented with complaints of difficulty to get up from sitting position, loss of appetite and bilateral lower limb pain, which has been increased over past 1 week. So we kept a provisional diagnosis of he has been having a symptom suggestive of proximal muscle weakness under evaluation. On examining patient, he was moderately built and poorly nourished. Pallor was present. His rest of the vitals were stable with no icterus cyanosis, clubbing, lymphadenopathy and pedal edema. Going on to central nervous system examination, he was a right-handed graduate, conscious, oriented in time, place and person. Attention, memory and speech was normal. Cranial nerve examination were within normal limits. Motor system examination, his bulk was normal, tone was normal. All of the upper limb powers were within normal limits. Going on to lower limb examination, his hip flexion and extension were weak symmetrically with a power of 4/5, but abduction and adduction was normal. Knee flexion, extension, ankle, dorsiflexion and plantar flexion were normal. His superficial and deep tendon reflexes were normal, and sensory system examination couldn't reveal any abnormality. There were no cerebellar signs, no meningeal signs, and skull and spine showed no tenderness or deformity. So even after examining the patient and other systems were also normal, we only got proximal muscle weakness under evaluation. Going on to lab reports, he had an anemia with HB 9.4 gram percentage with an elevated ESR of 135. Platelets were normal. Serum electrolytes, RFT, INR, chest X-ray, ECG were within normal limits. LFT revealed an elevated alkaline phosphatase. His viral markers were negative. Calcium was normal. So we went on to re-examine patient. How was he developing a proximal muscle weakness all of a sudden within 1 week? On re-examining patient, he was having normal power. So what happened earlier? Earlier patient was having painful restriction of movement and he was not obeying our commands to work through the pain. When we asked him to work through the pain, he was able to do the same flexion and extension with full power. So we went on to evaluate anemia. Anemia workup revealed peripheral blood smear with a normocytic normochromic blood picture and mild microcytic hypochromic change with evidence of RBC regeneration. Iron studies revealed blood picture suggestive of anemia of chronic disease. So we went on to re-examine the old reports. That is, he was recently diagnosed as monoclonal gammopathy of uncertain significance. So 6 months back, he was having a normal ALP of 99,
Now he is having an elevated ALP of 439. So what may be the cause? Why the sudden rise in ALP has occurred? We repeated ALP, it was again elevated. So we went on to investigate the causes of raised ALP. His PTH was normal, thyroid stimulating hormone was normal, vitamin D was on the little bit of lower side. So we took an X-ray also to look for any healing fractures or any bone mets, but it was also normal except for some osteophytes here and there. So an elderly male coming with bone pain in a old age and has been recently detected as MGUS. We went on to do a digital rectal examination which showed a hard prostate and PSA was very highly elevated. We specifically asked our biochemistry department to dilute PSA, which again came back as 958. We planned for a trust-guided biopsy and this is the biopsy slide. So you can see the red star marking the neoplastic cells arranged in a glandular formation and the yellow star showing sheet-like arrangement of the neoplastic cells. According to Gleason score, the gland-like formation is given a score of 3 and the sheet-like formation is given a score of 5. Majority had gland-like formation, so the biopsy report showed a Gleason score of 3 plus 5. And the black star is showing perineural infiltration of malignancy, suggestive of metastasis. You can also see the red arrow showing some signet ring cells. So patient was having predominantly pattern 3 plus LS area showing pattern 5. So finally his report was foci of perineural invasion with intervening stroma is fibromyomatosis with lymphocytic infiltrate and the impression was adenocarcinoma prostate, Gleason score of 3 plus 5, that is 8, belonging to WHO grade 4. We went ahead with, after consulting our senior faculties, we went ahead with a novel technology to identify metastasis and to assess prognosis in prostate cancer. It is the gallium prostate specific membrane antigen PET CT scan. The first one, the white star is showing the increased uptake in prostate and the rest of it is showing increased uptake in skeleton and lymph nodes. And the final report is adenocarcinoma prostate WHO grade 4 with extensive skeletal and lymph nodal metastasis in a patient who has been recently detected as monoclonal gammopathy of uncertain significance, hypertension and migraine. We also did a nerve conduction study which only showed an incidental finding of bilateral carpal tunnel syndrome and patient was asymptomatic for that. So going on to my take home message, detailed history taking and physical examination is the cornerstone for every diagnosis and patients and investigation should be re-examined and reassessed in situations of diagnostic dilemma. Normal X-rays need not be normal because X-ray is less sensitive. Gallium-68 PSMA PET CT is a very helpful and novel investigation in early detection of prostate cancer and prediction of response to treatment. Thank you.
Your clinical presentation initially was the patient had proximal limb muscle weakness of the lower limbs.
Yes, sir.
So how do you explain that?
Sir, he was restricting the movement due to pain, sir. We were missing out on that.
That was the reason.
Yes,
so he didn't have true weakness.
No, sir. It was a pseudo weakness. He was restricting due to pain. And when we asked him to suffer through the pain and do the same movements again, it was of normal power.
So one question you have to Matthew Thomas because you are a hematologist. Now she told that this diagnosis of MGS was done recently. So could this have been a confounder because this prostate malignancy would have been for some time and the bone marrow findings, hematology findings can sometimes overlap?
The clinical finding was how many months or years back was MGUS made?
Sir, 6 months, sir.
6 months. So it might have been present. Why did he do that?
Sir, because his son is a doctor. He has been having a generalized tiredness. So they did a full workup which showed an LFT with an reversal of AG ratio. So he went on to investigate and did the bone marrow and M protein work.
So this condition is a condition where the plasma cells in the bone marrow is less than 10. So that is clonal plasma cell. That means it should not be a reactive plasma cell, but a clonal plasma cell should be more than 10% in multiple myeloma, and if it is less than 10% with an increase in the M protein not more than 3 grams. So this is the ideal guidelines to make a diagnosis of MGUS. They do not have multiple myeloma. It is said that 1% of all the patients with MGUS will progress to multiple myeloma. It is not multiple myeloma. It is a malignancy.
How long should we follow this patient with repeated investigation?
If it is MGUS, we'll have to follow lifelong. Every year once and see whether they are increasing the M protein, the bone marrow, probably once in 2 years, and every year one person will turn into multiple myeloma.
Now, some of the differences, apart from what Professor has said, they do not have hypercalcemia, they will not get renal failure, they will not have any end-organ failure. This actually every multiple myeloma should start as MGVS and gradually move on to develop a multiple myeloma. That is
Some may not go.
everybody start with MGVS. No, 1% per year. That is well known. So start with MGVS and every year you can get 1% turning into multiple myeloma. That is the way.
And what about your patient? Did you start the patient on anti-androgen treatment?
Yes, sir. He was referred to a uro-oncologist and they are planning for orchidectomy and anti-androgen treatment.
It is said that monoclonal gammopathy is the new term for plasma cell dyscrasias. We all learned it as plasma cell dyscrasias. So the newer concept is that it is called a monoclonal gammopathy, and the most important one is definitely multiple myeloma. But monoclonal gammopathy can occur in several other conditions, including amyloidosis. Malignancy is one of the conditions where the malignant cells can produce M protein, and that is what probably we are seeing. No, correct. We'll have to reframe it as monoclonal gammopathy, probably due to malignancy.
As Professor said, the M band is not specific for multiple myeloma MGVS. You can have in other clonal disorders, particularly B lymphocytes. That's what it is.
Thank you, Dr. Adra, for the nice presentation.
Thank you, sir.
I think, is there any more?
No, sir.
No. I think we have come to the end of the free paper. So I thank and congratulate all the postgraduates who presented nicely. And I take this opportunity along with my co-chairperson, Dr. Abraham, to thank the organizing team for giving us an opportunity to chair this session. Thank you.
Thank you.
I sincerely thank Dr. Tommy Phillip and Dr. Abraham Etichin for their valuable support in leading the postgraduate students and for engaging the audience. I request both of you, sir, to kindly hand over the certificates to all the participating postgraduates. I would like to invite Dr. Ashita. Dr. Alna Marin George. Dr. CPBG Thomas. Dr. Sumit Riyang. Dr. Shahrukh Mohammed. Dr. Chris Alves Shaji. And finally, Dr. Adra VR. I invite Dr. Manju Matthew, Critical Care Consultant, Pushpagiri Medical College, to come on stage and hand over the certificate and a small memento to our Dr. Tommy Phillip and Dr. Abraham Etichin. you, ma'am. Thank you, sir. I now invite Dr. Rohit KB, Assistant Professor in the Department of Medicine at Medical College, Calicut, and the Treasurer of API Kerala to please declare the results of the poster presentation.
Good evening to all. So we had around 15 posters for evaluation. Myself and Dr. Peter George sir was evaluating, and he is not there. So I am announcing the prizes. The third prize goes to, it is shared by two, Dr. Anjali Jayagumar of PIMS THIRUVALLA. I invite Sharma sir to hand over the mementos to Dr. Anjali. So, sir, please stay back. And third prize is shared by Dr. Hridya Anna James, GMC Kottayam. Dr. Hridya is there? Second prize goes to Dr. Suganya MK, GMC Kottayam. And the first prize goes to Dr. Archana Lakshmanan from GMC Thrissur. Thank you. All the participants presented well. All cases were worked out well, but we had to select the four best. So thank you for participating in the poster presentation. Come with more and more papers next time. Thank you.
I also request Dr. Rohit KB sir to please distribute the certificates of participation and mementos for all the poster presentation. Dr. Mithun. Dr. Rahul Peter. Dr. Shibini. Dr. Adra VR. And Dr. Jemima. Dr. Sabir Habib. There were 4 extra participants. Could you please come forward for your certificates? I request Dr. Neeraj sir to kindly hand over a memento to Dr. Rohit KB. As we draw the curtains to a very successful program, we would like to express our overwhelming gratitude to each and every one of you who has participated in this program. It is only because of you, our dear audience, that we have been able to see months of fruition finally coming to last. On behalf of the API Kerala chapter and the organizing committee and the Central Travancore Physicians Club, we, Dr. Dasan Joseph and Dr. Ajish Koshi, are signing off in the hopes to see all of you again in perfect health, all hearty and gay during the next conference. Until then, take care, safe travels, and God bless you all.
Thank you all the participants for attending this and hope you enjoyed the session. You must give a feedback on how, whether you have actually learned and enjoyed the whole CME. And now I declare the CME as closed. Thank you and good night.
पंजाब सिंध गुजरात मराठा
द्राविड उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्छल जलति तरंगा तव शुभ नामे जाहे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय